Good morning, all of you. A warm welcome to day two. So today we'll be again discussing on pancreas and esophageal disorders more enthusiastically and more dedicated. So I would request Dimple to start the program for today.
Good morning, everyone. With immense pleasure, I open this conference, a convergence point for the trailblazing ideas and transformative insights. I, Dr. Dimple, welcome you all on the second day of the conference. We will start with our session on the topic Clinic in Pancreatitis Learn the Unlearn. I would like to invite our chairperson, Dr. Bhagirath Solanki, Dr. Rajendra Gurnani, Dr. Jignesh Patel, Dr. Jayesh Parwa, Dr. Manish Gandhi. I would like to invite our speaker, Dr. T.S. Chandrasekhar sir.
Clinics in pancreatitis, learn the unlearn. And the speaker will be Dr. T.S. Chandrasekhar, who is from Med India Hospital from Chennai. So I request the Dr. T.S. Chandrasekhar to start the discourse. Thank you.
So it is my sincere thanks to Dr. T.S. Chandrasekhar. I would like to just briefly introduce. He is one of the senior most gastroenterologists of our country, and he's practicing almost for 4 decades in gastroenterology. He has an important contribution in shaping how gastroenterology works in our country, and also he's a Padma Shri awardee. Thank you, sir, for joining us.
At the outset, I would like to thank Dr. Yogesh Sarvane. I've seen him, the kind of enthusiasm he has been having, the 7th Advanced Gastro Summit. The knowledge gained is to be shared. So I think with that motto, he has been organizing several meetings. I must congratulate him and his team for the great. It's a very difficult job for anybody to organize a meeting. So to Sunday to gather at 9 a.m. to listen to something very serious problem like pancreatitis. I really salute all the people who made it for this meeting. And I once again congratulating, and with the permission of the chair, I will start the proceedings. What I wanted to do is here, I was told that is a more for physician this meeting and for some surgeons, and the gastroenterology will be 20%. So how many physicians are there in this hall? So very nice, significant. So this lecture is designed for physicians. So gastroenterologists, they come to rescue if they are not. It's going to be an interactive session. So all of you can be glued to the, those who want the slide, you can just write to me in the mail ID, which are already there, medindialectures@gmail.com. So you can get the slide. And what I've designed is this talk is clinics in pancreatitis. This lecture would help you in day-to-day practice at now when you see a patient of upper abdominal pain. So I given the title as what one investigation would clinch the diagnosis. Okay, now you are all for the game now. What one, I think with our rich experience will be able to really easily can diagnose also very well. What one investigation would clinch the diagnosis? I know Venkat and the Vishwanath Mahapat will be very enthusiastic to answer first, but I just want them to answer later. This meant for the physician. Case one. So we have 4 cases. I will finish it whenever you want me to do that. I just follow the red letters only. Don't bother about for want of time. Recurrent right hypochondrial pain and epigastric pain, weight loss. Those physicians want to come forward, they can come and see the weight loss of about 3 kgs, known type 2 diabetes. He was ectric. And this is the LFT parameters, definitely elevated, and serum amyloid more than 3 times. So we are dealing with a patient of pancreatitis and jaundice. Most likely the pancreatitis and so again I want to tell you here is the whole lecture is designed for physicians, and the title of the lecture is what one investigation would clean the diagnosis. I know I see narration Sandeep, they will be very enthusiastically answering because they know that cases very well, but this is meant for physician. So this patient has got pancreatitis, and so I have designed 4 cases. Just one investigation would clean the diagnosis. This is the game. I am repeating it for the sake of latecomers. So the title of the lecture is what one investigation would clean the diagnosis. So far we have patient of acute pancreatitis. Now in this patient, one blood test cleans the diagnosis. What blood test in acute pancreatitis would clean the diagnosis? Apart from, serum amylase is to diagnose only. I want to know the etiology. Any takers? Okay. And one blood test with the characteristic imaging would really fix it. My God, this is what the diagnosis, no more diagnosis can be entertained. So where are we now? With this, you are able to answer this. So amylase is elevated, obstructive jaundice is there, and this patient has got, if you want to make the diagnosis, one blood test. Okay, if you are not able to make it, we'll go into the another imaging. This is the imaging. Definitely shows intrahepatic radicals dilated. Okay, and the next image will really fix the diagnosis. So before I go into the next image, can you tell us what is the diagnosis? Okay, this is the PET CT was done on this patient. It came with the PET CT. Now you look at the pancreas, you make the diagnosis now. So even the gastroenterologist also can make an attempt now. If we can help the physicians, what is the diagnosis? Diagnosis? Yes. So what one blood test will clean the diagnosis? So now we are coming to the imaging, diffusely bulky pancreas the patient has got, and the MRCP finding shows long segment structure in the mid CBD and lower CBD. Bulky, that the characteristic word. I think morning breakfast you would have enjoyed. Some of you, I don't know whether it was there here, and shaped pancreas is the one. So IgG4 was elevated in this patient. Why I'm bringing to the physician point of view is most of the time idiopathic or alcoholic pancreatitis we deal with, and we see so many difficult issues with the pancreatitis. But here one disease where the physician also would enjoy diagnosing and treating the patient. The patient was, they noted the diffuse enlargement of the entire pancreas and smooth margin. Just read the letters only, okay? Now this patient started on what treatment you would suggest? Steroid. You will be surprised to see that the jaundice disappears and the pancreatitis resolves. And normally the patients, what happens usually, they give up steroid when they become all right. He comes with the second attack of pancreatitis, and we restart the oral steroid. They get convinced, okay, we are also convinced that it is nothing other than the autoimmune pancreatitis. So this is the first case. So the learning point here is pancreatitis can be to large extent in this case is, treatable, and the only thing you have a high index of suspicion. I just want to ask our physician, how many of you do IgG4 in a case of pancreatitis? They can raise their hands. So that means this is a very learning experience that IgG4 need to be done in case of pancreatitis. Okay. Now, case 2, I will go into that. Severe abdominal pain. My job was easier because you were referred as a case of acute pancreatitis elsewhere. And there was no history of trauma, drug, and alcohol intake. Okay. And the lab parameters, serum amylase is 1650. So there's no doubt about the, you need to have at least one characteristic imaging suggests to have pancreatitis and serum amylase. And other parameters were not contributory. Again, our house officer really thought over this and he suggested one investigation would clean the diagnosis. What is that one investigation would clean the diagnosis? So I have chosen such cases where it will be so useful to our physician and is a reminder for our colleague junior gastroenterologist. What one investigation? So any physician want to take up apart from Mahapatra? So no, Mahapatra should come last, no? Okay. So this patient IgG4 normal. Sometimes same type of cases I used to present, so people enthusiastic IgG4 normal. Next. So this patient had, this is my lab technician came running, said, this is what I saw there. Blood sample. So the blood sample shows the white. So that means this patient has got hyperlipidemia. Can anybody tell how high levels of lipid can, how does it produce pancreatitis? And Yogesh will give the prize to them. If anybody tells that, I will very happy, particularly from the physician point of view. You have some prizes, no? So he said 1 lakh rupees. Anybody? This is what you make you to understand where are the area our deficit and you have to. Anybody wants to take up? Okay. Yeah. Okay, serum lipid profile, triglyceride, and this patient was treated at Kuwait and it started on all anti lower the drugs to lower the lipid level. Hypertriglyceridemia induce acute pancreatitis, and he underwent plasmapheresis and percutaneous pictal drainage of the collection. He had a huge collection also there. With that, he was referred to us, and at our hospital, we did a further investigation. By the time he came to us, the lipid level had come down because of the medical treatment he was given, and triglyceride had come down to 102, and imaging showed this is the pancreas. Maybe Sandeep would be interested in doing UES, but what happens sometimes is when you control the lipid level and you can manage conservatively also. So the patient had a collection started coming down. So the patient became better with this. So what a lovely diagnosis they made in Kuwait. And the thing we need to follow, we were not in a hurry. That is also very important. When to intervene in acute pancreatitis is also important. Just because we see the fluid, we don't want to drain it. At the same time, we don't want to delay it if the patient is really symptomatic. So there was no pain, no fever, asymptomatic, and rosuvastatin plus fenofibrate. And a family screening for dyslipidemia was done. It was, fortunately, it was negative. So the second case, the management is hypertriglyceridemia induced acute pancreatitis. So you manage like any other pancreatitis. Intravenous insulin infusion will help also. Plasma exchange, I said, plasmapheresis and fibrates, low-fat diet, alcohol avoidance, and weight loss, and the glycemic control will be done. So, how common the risk increases sharply when the serum lipid triglyceride increases more than 1000. So, this is one of the important parameters you need to do in acute pancreatitis. And now the question is, how does it produce pancreatitis? I think Mahapatra answered it very nicely. Excess triglycerides hydrolyzed by pancreatic lipase, release of free fatty acids. Free fatty acids are toxic, causing endothelial injury, ischemia, and acinar cell necrosis. And chylomicrons, there's the macro and is in size compared to other lipids, impede the pancreatic microcirculation. So this we need to remember all the physician. I think you see so many cases of dyslipidemia. Anyone coming with upper abdominal pain, please think of this case. And this is a classical serum. You can do a lab technician be able to identify. You have to give an orientation for this. I will not be going into the, since we started late, the discussion is similar to other pancreatitis. They have other stigmata will be in the skin or hepatosplenomegaly, retinopathy, and serum triglycerides more than 1,000. And there are co-triggers. You have to be very careful with the alcohol. Severe acute recurrent pancreatitis can happen. Systemic complication can also happen. Now, so two things we have really made it. One is IgG4. Second one is the hyperlipidemia. And third case, we are going into that now. Case 3, any comment you want to make it right now with the two cases? So I'll move on to the third case. 14-year-old child, epigastric tenderness, diagnosed acute pancreatitis because serum amylase is elevated, and the imaging also suggestive of similar episodes in the past. Thinking whenever recurrent acute pancreatitis, one of the treatment those days used to do that laparoscopic cholecystectomy. They see some small crystal here and there, or even the ERCP and sphincterotomy. Nowadays, we restrict ourselves unless we have a telltale evidence. This is nothing other than the biliary pancreatitis. So, unnecessary lap chole and ERCP can be avoided. This is. So anyhow, you were referred to us with the recurrent episodes of pain. Epigastric tenderness was there. And see the most of the parameters were normal. Then the patient had severe pain abdomen, amylase was elevated, and this is possibility of acute necrotizing pancreatitis with walled off necrosis are there. These all real life cases. With the date I'm just authenticating. And this need to be managed because say the previous case triglyceridemia, he did have collection and we managed it conservatively. But this case we could not manage it because it has become increasing size, pressure symptoms, and apart from the SIRS, it went into sepsis and necrosis. So we had to go for the metallic stenting, and this is what the lamps we did it. And the patient became better. He was all right. Sepsis improved. He was on liquid diet and soft diet and was discharged. And lamps were removed after 1 month. Patient comes back with the another attack of pancreatitis. Now the question is it really the acute recurrent pancreatitis of idiopathic, or again one investigation cleans the diagnosis? What is that investigation? 14 years old child, recurrent acute pancreatitis, and everything is there now. And yes, okay. Any physician before Mahapatra tells or Vishwanath? Any what one investigation? That is the title of our talk. One investigation would clean the diagnosis. Yes? Serum calcium normal, no? So you counter. You may be in the right direction just because I said serum calcium was normal. Sir, when was it taken? You can ask me. Serum calcium was taken during the acute attack. So normal calcium during acute attack will not rule out. That is a very important message I want to tell you, that please repeat serum calcium when the acute attack subsides. And this is what happened. This is the case. Ionized calcium within 1.23, and he had all the time. So you are right. You deserve the prize, but you did not counter, so you don't deserve a prize. Okay. So the message here is serum calcium during acute attack may be normal, but serum calcium after the, so he came when the acute attack was subsiding, then we repeated several times, and this is then what will you do now? It is easy for you to understand. So this patient, uh, I'm not going to the follow-up is advised the endocrine surgeon's opinion, because he had evidence of systemic scan, and this is what it is now. It is. So the message here is recurrent acute pancreatitis possibly due to primary hyperparathyroidism, planned parathyroid. And if the systemic scan is little doubtful, they go for the 4D ultrasound scan and CT scan, and all these things they do it, and parathyroid adenoma. We have very good endocrine surgeon. They would they explore the parathyroid adenoma. So the lesson learned here is, if the collection is not subsiding, don't wait. You drain it, number one. Calcium during acute attack can be high normal or normal, but repeat calcium that will clean the diagnosis of hyperparathyroidism. And if you do not diagnose hyperparathyroidism, sometimes in the beginning of my career, one patient, almost we are about to lose the patient, but we did not. So all these things are high index of suspicion, and they are all curable and not only treatable cases. So this is the early morning. This is the message is some of the diseases rarely in our medical will say that curable diseases, and this is one of the curable diseases, not to miss it. Do I have time for the fourth case? 2 minutes? Oh, I have time, 2 minutes. Okay, exactly. Case number 4. So we have discussed about IgG4, hyperlipidemia, hyperparathyroidism. Now you'll be wondering what else could be what one investigation would clean the diagnosis. Let's see. Anybody want to guess before the case? Huh? Before the child is born, you want to know what is male or female. Nobody wants to guess. Okay. Case number 4 is a known patient of ulcerative colitis, pancolitis, acute abdominal pain, again suggests to a pancreatitis, and CRP was on the higher side. And diagnosis. So one historical evaluation would clean the diagnosis. What is that historical diagnosis? Let me see that. He did have fatty liver, otherwise normal ultrasound abdomen, and treated with ciprofloxacin, metronidazole again. If we have a good, smart physician in your team and good house officer in your team, and a person who takes a very good history. So I made a point that before I see the patient, one person is dedicated for historical evaluation only. So those are the patients assigned to that any institution. So you must train them that they will write down all the drugs they have been taking it. Serum amylase elevated, lipase elevated, review of medications. Very important is you have to read it. The moment I said ulcerative colitis, our gastroenterologist start thinking very, and pancreatitis, imaging pictures, and mesalamine he had, steroids no, and he was taking the drug, azathioprine. So it started very recently because steroid was tapered and started, the immunomodulators was started, and that history, he came and told me that, sir, I have taken the history. He is just recently started as a, and all these stories started after the medications only. So there is definite corroborative evidence is there. Drug-induced pancreatitis, the historical only diagnosis possible. So acute edematous pancreatitis, we manage like any other the pancreatitis, symptomatically improved, amylase normalized, continued on. Everyone need to know about the bundle of classification. They will tell you class 1A, B, 2, 3, and 4. So this is the what very important. You can take a photo click of what is the class 1A, B, and 2, 3, 4. And the evidence-based classification for drug-induced pancreatitis, acute pancreatitis is there. And this is a very important. What are the drugs can produce pancreatitis? Azosis mercaptopin, two immunomodulators produces, very important. You have to take that, and the all other valproic acid I've seen with the pancreatitis, and very important phenofibrate also can produce adipavir also, amiodarone. So these are the various drugs can produce pancreas. So ladies and gentlemen, what is the lesson we have learned is hyperlipidemia, hyperparathyroidism, IgG4 and drug use. What do you need for that? You have to invest on patient, not the only the invest on time. So anyone with the inquisitive mind, thinking brain, exploring eyes, lending ears, searching hands, and you should be persistent, gutsy heart with a scientific approach. You can make wonderful diagnosis even in the era of highest advanced technology and imaging. And thank you very much for this wonderful opportunity.
We have a time for question, if any.
Okay, you are catching in the early stage, amylase will be elevated. That's a very good question. Suppose the patient comes after 72 hours. If you see the graph, there's amylase when it's coming down, but serum amylase lipase will be persistently elevated. So in the later phase, you can do this serum lipase. So you don't need to do both the things. But lipase, we do it after 72 hours.
Genetic testing for the pancreatic etiology of the pancreatic. Genetic testing for etiology of pancreatic.
Yeah, actually, genetic testing is evolved very much, and it doesn't change the treatment profile. Only thing we know certain diseases where high incidence of cancer will be there, like hereditary pancreatitis. So those things will be there. And for somebody want to ask the marriage proposal, everything, you have to be very careful in advising them what is the chance and everything. You have to be very transparent in telling them. There is a equal chance that may not get it also. So then number 2. Number 3, for research purpose, it is very useful. So to know whether the cancer potential and to advise for the future marriage proposal. And the third thing for research purposes.
Of family hyper-TAZ with the incidence of the acute pancreatitis, and what will be cut off the TAZ? I'm a practicing a diabetologist. Most of the patient is coming with a high TAZ, 500, 600, 700, 800 of the just, I'm seeing of the serum is just like the white color. So what message to patients to keep the TAZ?
I think
of
it's
the-
a very pertinent question. Most of the studies they have seen those TGL, triglyceride, more than 1,000, they are more prone to develop pancreatitis. I think more than 1,000, you have to be very careful. A certain time anyhow you need to control that. So most of the cases are reported in the literature more than 1,000. Sir.
I'm telling you all my patient, if the TAZ is more than 1,000, any abdomen pain and vomiting, get the amylase lipase is compulsory.
Yeah, actually, physician day and night, they see the diabetes, hypertension. I always tell my postgraduate, and if it's not enough, you are good in gastroenterology, you have to be extraordinarily good in the diabetes management, hypertension, hypertriglyceridemia. So one need to know every drug possible, all combination, and then only you can be treating the patient as a whole. It is not just treating one pancreatitis and letting out the drainage, draining the fluid alone is not our job. So we need to know we should really go out of the way to find out the etiology. So more than 1,000 is that.
Thank you, sir. Thank you.
So concluding, the pancreas is like tiger and pancreatitis is like injured tiger. but we have a tiger of pancreatic disorders and tiger of endoscopy of India. Sir, Dr. Chandrasekhar, you make the presentation very simple and very useful for the day-to-day clinical practice. Thank you for the presentation.
Thank you, sir, for the extraordinary knowledge. Now we will move to our next topic on the management of infected pancreatic necrosis. I would like to request our chairperson, Dr. Dhaval Gupta, Dr. Jigar Patel, Dr. Suresh Chatwani, Dr. Harshad Patel, Dr. Dinkar Goswami, and Dr. Pritesh Patel. I would like to invite our first speaker, Dr. Sandeep Laktakia, sir. He will cover the endoscopic management of pancreatic necrosis.
I will like to invite Dr. Sandeep Laktakia, who is senior gastroenterologist at AIG Hospital, Hyderabad. Today we'll be discussing regarding the management of infected pancreatic necrosis, with specific focus regarding the endoscopic intervention.
Thank you very much. At the outset, I would like to thank Yogesh and the entire team for inviting me for this wonderful meeting, 7th AP Advanced Gastro Summit. The topic today is the management of infected pancreatic necrosis from the endoscopic perspective, from surgical and intervention radiology. So 3 different speakers will be covering this area. I will be limiting myself to endoscopic part of infected pancreatic necrosis. So before I move forward, this is a very important paper which has come this year in pancreatology, and which is covering the revised guidelines of acute pancreatitis 2025. This very important document, led by Dr. Pramod Garg, the head of the department at AIIMS, covers entire gamut of acute pancreatitis, and those who are interested in it must read it. This is not only an Indian guideline, this is supported by European Pancreatic Club, American Pancreatic Association Club, Indian Pancreatic and Japanese Pancreatic Society. So several world leading authorities combined together to make this document, which has more than 100 authors. Pramod Garg is a lead author. It gives several recommendations for managing acute pancreatitis. Total of 96 recommendations. Every doubt that you have in mind is covered in this document, which is 45-page document. It also has some statements to follow. I initially thought I will cover this, but this topic was different. If we have time, we can discuss few slides in the end, time permitting. Now coming to my topic of endoscopic management of pancreatic fluid collection. I'm sure all of you know that pancreatic fluid collection, Dr. TSC just mentioned, can be pseudocyst or walled off necrosis. They are spectrum of the same disease. One has a collection with only fluid inside. Other has a collection which is walled off, has fluid and some solid debris inside. So pseudocyst is pure fluid, walled off, and walled off necrosis, as the name suggests, is also fluid collection with variable amount of solid content. Whenever we get a CT in a later phase of acute pancreatitis, say 3-4 weeks later, we see something like this, as we saw in the previous slides also by Dr. TSC. This is almost a mature collection ready to be drained, where I can show them. Yeah. Here's a little. Okay, I'm sorry. So this is the collection. The pancreas is here. It's a very well matured collection. This is the black thing is the gastric lumen, from which we can enter and drain the content between the stomach and the collection. So if you can place a stent, either plastic or metal, all the content will then drain into stomach and then come out. Either you can aspirate it out at the time of drainage, or they will come in the fecal matter. So to drain this collection, we can drain transmurally. That means make a hole in the wall of the stomach or duodenum. Generally 90% plus is from the stomach. And we often use an instrument called endoscopic ultrasound. I'm sure most of you would be aware of it. Who does not know about EUS? Okay, this is one of the endoscopes which has also a capability of ultrasound incorporated in it. So we have two different types of image: endoscopic image, where you see the lumen, and beyond the lumen we see the with ultrasound, and that's why it's called EUS, which can drain these collections whether they're bulging in the stomach or not bulging. And if there are blood vessels in the wall, we can avoid those blood vessels to prevent complications of bleeding. About 20 years back, some of my senior colleagues sitting here would be knowing that we were also draining without EUS by using simple endoscopy or a duodenoscope and targeting the bulge, a big bulge in the center, and making a hole with a needle knife and then passing wire and placing stents inside. But the problem with that is that you need to a collection which is bulging in the stomach. So non-bulging collections could not be drained even if they required draining. And that's why EUS is now the way to go forward in draining these fluid collections. So the major advantage that EUS offers is that it improves the localization. You can visualize and avoid blood vessels which are interposing in the way. You can select the right point of entry, the thinnest point, and ability to puncture the non-bulging one. The only drawback is that sometimes thicker stents have a more challenge in placing by EUS compared to a regular duodenoscope, which has a thicker, wider caliber. Next, we come to which types of stents to be used. I'm sure you must be aware that either we use metal stents or plastic stents. Plastic stents are cheaper. They're effective for patients who have only fluid in those collections and not solid debris. Whereas metal stents are little expensive, but they're more efficient in draining. They have a wide caliber, so the fluid can very easily drain out. And once the stent, these are self-expandable stents, once they expand to a diameter they're supposed to reach, 15 to 16 millimeters or so, then the solid content can either spontaneously drain out into the stomach, or if we need to go inside the cyst cavity and pull out physically, which I'll try to show in some of the slides subsequently, to do a necrosectomy. So let me show how these procedures are done. The procedure generally takes about 15 minutes to 20 minutes, maximum half an hour in expert hands. So this is just an evaluation of the collection. This is how a pseudocyst on EUS would look like. So you see the wall is all mature. The contents is, the black is all fluid, rest is all solid content or debris. Then you can measure the dimensions. Larger the size, more symptomatic they're going to be. You know the wall thickness. You know which scope position if you have a fluoroscopy side by side, which is often required. You can avoid the blood vessel, as I said, and select the right point of entry. So these are the things that we do prior to drainage. And once we decide, then we puncture this collection. This is a special type of a needle, which is a long hollow needle, a 19 gauge in diameter, through which we can aspirate the fluid and send it for contents to confirm infection is there or not and whether amylase is high. After we puncture it, then we pass guide wire inside, coil it like this, seen under X-ray. And once it is coiled well, then this is the needle that is often used. These guide wires, once they're coiled inside, allow us to now dilate this path or fistula to create, there are several types of dilators which are required. I think that I'll skip this. And this is the fistula which is created, so by which we actually burn our way in over the guide wire. This is the most common method of creating a more sustained opening. And then we dilate this path with a balloon. So this is a balloon which goes over the same guide wire. So it's a 4-step procedure. The first is puncture, second is guide wire, third is balloon dilatation, and the fourth is stent placement. So balloon is also seen on endoscopic ultrasound. You can see the image. You can also reconfirm by X-ray and endoscopic view if required. And the last step is then placing the stent. But before that, sometimes we use metal stents. In that case, we use a smaller caliber balloon of 4 or 6 millimeter. So this is a small caliber balloon being used. So depending on what type of stent one is planning to place, the diameter of the balloon changes accordingly. Then we can place multiple guide wires to the same hole that we have created. And finally, we place the plastic stents. This is the plastic stents which are placed. You see this, the pigtail, it's a curved at the gastric end. Other end inside the cavity also has a curve. So this helps in fixing the tube and does not migrate out spontaneously. If you keep a straight stent, this can migrate either inside the cavity or into the gastric lumen and does not serve its purpose. So double pigtail stents are required. Usually more than one is required. So this is for the plastic stents. What has really changed in last 10 years or so is the availability of large caliber metal stents, which is what I was saying in the beginning. These are of two different families of stents called lamps and biflanged metal stents. All are equally effective. Let me show you how they are placed. This is a large collection with a lot of infection inside, as you can see on the EOS image. An experienced eye would tell us that this collection has pus inside. Also, the symptoms and other parameters would also guide us same way. And this is a stent which is coming inside. You burn your way in and then deploy this stent. The one flange opens up inside the collection, as you see on EOS view, and then we come back into the gastric end and deploy this other stent of this other side of the lamps. And the pus starts coming out. So this is how these are very easy to place, very costly though, but easy to place, can also be done bedside without fluoroscopy, and an experienced hand, it can take less than 2 minutes or so to place it. So if patient is very sick and it deserves a drainage, one can do it. There are other stents which are a little cheaper and also equally effective. This is called biflange stents, where they have the design that they have flanges on both the sides. And in interest of time, they can also be placed similarly. As long as you can drain the collection by using these wide caliber stents, they do the job. This is how the stent would look like in the end. So which stent to choose is dependent on the content. Just a minute more, I think, and I'll wind up. Is dependent on the content of the collection, whether it's pure fluid or fluid plus solid, and how much solid will decide. If more solid, then metal is better. If more fluid, it's plastic is as good. Since there are multiple sequential steps in plastics and placements, each step is dictated by the success of the previous steps, and that's why a synchronized effort in the team is required. Several imagings are used during this procedure. It's endoscopy, EUS, and fluoroscopy, and each step requires this. This is how a collection would look like in the beginning, and on the right part is how it looks in the end. This is at 3-4 weeks when they pull out the metal stents. Plastic stents can be left longer. This is our own experience, which was published long time back. I'll move forward and just show you one more thing. It's called necrosectomy. When the stent is blocked by a solid content which is coming out, you can also do endoscopic removal of this solid dead tissue, which traditionally surgeons have been doing by doing laparoscopy or laparotomy. This can be done by endoscopy itself. Through the stent, you can go inside, remove the stent, go inside the cyst cavity, irrigate it well, use instruments to remove these chunks of dead tissue, and actually patient feels quite better at the end procedure. These are some of the publications whether necrosectomy can be done at the time of index drainage or later on. Occasionally, we also take help from intervention radiologists and do a combined procedure, which is called as multi-gateway technique, where not only percutaneously we drain, but you also drain endoscopically simultaneously almost the same patients. This is the patient who's come back later with collection. So in the end, I would like to sum it up by saying that endoscopic drainage of pancreatic fluid collection is effective, safe, and can be managed for both patients who have walled up necrosis and pseudocyst. The decision for stent depends on what it contains. All these stents have to be removed after finite indwell. The metal stents definitely at 3 to 4 weeks. Plastic can be left sometimes lifelong if the patient develops a disconnected syndrome. Thank you very much for your kind attention.
Thank you, sir. Sir, the questions will be taken at the end of the session. Sir, please have your seat, sir. Thank you, sir.
I like to invite Dr. Pawan Rawal. He is the Senior Director of the Interventional Radiologist Department at the Medanta Hospital, Gurgaon. He will give the talk on the management of infected pancreatic necrosis.
Thank you very much. At the outset, let me thank Dr. Yogesh for having me here. The disclaimer is I'm a gastroenterologist, not an interventional radiologist, so I had to put the soul of an interventional radiologist in me to prepare the slides. I'll try to justify the same. So Dr. Sandeep has already put the things into perspective. Now we know what are the acute fluid collections, and we know what happens when the pancreatitis sets in. It can be edematous, that's non-necrotic or necrotic. If there's a non-necrotic pancreatitis, the collection also will be non-necrotic, called as pseudocyst. And if there will be a necrotizing pancreatitis, the collection also will form a necrosis. At the end of 4 weeks, this is called as walled-off pancreatic necrosis. So just reiterating, like this is acute fluid collection leading to formation of pseudocyst without any necrosis. The other one is necrotizing pancreatitis, finally leading to a walled-off necrosis. We all discussed that no one team can handle the stuff because the disease is so versatile. So it's a teamwork wherein Dr. Sandeep already put in the endoscopic part of it. I'm here to give the role of intervention radiologist. So where do we put in as an intervention radiologist? We know that endoscopic route is the most physiological route to drain the collections, but sometimes this doesn't happen, especially if the patient is sick, patient is not a candidate for endoscopic drainage, failure of medical treatment, or the collection is far away. You see the collection in the paracollic gutter, we usually label it as a type B1, where you can't reach by endoscopic means, and then you have to bring in the intervention radiologist to drain this collection. So these are the usual indications where we come in. There are some less common indications also. Suppose this wound is forming a mass and it is compressing the stomach outlet, leading to gastric outlet obstruction, meaning maybe it's a jejunal obstruction also. Sometimes the patient is beyond many weeks of illness, but the symptoms are persistent. In any which way, he's not a candidate for endoscopic or surgical drainage. And sometime in the disconnected duct syndrome, what is disconnected duct? Wherein the necrosis was too much, the pancreatic duct actually is not in connection. So the body and tail duct is not in connection with the head duct. So this is called as the disconnected duct syndrome. And you may require intervention radiologist in that. The timing is very important. You can't drain, you should not drain the collection at each and every time. Suppose the patient was admitted today. In first week, there is an inflammatory response we discussed yesterday. And the second week, there will be an infection that will ripen. The patient is sick, but then every sick patient having a collection should not be drained. And there is enough data to tell that. This is a pointer trial. This is a very landmark trial in New England Journal of Medicine, which showed that if you drain early, vis-a-vis you drained later on, that is called as the postponed drainage, around 3 to 4 weeks after the formation of wall, it said that early drainage is not good. So that means the routine immediate drainage, even when the necrosis was diagnosed, within 4 weeks did not improve the clinical outcome. Rather, the postponed drainage was good. One, the complications were less. Second, rather, it's actually avoided an intervention. That means if you did wait for 3 weeks or 4 weeks for the drainage to happen, 39 to 40% would not required, and they will improve with the antibiotics. So that was the advantage. So that should be taken into account. Next is how aggressive we should be, whether it should be a straightforward open necrosectomy or video-assisted necrosectomy, or should be a step-up approach. There is again data. What is step-up approach is that you be a little slow. You start with the medical treatment, you give antibiotics. Then if needed, if the patient is sicker, and as we saw, we go for the percutaneous drainage. And if needed, we go with the minimal invasive necrosectomy. What is it? That even you can do necrosectomy through the percutaneous drain we already put in. And if then needed, you go for surgical. That's called the step-up approach. And it was found that the step-up approach is better than directly going for the surgical necrosectomy. In this Painter trial, this proved everything. So it is again a fact that minimally invasive step approach as compared to open necrosectomy, it reduces the rate of complications. So that should be the practice. Now, how PCD is done, not going in detail, it's a routine stuff people do. It's like any cell danger technique. So under the ultrasound or CT guidance, you place the needle, you target the collection. You have to avoid the vessels, blood vessels if they come in. Use the cell danger technique. You may have to dilate the tract, and then gradually you have to increase the size of the drain you put in. The concept is, as was in the endoscopic thing, we have to remove the necrotic material, because necrotic material becomes the nidus for the infection, and it keeps on giving you fever. So gradually the size of the duct drain has to be increased. So this is the stuff we do. This is the Seldinger technique, and then you put the drain. The guidance can be ultrasound or CT, depends upon the location, the ease of access. So if it's a deep-seated the collection, you may use CT. If this is accessible collection, of course, the ultrasound is the real time. It gives you the actual picture, and you can use the Doppler as well. Sizing varies. It depends upon the amount of necrotic material collection has. So suppose the necrotic material is quite dense, you have to increase the size from 12 French. I mean, people have gone beyond 20 and 24 French. And of course, if you think that the collections are multiple, suppose one is there in the lesser sac, second in the paracolic gutter, and if they are septated, you may have to use the multiple drainage techniques to drain the collection. Now, they require further maintenance also. Sometimes you need to flush them because there is always a chance that the catheter will be clogged because of the necrotic material. You have to assess them. Repeat imagings are required at a gradual interval. And we have to watch at 72 hours whether your patient has responded to all these measures or not. So this is one example where you went ahead with the drainage. This is the drain in situ. So this is the path. Usually it's the retroperitoneal path is followed to avoid the stomach, and that helps a lot. As I said, catheter upsizing is required, not only because you need to remove the necrotic material, but sometimes you need to put an endoscope through this drain to do a necrosectomy. It's called the percutaneous necrosectomy. So that requires the upsizing as well. Many of the troubleshootings can happen. You may need to reposition the catheter. I mean, these kind of things keep on happening once your patient is inside your hospital in the ICU. The IR people are gradually involved, and the reposition keeps on happening. Success rate has been good. Among the good heads, the success rate is 65 to 90%. And important is the point too. Actually, 75% of these people, the surgery was avoided. That actually amounts to 3/4. And usual, the dwelling time is around 14 to 28 days. So that's the time where the drain is needed to be required. Now, success has varied because of the nature of the collection, amount of necrotic material, sicker patient, and suppose you drained the collection early in the phase of acute pancreatitis where the wall formation was not adequate. So in that cases, there can be a variable success rate you can achieve because of the in view of the drainage. This is again one of the example where the wall duct necrosis was there. It was effectively drained, and gradually there is a reduction in the size. This is what I was talking about. It's not that you can't you pass the endoscope through the mouth through ears route. So this is the percutaneous route where you actually do a percutaneous necrosectomy with the help of this called a sinus tract endoscopic necrosectomy. You take initially a pediatric scope, or later on gradually you have a tract dilatation, and you pass an adult scope, and you do the necrosectomy with the help of the snares. Complications are known. Patients are usually sicker. So those patients who require percutaneous drainage, they are sicker. They are more toxic. Sepsis is usually there. So complication can happen at the outset in the form of bleeding, in the form of organ injury, the adjacent organ injury. Since you are creating a track with the collection and it is outside into the through the skin, and there is an active pancreatitis going on, there can be external fistula formation. That's very important, and one of the common complications that patients can develop. Like this is the one where this is the track, and then the percutaneous persistent fistula. That means you already put a drain, and after week, 2 week, 3 week, there's a persistent drain output through the percutaneous drain. Usually, these patients, they improve by conservative management. You actually improve nutrition, high protein, high calorie diets you give. Sometimes require the octreotide. Octreotide is anti-secretory, and these things, they help. But yes, sometimes you may require other measures. Sometimes you actually treat them with the endoscopic route by a term called a pectogastrostomy, where you actually internalize this fistula into the stomach with the help of endoscopic ultrasound. So this is the resolution of the fistula we could achieve. Dual modality, he already talked about by Dr. Sandeep, wherein actually you have both the measures acting together, the endoscopic route and the percutaneous route working together, the multiple gateway technique we talked about already. Some roles of the interventional radiologist could be there for vascular complication. We know when there is an infected necrotizing pancreatitis, there is increased incidence of pseudoaneurysm formation, especially involving the splenic vein, gastroduodenal vein, and the pancreaduodenal arteries. They sometimes are lethal. The hemorrhagic complications are also not uncommon. Severe pancreatitis can create a very, very conducive environment. Actually, it erodes the vessels, leading to the retroperitoneal space, leading to the bleed and the collections. Early recognition is helpful. Patient develops tachycardia, hypotension, fall in hemoglobin. CT angiography may help. The endovascular treatment is quite useful in the form of either coil embolization. You can coil the aneurysm actually in one or two way, or you can place a vascular stent to decrease the distance. So in summary, percutaneous drainage is minimally invasive, effective, first-line intervention for infected and necrotizing pancreatitis. We should place it appropriately to those toxic and sick patients, not improving with the medical treatment and not amenable for the endoscopic treatment. We can place retroperitoneal approach is preferred, and it allows to avoid the stomach. The trials have shown that alone PCD can be helpful. It can avoid the further intervention as late as possible. You have to pull up your patient to at least third and fourth week, if possible, to give good results. We already discussed. You can take the help of endoscopist also, where you can use the dual modality to effectively drain the collections. Complications are there. Fistula can form. The other complications there, but they can be very well managed. And as I said, step-up approach is good rather than directly jumping onto the open or ward necrosectomy. Preferably, it should be a slow, gradual, stepwise approach that should be followed. And advances in the imaging and catheter technology have actually improved the outcome and improved the prognosis. But finally, pancreatitis is a messy organ. It requires a multidisciplinary team to manage the collections. Thank you very much.
Thank you, Dr. Pawan. Please have your seat on the stage. We'll take questions in the last.
Now we'll learn about third modality of treatment of acute infected pancreatic necrosis, surgical management by Dr. Anand Patel, practicing gastrointestinal and bariatric surgeon.
Good morning, one and all, and I invite you behalf of the Noble Gastro Hospital. So, you should have a backup plan. Similarly, when scope and catheter rest, scalpel rises, and that's how the surgeons often call in. Technical error. Okay then. Okay. So here we begins, and once again, welcome to this our summit. And the role is appointed me over here is surgical management of infected pancreatic necrosis. As you see that this group of the pancreatitis is often severe, and the mortality is quite high when it become infected. Well, this is the usual scenario when the surgeons involved, when there is a clinical deterioration despite optimal medical therapy, and there is a confirmed or suspect infected necrosis, and where either suboptimal or failure to invasive or radiological intervention, and then you need some another step of approach, then often the surgeons involved. Or other subgroup is when there is a abdominal complications where my radiological friend or endoscopist cannot assess. Well, when we comes in, we have a two goal in our mindset. First is debride the infected necrotic tissues and provide access for irrigation and drainage. And
Also look for the long-term nutritional access. As we know that the nutritional parameter also we have to take care in. And the principle also here is the same. Minimally invasive approach are preferred to open necrosectomy, as the lot of studies, my previous speaker has highlighted the importance of minimal invasive approach. And whenever possible, the surgical intervention one has to delay, probably beyond 8 weeks. Well, when we sets in, whether it is a surgeon or the endoscopic, he should have the clear three-dimensional, before doing any intervention, he should have a clear picture which is the best route to enter the necrosectomy. As we know, the pancreas is a retroperitoneal organ, and usually we get either transgastric, either we go through transgastrocolic approach or through the transmesocolic approach. There is another approach, this is retroperitoneal approach. So almost 4 approach we have for any kind of necrosectomy. And for that, we have to utilize 3-dimensional or probably a good CT scan where your interventional radiologist can help you which access should be the best. While I decide for any kind of necrosectomy, I usually talk with my endoscopist and we decide the plan. So the simple is transluminal is always preferred. So just evaluate based on CT scan, whether the necrosis at the vicinity of your GI organ, whether it is a stomach, whether it is a duodenum. Then you see it whether that can be utilized with a concomitant procedures like percutaneous access. But when the locations is away from stomach or a duodenum, then probably a laparoscopic approach would be a good case for this case. The principle is same. Less is more. Approach appear to remain most appropriate. So this highlights the percutaneous drainage, whereas the previous speaker, Dr. Pawan, has very well highlighted that once you put the small caliber percutaneous drain, that it gets a time, almost 2 weeks for that maturization. And what we do here is in the surgical OR, we are doing the upgradation of the drain. Our aim is that to dilate the tract so that we can approach through video-assisted retroperitoneal debridement. So the first principle lies that you follow the track and upgrade the drain. This shows that how we do the video-assisted retroperitoneal necrosectomy. Like similarly, endoscopic procedure is carried out. This is the same way with using the standard laparoscopic instrument. I have a 5 mm telescope and I have one suction in my hand. And you can easily see that how greatly I can do the necrosectomy under control vision. I do not want to damage any surrounding structures. I do not want to cause any significant bleeding. So this is the very useful tool. And this kind of necrosectomy, usually we can carry out those collection which are left side of the spine, means toward the left flank region. And here we have to safeguard is anteriorly above the colonic structure. This is the one of the most common necrosectomies being performed. When we are not able to carry out or those collections which are lying on medial or more toward the pancreatic head, there we do cases of transperitoneal or transperitoneal transgastric necrosectomy. This was the case which the patient had a infected necrosis, but prior is pseudocyst was drained. But since amount of necrosis is too high, sometimes you need a more radical approach or maybe a frequent, like Sandeep sir has highlighted that time this video I had carried out almost 9 years before. That time good axial stent weren't that much frequently deployed. So here many a time the cost factor comes in. So many a patient preferred one-time approach. And we can see here that I have explored. Again, you have to see the CT scan, decide where is the predominantly necrotic part is there. Here I am going through retrogastric rather than the transgastric. And once you open, we can clearly see the necrotic amounts. And again, the standard irrigation and suction is being placed. The trick over here is that delay necrosectomy. If you wait up to 12 weeks, the necrosome is very easy to separate it out from the retropancreatic bed. And that's a easier way to do a necrosectomy. The more earlier you intervene, there is a more chances that you will damage surrounding structures and bleeding too. Yes, extraluminal drainage has its own sets of problem, like pancreatic fistulas, bleeding. That's quite common after any necrosectomy. So you can see the necrosis, large amount of necrosis you can deliver out through laparoscopic approach. This is another video showing there is a role of also open necrosectomy. This was the necrosectomy I had carried out through transgastric. Many a times we condemned open necrosectomy as it will be more invasive. But believe me, if you have a good radiologist and you have fixed protocol, then even with the less invasive, here I have directly opened the abdomen through transgastric, I am carried out the necrosectomy. So every procedures have their role. We cannot say the one procedure is the best. Well, it is lightly said that after the earthquake of major operation, there is a tsunami of complication. And what matter is how steadily we navigate through. It is not uncommon to see a blood from the drains. We have seen the blood from the drain. There is a bile in a drain. And sometimes the enteric content also we see. I feel interventional radiologist has a great role, not only in the early progression of the disease, but also at the later stage when you have a lot of risk of pseudoaneurysms. And when we have biliary perforation, like typically a duodenal perforation, I would be literally skeptical to do a necrosectomy, in particularly in the head region, where the often duodenum get perforation. Many a times you might get colonic perforation, and that time you have to do a lot of other intervention. People also presents with abdominal compartment syndrome where we have to do laparostomy, colonic perforation, and we have to do ileostomy. Well, my purpose was to highlight the surgical approach in necrosectomy. I'm avoiding this slide. Well, the conclusion is timings. Delay until the necrosis and peripancreatic collection become walled off. Typically, that happens after 4 weeks. Involve the surgical team in early for the decision making, but intervene the less. Unless there is an emergency, you involve your surgical team at the beginning of the course rather than asking for the later one. Probably that is a crucial time and we might miss the bus. Step-up approach is always preferred. Whenever possible, prefer a drainage through transluminal. And timing on the intervention should be delayed. Always remember, delay, drain, and then debride. Thank you.
Any questions from the audience?
Yes, please.
Is there any harm of retrograde acid going into the cyst, or some say patients is taking alcohol, tobacco? Is there any long-term effect or any other effect, or is it a only valvular effect, or what way you tackle the fistula?
Thank you. So the question is, once we drain endoscopically these pancreatic fluid collections from the posterior wall, the collections are in the lesser sac. And once we place these plastic or metal stents, is there a risk of gastric contents of the food item to go into the cavity? The question is very valid. Thank you for raising it up. Yes, it can. The food matter can go in. Sometimes we see rice particles or dal particles in the cavity, especially if the large stents are used. That's mainly in patients either who have paralytic ileus or they have obstruction in the gastric outlet for say duodenal deformity or because of edema in the pancreas in the head region, which is causing some outlet flow of the stomach. If that path is okay, then these things do not make a difference. Even if you drink alcohol, it will go down that duodenum and get absorbed there rather than causing going inside in cavity. And most of these openings also close with passage of time once we remove these metal stents. And often when you do an endoscopy, say for any other reason, 6 months, 1 year, or many years down the line, we hardly see anything, or sometimes you see a small scar there. So the risk is very, very less.
Sir, you put the plastic stents indefinitely, or would you remove it after a certain, like cavity collapse?
That's a great question. So when we place plastic stents through endoscopic route, we leave them for a long period of time. Metal stents should not be left inside because they can cause complications in left inside, whereas plastic stents are much safer and can be left indefinitely in a situations where there's a disconnected pancreatic duct, which happens sometimes after severe necrotizing pancreatitis. The purpose is that this plastic stents also works like a conduit to drain the upstream disconnected pancreas, and that juice can flow through this into the stomach.
I will like to ask one question. So if patient has come to us with acute necrotizing pancreatitis, patient has improved well over a course of next 2 to 4 weeks. Patient is asymptomatic. We are monitoring the necrotic collection. 2 3 months down the line, we see there is a well-formed 3 4 centimeter collection with 4 5 mm wall in the lesser sac, and patient is completely asymptomatic. Do we need to drain that collection?
Okay, so the question is, I'll just repeat it for others, that a patient of acute pancreatitis, he's recovered. He has a small collection, 4 5 centimeters you have mentioned, and patient is completely asymptomatic. Are we justified in tackling this? I don't think so. Any small collections will also disappear with time, or even if it remains, if it's not causing some, don't drain it. But if it's a big collection, sometimes the dilemma occurs when it's a 10 centimeter, 12 centimeter collection, patient still is asymptomatic. Those are the ones where we watch for any symptoms. If they have fever, pain, all those things are clear-cut indications. But there are some patients who will just not improve. They have no pain, no fever, but their weight is still gradually going down. They're still slightly catabolic, but the collection is big. These are the ones which should also be drained.
Sir, just sharing the experience, especially in elderly females and males. Those who are elderly, we have seen that those who have big collections, though they are asymptomatic, they come up with colonic fistulas. So what should be done, sir? Should we drain based on their age, size, irrespective of their symptoms? Because we had 3 cases, everything normal, Anand will agree, and they just came with sepsis after observing them for 1 or 2 months with colonic fistulas.
Raval, you will take that? I think we all are experts. I think we work together. I think that's very important. Before I answer this question, I want to tell that the treatment is a team effort between the surgeons and the intervention radiologist. We all work hand in hand and decide which way is the best for the patient. Never decide in isolation. I think then we burn our fingers. And the question that you asked is large patients who are elderly and have large collections. I think it's worth draining them because they may rupture in different directions. These spontaneous resolution is also, it's not like that the body absorbs that. They open in some GI tract. If it's stomach, no problem. Duodenum, no problem. But colon, yes, because that's a area which harbors a lot of organisms. And then there is a cross contamination of the colonic contents coming into this. And then they come back with fever. So any patient who has this collection and develops a fever later on starts suspecting there is a colonic communication.
Very nice questions you had asked. Since last 9 years, what I have learned from surgical practice, because see, not every center has a medical gastro or surgical gastro. So we've been told and informed that whenever the pseudopancreatic cyst comes, you can give surgical correction to them and delay the intervention till the patient develops symptoms. I have changed my practice. If the patient has a good cyst wall formations and symptomatic more than 6 centimeter of size, I always ask my endoscopist to drain endoscopically rather than the surgically. Second practice I have changed. Pancreatic fistulas are much more difficult to treat surgically. Better than you convert them to pseudopancreatic cyst. You make them cyst. Converting fistula to cyst is not uncommon. What I do initial practice, I upsize the drain. Later on, these patients, after 4 months, 6 months, they roam with a drain. It is very difficult for me. It's a disconnected duct. You don't want to go inside. Already you have done twice laparotomy. I start downgrading the drain. start from 22, 20 and make the infant feeding tube. And there is a one point will come where the stricture will form and the pseudocyst will appear. That time is the right time for the endoscopist to enter and drain that pseudocyst through either transgastric and put the pancreatic duct stent. This is, I think, I have learned the best approach after a couple of years.
Only one addition what I would make is, I think Dr. Sandeep talked about the symptoms of pain and fever. A presence of gastric after obstruction is also common. A patient of pancreatitis recovering maybe 5th, 6th, 7th, 8th week coming with the vomitings. Be aware that he can have the mass effect of the von or pseudocyst on the stomach outlet. So this again becomes the indication. Usually we don't label them to GU and we don't do the imaging. You should have a low threshold doing some kind of imaging to rule out and this kind of gastric outlet obstruction and go ahead with the drainage.
We have excellent discussion and debate over the topics, but in interest of time, we have to end the session. Thank you, everyone. Thank you, everyone.
Thank you.
Thank you, sir, for the amazing session. Now we will move to our next session on GERD Symposium. I would like to welcome our chairperson, Dr. Manish Agrawal, Dr. Sunil Wadhwani, Dr. Kunal Bhardwaj, Dr. Kirit Kubawat. I would like to invite our first speaker, Dr. Zubin Dev Sharma. He will speak on ineffective or absent esophageal peristalsis on manometry, a dilemma for surgeons.
Good morning, everyone. We are moving to the next symposium, that is GERD Symposium. Almost every symptom related to gastrointestinal system can be attributed to GERD, and most of the pathologies of upper GI, they can be related to this very common condition. Let us learn it from the experts. For that, I first invite Dr. Zubin Dev Sharma from Fortis, Gurgaon. He will discuss about ineffective or absent esophageal peristalsis on manometry, a dilemma for surgeons. Over to you, sir.
Thank you so much. And once again, I thank Dr. Yogesh for having us here. Yesterday I talked of corrosive, but this is something which is again much more, intrinsic problem of the esophagus, where the peristalsis has gone down. And how it affects our management, I'll try to go more towards that. So what I will try to tell is that when you see a report which says ineffective motility or absent contractility, what it really means as a physician or as a surgeon, how does it affect our use of PPIs and our use of surgical interventions? Nowadays, we also have EndoFlip available, which I think I'll just touch on briefly how it can be used by the surgeons to really improve their outcomes, and some India-specific perspectives. So these two are the images, which is the agenda of today's talk. The first slide, this shows that these two are high-resolution manometric images of esophageal body. What you are supposed to see here at this area are nice, green and orange-colored diagrams. What you are seeing is just plain sea blue color and nothing more than that. What it tells me that esophagus is not contracting. It's just contracting here, but there is nothing down the line. On this side, again, you can see there is absolutely nothing on the esophageal body. So this simply means that whenever you are swallowing, your esophagus does not have the power to push the food down. How it affects us? When we define ineffective motility, the parameter we use is something called as a ineffective swallows or DCI. It means that the strength of esophagus has come down. The value we put that as a DCI of less than 500 for ineffective motility, and majority of the swallows on the manometry should be less than that. In absent contractility, we say that the power has completely gone. The DCI is less than 100. That means that there is zero contractions happening. We also used to use a term called as fragmented peristalsis, which is now a part of ineffective esophageal motility. Let me show you this particular diagram again. This is something called as an impedance manometry. The purple color which you are seeing here is basically the food content or the water that we have taken. You intake the water here, the color will move down like this. This is supposed to be the normal contraction. You can see in comparison to this, there is zero, it is much more weaker. And on this side, you have a completely failed swallow. So this basically tells me that the patient doesn't have motility. And there are multiple reasons behind it. There are some neural factors, there are some muscular factors which lead to IEM. Now, IEM is a very common finding on manometry. Sometimes it's just a normal variant. Sometimes these patients are completely asymptomatic. Rarely, but what they definitely will have is an abnormal reflux clearance and abnormal bolus transit. What it basically means is that the food that is in the esophagus is not going down very well. And number two, whatever reflux is coming from the stomach into the esophagus cannot clear it down very well in proper time. And that's where the GERD starts to cause more erosive illnesses. That is where you will have those ulcerations, you will have patients who complain of food coming back and patients who complain of dysphagia. Now, GERD has developed into many therapies now. We have a lot of endoscopic interventions, we have surgical interventions, and particularly endoscopic interventions we published last a few months ago, where we can actually tackle all these problems. But before we go on to tackling these problems, we have to get all the workup done. There is something new also on the horizon, something called as GERD-X, which is almost like a partial fundoplication. Again, you need to look at how the motility is before you decide that which of this will you use. Surgeries are all of these. You all are aware of the Nissens is the gold standard. You can do a two-pit called as a partial fundoplication. Nowadays, something called as a magnetic sphincter augmentation is also done. And there are hybrid techniques also. But why we should be worried is because if you have hypomotility, you have impaired clearance, the reflux will be still there, and there's a risk of dysphagia after any intervention we do, whether it's endoscopic or surgical. It's very common, and manometry alone will not rule out a surgery, but it will actually tell you which surgery to be done in which patient. What's the problem with ineffective motility? If you see in this particular study, it basically said that these patients do not clear the chemical, that means the refluxate coming from the stomach into the food pipe, and that is causing patients persistent symptoms. So even if you do a wrap surgery in them, they will still have that refluxate persisting. In fact, it may actually increase the problem. So esophagus cannot clear the reflux which is already there in patients who have ineffective motility. Now, this was a very nicely done study. What they did was they actually induced impaired peristalsis by using a drug called as sildenafil. And they compared the clearances in upright versus supine position. What actually happened was this. If you talk of the volume of the reflux after giving sildenafil, the time taken for esophagus to clear went up very, very high as compared to normal. Similarly, the chemical reflux, also the time went up very, very high. So this study very beautifully showed you that if you actually induce impaired peristalsis, your chances of clearing esophagus becomes very weak. Coming on to absent contractility, we showed in this particular study, which we published in GUT a few years ago, that it's the etiology of absent contractility. Once you find absent contractility, please look for autoimmune triggers. Look for scleroderma, look for severe GERD. You have to understand that this is a definite abnormal finding. So it should trigger a more extensive search for the reason for somebody to have absent contractility. And in these patients, esophagus is incapable of pushing due to additional resistance, and the refluxate will stay longer. So if you do a wrap in these set of patients, these patients will not be able to push the food down and they will have more of dysphagia. But it's still not an absolute contraindication. It dictates a tailoring of the wrap. So avoid a Nissens in absent contractility. two-pits or door is more preferable. What is important is understand what your patient, what he is saying. Is it a reflux dominant? You should do a partial wrap with a hernia repair. If it is a dysphagia predominant disease, consider only hernia repair or gastropexy. Do not induce a wrap in these set of patients, because if you have absent contractility, there is no power in the esophagus. The moment you put a wrap in, you are creating additional resistance at the level of LES. They will not be able to push the food down. Coming on to what you can do all these things if you have those available: a manometry, a pH impedance, barium histogram, endoscopy will tell you a lot of answers. How I choose or how I discuss with my surgeons is, I confirm GERD, that's the first step, exclude eclasias. You stratify the motility, look for the amount of motility that is there. If it's absent, avoid wraps. You can also use endoflip as an intraoperative target. So these are the 4 steps we usually follow for management of GERD. For what's the evidence of what I'm talking about? What is the evidence that is actually there? So evidence shows that these are the various major studies that patients who do have IEM, doing a partial may actually reduce postoperative dysphagias. And even in this, in a nice review from SAGES, it said that a partial is commonly acceptable in patients who have dysmotility. So reflux predominant, you can do a wrap. Dysphagia predominant, do not do a wrap. In absent contractility, the risk remains the same, that the dysphagia risk is much higher if you do a wrap. This was a study, again, in 2021, we studied the higher postoperative dysphagia, and these patients may actually require dilatation if you do a wrap in them. So this was the final recommendations from across the guidelines, across the various societies, that in adult patients with esophageal dysmotility, a partial is better than the complete, whereas others will cause more issues. Even if we do something called the magnetic augmentation, it's the same thing, that you should not be going ahead with a complete wrap in them. They may actually have a more nuanced dysphagia. That's the data from 23 as well as 2020, where it does improve the symptoms, but we should not be doing. Similar to the previous guidelines, the guidelines again recommend the same thing. You can try for a magnetic wrap, but you should be aware of possible problems. Now, endoflip is a device which is like a sensor you can use intraoperatively, that how much tight your wrap actually is. The classical way is to put in a boogie and see, but this is a boogie with sensors. So your sensors will tell you what is the pressure. You calculate something called the distensibility index. So the recommendation would be that in case if you have it available, you can use DI and target DI less than 1.5. If it's 1.5 and less, you will have a higher dysphagia. If you keep it between 1.5 and 2.5, that's where the best outcomes are. These are the targets you can use when you are using, if you have endoflip available, which is now in India. It's expensive, but it's available. What do we know? That in India, I think definitely IM is very, very common. This is the Indian data across from all over India. Our targets are that in India, the DCI less than 400 is something which is more acceptable as an IEM as compared to the West. So last 2 slides, that, what do you do if you have normal motility? You can do a full repair. IEM, large breaks, to do a 2 pits, and absent, you should totally avoid total wrap. In case you end up wrapping them, they will develop something like this. They won't be able to contract anything. You have post-fundoplication dysphagia. You again do a manometry. You again do an endoflip. You keep on dilating them. Or they will develop something like this, which is a post-Nissen's chest gurgling. The food is not going down. It's actually coming back into the UES. And these patients can actually hear the gurgles in the chest. So how do you choose? IEM small hiatus with Hills to ARMA arms. Normal HREM with small hiatus, you can do a GERDEX or NARMA. Large hiatus with ineffective motility, partial, normal, you can do a fundoplication. So it's not an absolute contraindication. You need to tailor with your wraps, with your intraoperative calibration, either use a boogie intraoperatively, or if available, use an endoflip. Look into the manometry just before doing any wraps or any endoscopic intervention. Even use HREM, pH impedance studies time variant to personalize the decisions. I think the time is that we have to now personalize every GERD therapy based on the what findings we have. Manometry bariums are easily available, and that in fact should be mandatory to do before even we think of doing any advanced interventions for GERD. Thank you so much. Thank you.
Thank you for the nice and lucid talk. Our next speaker, and none of the above, the Dr. Yogesh Sarwani. He is the most dynamic gastrophysician, and he is the organizer of the consecutive 7 advance of the Gastro Summit. So I would like the Dr. Yogesh Sarwani, he is going to talk is what is advance in management of the GRD. India is overcrowded. Everybody is having the patient. He is complaining of the GRD. So what will be treatment apart from the medical? What will be newer PPAIs and beyond?
Yeah.
Dr. Yogesh Sarwani, please.
So once again, thank you, respected faculties and all delegates to be here with us. So I will be discussing on newer advances in management of GERD, newer drugs and beyond. So what is the purpose of this presentation? To learn new drugs for GERD, understand indications for endoscopic therapy, and what are the subset of patients of GERD who may benefit with this endoscopic therapy? Does this reduce PPI dependence? And how to stratify this patient, what you will choose, medical, endoscopic or surgical therapy? So before we begin, let us understand the definition of refractory GERD. Definition is those patients who have none or partial response to dual PPIs for 8 weeks, that is 2 months. But now the newer definition based on the Lyon consensus is actionable GERD. What is that? That those patients whom you are giving PPI, not responding to PPI for 2 weeks, along with that, those who have endoscopic evidence of GERD or have abnormal reflux monitoring like high AET or more number of reflux episodes, they are classified as actionable GERD. This is an extended definition of refractory GERD. So let us also go through 3 cases. First is 55-year male. He has long-standing GERD, PPI partial response, endoscopy large hiatus, and grade C esophagitis. This is a case of refractory GERD. Case 2, 34-year female, long-standing GERD, complete response to PPI, but when she stops, the symptoms reoccur and she is not willing for medicines anymore. Endoscopy, everything is normal except laxity of the LEAs, Hills 2. Case 3, again 42-year female, GERD, partial response to PPI, endoscopy is normal. So how do we choose individually? What can we do the best for them? All are cases of refractory GERD. So what are newer therapies? First is medical, which is vonoprazan. Other is endoscopic, which is ARMS, ARMA or GERD-X. So let us go one by one. So coming to medical therapy, the newest kid on the block is PCAP. That is, what is the mechanism of action? That PPIs, they enter into the parietal cells in an inactive form. They need acidic environment for activation. Once they act on the pump, HK pump, they reduce the acid production and decrease symptoms. Well, what does PCAP do? They enter in an active form. They know they don't need any acid environment. They are more acid stable and hence they act fast, and have also studies have shown they have higher healing rates and longer duration of action. Studies have shown that when you are treating H. pylori, the combination regimen of H. pylori with PCAP is better than PPI for treating and eradication of H. pylori. So vonoprazan has a rapid onset and long-lasting duration of action, and it is effective even in the fat state. PPI we have to give always in the NBM state or 30 minutes before breakfast or dinner, but this you can give it anytime. So should we choose vonoprazan over PPI? No, not in all cases, but you can choose when you need faster relief of the symptoms, especially in acute gastritis or acute GERD. Healing rates, some studies have shown are better, but we need Indian data. Definitely, when you are treating H. pylori, you should combine vonoprazan now because it has a better eradication rate compared to PPI. So now let us go through endoscopic therapy. There are several factors which decide that in whom we will choose endoscopic therapy. So first is anatomical stratification. Why does hiatus hernia occur? because we have two components at the G junction. One is LES sphincter complex, which includes LES and esophagogastric junction. This is the internal sphincter, while crural diaphragm is the external sphincter. And there is a ligament called phrenoesophageal ligament which connects the LES and the crural diaphragm. So any disturbance in either of this will lead to symptom of reflux. There are two types of GERD. One is early GERD, in which there is only disturbance in the LES complex, while crural diaphragm is intact. Other is advanced GERD, which means that there is separation of LES as well as the crural diaphragm. And mind well, whenever crural diaphragm is not functioning properly, it is not an indication for endoscopic therapy. Let us go more in detail. So what is LES? As I mentioned, that early GERD involves only LES. So this LES has sling fibers, which are the continuation of esophageal inner circular fibers, and they extend into the stomach. So when you contract them by clipping endoscopically, these muscles are pulled down and this further accentuate the anti-reflux barrier. So this is the target for endoscopic therapy. We also should know Hill's classification. I will run through this video. When you do endoscopy and you are planning for endoscopic therapy, it is very important to look at the LES for at least 60 seconds. So you can see here right now that when you look at the LES, it is just Hill's 1 or 2. But when you inflate it over a period of time, you will see that it gradually opens up. So this is now Hill's 3, and after a few seconds, it becomes Hill's 4. So it is very important indication, especially for physicians, surgeons who may refer for endoscopic therapy. If any patient who has more than Hill's 1 and 2, that is Hill's 3 and 4, it means that the crural diaphragm is not intact and they will need surgical therapy. But if there is Hill's 1 and 2, endoscopic therapy may be offered. Now, one more important thing, that if you earlier in Leon Consensus 1, it was recommended that if you have LA grade C and D esophagitis, it is a definite indication that this is GERD, refractory GERD, and there is no need for any further investigation before proceeding to therapy. But now, even if you have LA grade B esophagitis, it means there is no need for pH-metry to proceed for therapy. Either you can go for surgical or endoscopic therapy. There are certain contraindications to endoscopic management. One is hiatus hernia more than 2 centimeters, CD esophagitis, peptic stricture, varices, and connective tissue disorders. So now let us go through the motility studies. There are several stratification by the motility studies. There are several components which we need to understand. One is acid exposure time. Other is reflux episodes. Third is symptom associated probability and SI index. Fourth is hypomotility on manometry. And fifth is MNBI, which is mucosal damage due to reflux on pH-metry and impedance. So if your AET is more than 6, it is a definite indication that this is a refractory GERD, pathologic GERD, and this needs intervention. If it is less than 4, it is normal. If your reflux episodes on 24-hour pH-metry is more than 80, it is a pathologic evidence of reflux. If it is between 40 to 80, it is inconclusive. And if it is less than 40, it is physiological. And both SI and SAP provide information for association of reflux events and symptoms. So now there are 4 phenotypes. If the patient is presenting with reflux symptoms or heartburn, one is erosive GERD, which means on endoscopy, you will get some evidence of esophagitis. Your AET will be high. Reflux episodes will be more than 80. SI and SAP will be significantly there. In this, you can do either endoscopic intervention or surgery, and obviously medical. If they are not responding to medical, either endoscopic or surgery. Other phenotype is that endoscopy will be normal, but AET and reflux episodes will be high. Your SI and SAP will be significant. In this, also you can do endoscopic intervention or surgery. Third is reflux hypersensitivity. Means your endoscopy will be normal, even reflux episodes and acid exposure time will be normal, but your SI and SAP will be positive. In this, you don't need any endoscopic therapy or surgical therapy, just give neuromodulation. And fourth is functional heartburn, which means everything will be normal. So now what to do? When to decide either endoscopic or surgical therapy? So if on endoscopy, if there is legs, LES, Hills 1 and 2, you go for endoscopic therapy. Esophagitis A and B, you can do endoscopic therapy. AET more than 6, SI and SAP significant, you can do endoscopic therapy. Mind well, in all these patients, you can also do a surgical therapy. So surgical therapy is indicated in those patients who have a crural damage, Hills grade 3 and 4, and a large hiatus hernia. There are also several patient-related stratification. First, those patients who are not willing for any PPI therapy, they are worried for long-term side effects of PPI, not willing for surgery. Now, age is also important. Suppose any old patient who has refractory PPI symptoms, you don't need any, who has refractory GERD and is doing well on PPI, you don't need any therapy. But any young patient who has a hiatus, definite evidence of GERD, there is no point in treating those patients with long-term PPI, better to go for surgery or endoscopic therapy. So this is our data in which we have shown that endoscopic therapy reduces the PPI dependence as well as improves the quality index of life. I would skip this video. There is this is ARMA, which means that we only ablate the mucosa and submucosa. What happens after ablation? That your contraction occurs, collagen deposition occurs, fibrosis occurs, and this further accentuates the cardiac notch. So there are several studies by our Indian authors also which have shown that there is significant decrease in DMISTR score as well as improvement in the GERD quality scores. So when endoscopic therapy, what to choose, either ARMS or GERDX, it depends on the volume of reflux. If it is a low volume, that is up to 80, you choose ARMS. If it is more than 100, you choose GERDX. Just 1 minute more. So coming back to our case, first case, this case is grade C esophagitis, impedance and pH and impedance is not required. Why not required? Because already grade C esophagitis, no need for anything. Just directly go for surgery because this patient has a large hiatus hernia. There is no role of endoscopic therapy. Case number 2, when endoscopy was normal, but only legs LES2. In this, we did a pH metry. Acid exposure time was high. Reflux episodes were 85. Manometry showed hypotensive LES. This is a case of non-erosive reflux disease. We'll go for endoscopic therapy or surgical therapy based on the patient choice. Case number 3, 24-hour pH, everything was normal, manometry normal. This is a case of reflux hypersensitivity. We will not go for any endoscopic or surgical therapy, only neuromodulation. So to conclude, vonoprazan is better than PPI, especially for acute symptoms and H. pylori eradication. Always before proceeding for any kind of reflux surgery or endoscopic therapy, especially lax LES 1 and 2 and LA grade A esophagitis, you should go for pH impedance studies. And AET reflux episode, SAP and SI authentically differentiate reflux hypersensitivity and functional heartburn from NERD and should be included in workup to judicially stratify patients. Thank you.
Thank you so much, Dr. Yogesh. I think that was a very nice presentation. As a diabetologist, we feel that every person in a family might be having diabetes. Similarly, I think GERD also is very, very common. Every family must be having one. So there must be a lot of questions, but I think we can take it at the end of the session. So now we have the next speaker in form of Dr. Gaurav Chawla, who is at Kanpur Medical Center, Kanpur, and sir is going to speak on management of GERD in pregnancy. Over to you, sir.
At the outset, I would like to thank Yogesh, and I think this is my 4th or 5th visit to this meet. So GERD spectrum, when we see in normal individual, we try to classify, as Yogesh told, whether it's NERD, whether it's functional heartburn, whether it's reflux hypersensitivity, or it's a erosive form of esophagitis. And they are prone for complications of stricture, Barrett's adenocarcinoma. Luckily, in pregnancy, we don't see much of the erosives or much of the strictures complication happening. So as it all depends upon acid exposure time and what is the reflux sensitivity, what is the symptom index, which was beautifully highlighted by Yogesh. And this classification usually we don't follow in pregnant individuals. So in pregnant, what is GERD is usually defined by a Montreal definition and classification of gastroesophageal reflux disease, which came in 2006. And it is a condition which develops when the reflux of stomach contents causes troublesome symptoms and or complications. So this is the definition which we follow. During this Montreal classification, it classified into esophageal symptoms and extraesophageal symptoms. Extraesophageal symptoms, because of lack of specificity, is not followed in pregnant individuals. We cannot demonstrate syndromes with esophageal injury also during pregnant populations. So typically, we have a symptomatic syndrome with typical reflux syndrome, which we followed in pregnancy to define GERD. Now, what is the symptom which patient will have two cardinal symptoms to call it as GERD? One will be a troublesome heartburn, which will be feeling a burning sensation in the retrosternal area, or maybe regurgitation, which is perceived as a flow of reflux gastric content into the mouth or hypopharynx. And usually, regurgitation is more common than heartburn. Mortality of any GERD in normal population or in pregnancy is very low. But why we are talking about is the quality of life is affected. They have low physical and mental well-being. It affects sleep, eating, drinking, and it may affect the overall well-being of the fetus also. So what is the epidemiology? Usually it's a very common in 30 to 50% of pregnancy and reaching up to 80% in some populations. And usually 17% will have both symptoms of heartburn as well as regurgitation. And it is present throughout all the 3 trimesters, and it is more in the 3rd trimester. So this was a German study in which they did a reflux disease questionnaire, recruited normal controls and pregnant women, and followed up throughout the pregnancy, 305 patients in female controls and 408 pregnancies. So what they found in controls, they had only 9.6% of GERD. In first trimester, it was around 26%. In second trimester, 36%, and rose to 55% in the 3rd trimester. And the severity of GERD also increased as the pregnancy advanced. So this is the pathophysiology of GERD in normal. It depends upon the peristalsis, which was highlighted by Zubin, where how is the esophageal body peristalsis, whether intact primary, secondary peristaltis, how is the GE junction, whether TLESRs are happening or not, infrequent TLESRs or frequent, and what is the normal gastric emptying. So based on this, what happens in pathophysiology in pregnant individuals? In pregnancy, it's multifactorial, usually having both hormonal as well as mechanical factors. So there is a progressive decrease in LES sphincter pressure because of increase in levels of estrogen, progesterone during pregnancy, and the highest levels of decrease in low esophageal sphincter at 36 weeks. And there is also, as the pregnancy advances, there is increase in intra-abdominal pressure is happening because of the enlarging uterus. And there is also ineffective esophageal motility, which leads to prolonged acid clearance time. So what are the treatment and recommendations? So the heartburn and regurgitation, which I talked about, has a sensitivity of 78% and specificity of 60% to diagnose GERD. And we should understand what something called critical teratogenic period, which is in the range of day 31 from the day of in a menstrual cycle date and to the day 71 from the last menstrual cycle. And what we follow is a step-up approach of treatment during pregnancy, which will I come to. Now, what is the role of gastroenterologist when we have alarm symptoms such as GI blood loss, persistent vomiting, dysphagia, chest pain, involuntary weight loss then? And usually when we talk about management of GERD, so we see antacids are there almost 100 years. In 1970, we gave antagonist, H2 receptor antagonist came, then PPI came, now PCAP came, but we cannot give alginates in pregnancy. PCAP has no data in pregnancy. So remaining things can be given in pregnancy, and I'll come to that. So first of all, first line of therapy is the lifestyle and dietary medication whenever we are suspecting GERD in pregnancy. Then if patient is symptomatic reflux, we'll stop it there. But if there is no response, then we'll do antacids. Antacids are the first line of defense. And then if there is no response to antacids, then there may be 2 options. Either give sucralfate or you give H2 receptor antagonist with antacid. If that is also not responding, then you can give PPI plus antacids and then assess the symptomatic reflux. If still not responding, then we can refer to gastroenterologist for evaluation. Any alarm symptoms, as I discussed, we require a gastroenterologist reference. So these are the lifestyle modifications which have been studied for GERD. when we should avoid fatty food, carbonated beverages, caffeine, citrus. We should follow frequent small moves. Losing weight will not be an option in pregnancy. And we should avoid alcohol, smoking, and sleep with head and elevation and sleep on the left side. So if you see, there have been data, but strength of incident and pathological conclusiveness may be equivocal or moderate in each of these cases. In pregnancy, what they studied, they found head of the bed elevation and lying in the left lateral decubitus position was very useful. And they avoid intake of food that may precipitate reflux, that has found to be useful, and avoid lying down within 3 hours after eating. So this was a meta-analysis. Are lifestyle measures effective in patients with gastroesophageal reflux disease? And what they found that 2 interventions which were found to be useful, head of the bed elevation and weight loss. That was and then they also found out the left lateral decubitation position that also helped the patients, and the dietary modification which we discussed that also had some impact. So this was a small RCT where they did acupuncture, and they found that women who underwent acupuncture therapy had relief of symptoms of GERD compared to not, and they have a better improvement in sleep patterns also. So now coming to antacids. Antacids which are available are containing calcium, aluminum, and magnesium. These are the second line of treatment of GERD during pregnancy. And 30 to 50% of women only require antacids to relieve heartburn during pregnancy and will never step up from this category. So is Mucain an appropriate medication for the relief of heartburn during pregnancy? So this is a moderate quality RCT, 50 pregnant women. They into 3 arms, either placebo or magnesium hydroxide plus aluminum hydroxide plus oxytocin. Then second group without oxytocin, and then third group with placebo. So they found that antacids with or without oxytocin produce similar relief from heartburn and increase heartburn relief compared with placebo with borderline statistical significance. And but we should mind out there was no relief of nausea or regurgitation, but heartburn was relief. And if we see the category of antacids, FDA has not categorized these antacids. What will be the preferred choice? Preferred choice of antacids may be calcium-containing antacids because they have beneficial effect on the treatment in the prevention of hypertension and preeclampsia during pregnancy. Magnesium sulfate also results in 50% reduction in eclampsia risk, and that also has found to be useful. And what is not recommended is antacid containing bicarbonate or magnesium trisulfate. Now coming to sucralfate, sucralfate can be the next pharmacological option. Usually in animal study, it has found to be teratogenic only if you give 50 times more. FDA has given a class B drug. There's only one RCT. More women in the sucralfate group experience relief of heartburn and regurgitation when compared to the lifestyle modification group. Now coming to the acid suppression therapy, H2 receptor antagonist and PPI therapy. So in H2 receptor therapy, we have a double-blind placebo-controlled study of ranitidine for GERD. So ranitidine 150 mg twice with antacids was given, and they found that it led to significant reduced symptoms compared to baseline and with placebo. Heartburn was reduced by 55%. So there was a consensus that has been reached to combine H2 receptor antagonist with antacid when symptoms persist with antacids alone. Now, among other H2 receptor antagonists, we have cimetidine, famotidine, and nisatidine. Cimetidine to be avoided. Why? Because it results in reduction of testicle and prostate size due to its androgenic activity in animal study. Famotidine has not been studied. So only ranitidine has found not to have any anti-androgenic effect on animals. Now, the safety of H2 receptor blockers in pregnancy, there was a meta-analysis. It was a good meta-analysis published in American Journal of Gastroenterology. So they found that 2,398 pregnant women were exposed to H2 receptor antagonists, and they found the odds ratio of congenital malformation was 1.14. There was no significant statistical difference in the risk of spontaneous abortions, small size for gestal age, and preterm delivery. Similarly, for PPI therapy, now coming to lastly to the fourth line, it is the fourth line of treatment of GERD in pregnancy. We have various PPIs, omeprazole, esomeprazole, lansoprazole, desolansoprazole, rabeprazole, and all can be given. But we should remember that omeprazole was a class C drug because of potential fetal toxicity based on animal study. All other PPIs are characterized as B, category B. So again, this was a meta-analysis seeing the safety of PPIs in pregnancy. So good amount of pregnant women were followed up with PPI in the first trimester and there were controls of unexposed pregnant women. The odds ratio for congenital malformation was just 1.12, and there was no statistical significant difference in the release of many major malformations, any spontaneous abortion or preterm delivery. So this was a landmark trial in which published in NAGM, where they used a proton pump inhibitor therapy in early pregnancy and risk of birth defects. So again, 5,802 pregnant women were followed, and they were given PPI 4 weeks before conception itself and followed till the end of the first trimester. And there were good amount of controls. So they found that there was PPIs were during first trimester was not associated with significant increase of any major birth defects in a cohort study of so many cases. So lastly, there might be some evidence that children exposed to PPI or H2 may have increased risk of asthma, but not very proven. So this is a summary which we have already discussed. So antacids, FDA classification is not there. H2 reserve category, all PPIs category B except category C. To summarize, I think typical GERD in pregnancy can be diagnosed with characteristic symptoms of heartburn and regurgitation and no need for further testing. If there are alarm symptoms, consider referring them to gastroenterologists. Step-up approach with lifestyle modification as the first approach. Pharmacological treatment may be beginning with antacids. We can, calcium-containing antacid will be the first, followed by magnesium. And if still symptoms surface, they may good idea to give sucralfate. If still it is not responding, H2 receptor can be combined with antacid. For lastly, only PPI to be given as a rescue mitigation for breakthrough GERD. So always, because of the ethical concerns, whatever data I present, there is always low quality of evidence because of the ethical concerns in this population. And thank you.
Thank you, Gaurav, for very lucid presentation. Now, next topic is a debate.
Sir, we will take questions, 1 or 2 questions. Somebody.
Any questions from audience? Etopride.
So prokinetics have some role in the treatment of GID, but predominant therapy will be acid blocking, either with PPI is the main line. But there has been a lot of meta-analysis where other drugs such as prokinetics or baclofen may have an adjunct role in PPI management.
Sir, this is just continuation with that. Suppose there are many patients who are comfortable only on prokinetics. So can we give it, and how long we can give Sintapro or glycosulfide?
So that's a very good question. So the question is that how long should we be giving prokinetics? And yeah, only prokinetics. So first thing is that prokinetics should not be given for a long period of time. Whether, even if we consider them as safe, like itopride, but they are not completely safe. Although they say that they do not cross the blood-brain barrier, but I have still seen EPS happening with even that. So first thing, it should not be given for long. Whether alone do they work? No, they don't really work for GERD. But if you have a patient who has a gastroparesis, that yes, they might be working for some time. We also have to understand that although in India we have all the prokinetics available, but they are not all of them are really being studied well or approved. In fact, in US, none of them are available except for metoclopramide. Rest all are not available. So alone PPI, alone prokinetics for GERD, no. Long term, definitely no. Give them only for short bursts, maybe 2 weeks, 3 weeks at max, and then bring them down.
In patients, my question is for Zubin sir. In patients with IEMs and absent contractility, is there any medical management role after surgical intervention for improving the esophageal motility? Any medication you advise for the same?
So if patients has an absent contractility that is very evident, I would want to know why it is happening, whether it is the severe GERD that is the reason behind it, which is seen in 1/3. But a lot of these patients, in particularly females, may have scleroderma. So identify that and we have to treat that. except that if we can't find any cause, just absent contractility, then medically you have to give them PPIs to at least bring down the acidic reflux to decrease the erosiveness. They would still be volume refluxers. So maybe adding up a prokinetic in this place might be useful. But again, give them for short time, give them only when they are at their worst days. There will be good days and bad days. Lifestyle modifications will work a lot in these set of patients. Rest, there is no good prokinetic which works very well for esophagus. They might work well for stomach or duodenum, but for esophagus, none.
Thank you.
Hello.
Sir, when nothing works, is there any role of using erythromycin as a prokinetic?
Erythromycin, sir, it can be used, it does work, but again, it doesn't work very well for esophagus. It can work good for, duodenum, in fact. So in fact, when we do sometimes enteroduodenal manometries, we can use erythromycin as one of the provocative tests to induce motility down. But for only esophagus, if you for GERD, I'm not very sure.
Mainly, sir, it has a role in gastroparesis rather than GERD.
Hello.
Last question, please.
Yeah, sir, I have two questions. One is for Dr. Yogesh. Sometimes we are seeing patient is done somewhere endoscopy. It is done under conscious sedation. I mean, only local anesthesia. And sometimes we do under short GA. We are seeing difference in the Hills grading. So ideally, it should be done under short GA to better
Yes.
assessment. And second question, sorry, for Dr. Jubin. I have one lady, old age, only complain of coughing. When we do endoscopy, significant secretion is there. When we do the barium study, retention was there, but not done time barium. Then in manometry, IRP was normal, but there is absent contractility. So should we do time barium for all the patient? Is there any variation form of the achalasia, or what can be the possibility?
So first answer to first question, Viral, is that you are absolutely right that whenever it is done without anesthesia, because of retching, there is false impression of hiatus. So at least whenever we are planning an endoscopic therapy in such patients, we should do again endoscopy before concluding endoscopic or surgical therapy, as well as I showed the video on Hill's classification. So we should at least see G junction in a retroverted position at least for 60 seconds. So that is the thumb rule. If in 60 seconds it is beyond LES Hills 2, that 3 and 4, then we should not proceed for endoscopic therapy.
One question, please. Yogesh, thanks for all the answers. Absolutely, the local anesthesia is not a complete endoscopy assessment. It has to be given some midazolam or some type of anesthesia for complete assessment. Coming to Hills 3 and Hills 4 lesions, when we do the endoscopy with previous symptoms, when already proved Hills 3 or 4, do we go for pH manometry, pH studies and manometry? How? I'm like, can we justify this?
So if it is grade C, B or D esophagitis, along with Lex LES 3 and 4, there is no need for pH metry. Okay, but LES 3 and 4 without hiatus, I would recommend pH metry.
Thank you.
So although the Leon consensus says what Dr. Yogesh is saying, in my practice, I still offer them a pH. You know why? Because I need to know whether patient's symptoms are really being caused by reflux or not. I don't want to operate on them and later on, so the patient might be just saying, I have burps, and we might attribute it to reflux disease. Whereas that symptom will not be corrected by when you do a fundoplication. So consensus doesn't say it is required, but practically I think if patient can afford it, it's better to do it.
So manometry is essential.
Manometry definitely you have to do it.
Definitely. Thank you so
And
much.
just a quick answer to the question you asked about that lady. Yes, type 1 aclasias can have a low IRP variant. In fact, they can IRP go down to as low as 10. So if there are other tests which suggest it is aclasia, you should treat that as aclasia and not anything else.
Conclude this,
Thank
I
you,
would request the
Yogesh.
chairpersons to be on stage for the debate. Thank you.
Hello. Next is debate between medical and surgical colleague. Whether we should subject the patient to long-term PPI with pill burden versus one-step solution of surgery with better lifestyle, but having a few post-surgical issues. I would like to invite Dr. Anand, our own Dr. Anand Patel from surgical side. Uh,
Morning to respected chairperson and welcome delegates. I've been given the task, generate a debate. Usually when the world of digestions, when the theory exhausts, surgical often clarify the situations. So I will try to emphasize what stands of the surgeons are over here. Well, if you see the pooled analysis of GARD, it's almost 15%. And it is well recommendation is that the standard treatment is take is PPI for 8 to 12 weeks of therapy. The indication of GARD treatments very well established between the medical as well as surgical. And it is been proven since long. If you type GARD surgeons versus the long-term PPI consensus, you will see the list of plethora of indication, when to do surgery, when to do long-term PPI. Even this is very simple with the availability of ChatGPT. Even the patient can also identify what is the best solution for him. And you can see that clear-cut indication they have given severe erosive esophagitis, Barrett esophagus, young patient who want to avoid long-term maintenance of medications. And when we have definitely abnormal 24 hours esophageal pH. But if you scrutinize, there are certain words are also there. Symptoms persist despite adequate PPI and dissatisfied with the PPI. I'll tell you practically those patients who are not PPI responsive, they are not better candidate even for the surgery. Well, then what is the question and debate? Here the question is symptoms control of with PPI and what is the long-term solutions. We are not talking about the patients who are out of surgical. We are talking about the patients who have a very well symptom control with a PPI. Can we offer them long-term solutions? Well, there is then go back to limitation of PPI therapy. If you see in a detail, many of the patients still that if it is a volume regurgitate patient, they are still dissatisfied with the PPI. There is no impact on non-acid reflux. Reflux will be still there and does not correct the mechanical defect, particularly LES incompetence and hiatus hernia. And there is also a risk factor for the long-term PPI use and very well established. They have a nutritional malabsorption, increased risk of osteoporosis and fractures because of depleted calciums. Kidney disease association is very well established and also increased risk of infection, typically Clostridium difficile and as well as the pneumonia. If you see again the literature also gives the plethora of complications, particularly probably speculated complication like cardiovascular risk factors by endothelial dysfunction and sometimes neuroendocrine tumors. We do not know the exact associations, but over a period of years of intake of PPI, this could be the long-term complication. And probably we have to counsel the patients who are on this PPI, and we should also discuss the long-term solution for them. Let's see the surgical arms. The surgery basically has two principles. It restores the lower esophageal sphincters and prevent both acid and non-acid reflux, as well as it correct the hiatal hernia. And the surgery is not the new. It's been carried out since last 5 to 6 decades. And over a period of 2 to 3 decades, it's been carried out through laparoscopy. But when we are in a debate, we need a data. Without data, we cannot produce. So when I was searching for the data, particularly meta-analysis and random RCT studies, I found these studies from the SAGES, where they have seen the surgical treatment of GARD, systemic review and meta-analysis. And if you see the 5 years of the data, mostly the surgery has been preferred because it normalized the pH. If we talk about long-term symptoms, over the period of 5 years, the surgery always favors over non-surgical solutions. But when we see a short term, definitely surgery goes higher, core higher. But when we see a long term, the quality of life in a PPI therapy as well as the surgical arms are same. What I want to add the point is surgery is not the harmful. Surgery is not carrying more complications that one should be afraid after 5 years. Well, the complication risk also I will cover. Another is Barrett esophagus. When I was searching for that, whether the surgery decreases the rate of, no, it is not. Even at after fundoplication, the patient is at risk of Barrett's and the patient should be on the surveillance endoscopy. So what I figure it out is definitely a quality of life as well as the symptom controls score much better in this group of arm. Then why there is so much of the patients are choosing PPI over surgery? What I call this is paradox in GRD management. If you see the literature, anti-reflux surgery is only 0.5% in GRD patient in US. Compared to Korea, when you see only 340 surgeries versus 3.1 millions on the medications. What could be reason for that? Maybe the patient prefer for easy and lifelong medication. Medication is easily accessible over the over counter. You don't have to visit the physicians also for that. There is a fear of surgeries and its complications. Probably physicians are also more comfortable on prescribing the PPI. And I would be sure that the physician would have referred for the surgery. Some complication could have happened and the patient would definitely tell the physician, why did you refer us? There is a limited surgical referral also. Just doing mere fundoplication does not abolish all the problems. GERD is not only the anatomical problem, there are a lot of other physiological problems are also associated with that. Upfront surgical cost versus cheaper PPI. I agree with that. If you compare the cost by cost, the surgical cost will be equivalent at the end of 6 years. So definitely PPI score better over there. And there is an uncertainty due to fear long-term RCT. Even we have very limited how to compare this group of the patients. Well, if I say that cost effectiveness, so definitely very few subgroup of the patients are there who are taking themselves. Over a period of years, they do require regular consultation. They do require regular endoscopies. Surgery is a one-time cost surgery, provides durable control, saves in long-term and reduce dependency on medications. Particularly, this is very important in a young person where you don't want them to continue with the PPI therapy. Well, I also agree there is a undesired surgical outcomes. But when you see, it's largely depends upon the type of surgery you do it. Over a period of years, when the PPI themselves has matured, we surgeons are also has become matured. Now we have a better armamentum with the pH manometry impedance. We now know which are the better candidate for surgical management. And all these complications are comparatively lower compared to your gain. So what I feel, PPI resistant GRD would have less than 50% chance of success. Even flawless fundoplication technically might go wrong. Reflux hypersensitivity is another entity which may not benefit from the surgery. A prior esophageal impedance monitoring is must if you are asking the patient from switch over from PPI to surgery. Surgeon expertise plays a very big role. Proper selection of the patients and technique of repair is a give you the crucial outcome. I think the best candidates are proven GRD with hiatus hernia, young patient, and they are PPI responsive and have the volume regurgitations. So absent of the symptoms free is not the failure of surgical outcome. Modern laparoscopic fundoplication is safe and minimal invasive. Complication rates are low and the recovery is quick. PPI symptom suppression only with a long-term risk factor one has to keep in the mind. And surgery correct the anatomical correction, it is the long-term cure. So the conclusion, anti-reflux surgery is often regarded as a last resort for the patient, but for the suitable patient, surgery is superior to the lifelong PPI. Thank you.
Hello. I would ask Dr. Amit Agrawal, senior gastroenterologist from the MGM College, Indore, to put the medical gastroenterologist perspective.
For giving me this opportunity for this debate. Most of the job is done by my friend Anand Patel. Because he has presented most of the slides which I have already prepared. But so So now I'm going to present a similar slide in which some different aspects, the different side from the coin. HB and GID is very common, present in around 15% of the population. Is a chronic relapsing disorder. This presentation is mostly suggested from some guidelines and most of the data proven. PPI have most of the PPI is relief for symptoms relief and as for American College of Gastroenterology, American Gastroenterology, PPI is the first line drug for the treatment for the chronic GERD. The ASEAN Indian consensus into 2020 also PPI is the cornerstone. Endotherapy and surgery is selective for few patients. When we see these guidelines, PPI is the most commonly prescribed medicine with ample of data. Please demonstrate this is very superior for controlling of heartburn and regurgitation. PPI have very good healing power, almost increased progressively for up to 8 weeks in more than 80% healing rate. Twice daily PPI more improved healing rate, and difference is more pronounced in patients which have severe esophagitis. In patients with erosive esophagitis, if we discontinue the PPI, it leads to relapse of the symptoms and the recurrence of the endoscopic lesion. That's why long-term PPI is needed. The meta-analysis of almost 10 RCT have shown recurrence of esophagitis around 3/4 of the patient in over a year. My friend Anand Patel have shown that long-term PPI have various side effects. This is just a myth with some evidence. When we see side effects like they have very cardiovascular side effect, stroke, vitamin deficiency, renal side effect, enteric infection. When we see data, the only enteric infection and Clostridium difficile, these are the two things which have proven. Other things, pneumonia, SIBO, cardiac, renal side effects, they are not statistically significant in long-term PPI usage. When we see long-term PPI use, in contrast to my colleague Anand, fractures, a major cardiac event, they are very rare. Renal side effects are also rare. Most of the time, Clostridium difficile infection can occur and sometimes gastroenteritis. Then another point which my colleague have discussed, long-term PPI versus surgery. There are various trials. One of the significant trial is Lotus trial, in which long-term usage of esomeprazole versus surgery in patient of chronic GERD. This is a very large trial. Almost 554 patients are included in this trial, and out of which 266 randomized for the esomeprazole and almost 288 for the long anti-reflux surgery. And the result of this trial, surgery have some mechanical complications like dysphagia, blood gas, inability to breathe. PPI are well tolerated. They have no major new long-term safety concern over the 5 years. So Lotus trial showed that long-term optimized PPI therapy is effective as surgery in maintaining GERD remission and while avoiding some irreversible surgical side effects. Another trial, Sopran trial, this is a very long, almost 12-year outcome trial. This is a Swedish multi-center randomized controlled trial. In this is one of the longest GERD RCT. This shows almost after the 12 year, the equal efficacy for the symptom control like reflux and regurgitation, but dysphagia and flatulence is higher in the surgery group as compared to the PPI group. So at 12 years, surgery almost 53% in sustained remission. Omeprazole is almost 40 to 45% effective. Surgery is statistically significant, little bit, but many patients in both arms relapsed and needed dose escalation or reintervention. So after 5 years, after the surgery also, almost 30 to 35% patient needed long-term PPI. Then other meta-analysis, they show there is no difference in the mortality or cancer outcome after the anti-reflux surgery. Surgery have relatively less symptoms in initial first 5 years, but more adverse event because this is the irreversible change. So conclusion, both are effective. So choice would be individualized. PPI is safer and surgery have some irreversible changes. And surgery, for my friend, surgery is not at all a cure because this is not an anatomical disease. This is some physiological aspect also. And despite of breast surgery, almost 3 to 5 years later, 1/3 of the patient needs long-term PPI. So when we compare the PPI versus anti-reflux, so Lotus trial, Sopran, various meta-analysis, JAMA registry, long-term cohort, PPI safety trials, they are almost equivalent, and surgery have some irreversible damage, and PPI long-term have no side effect except some enteric infections. So in the long term, PPI as compared to surgery are equally effective. Cost is very high in case of surgery as compared to the PPI, and adverse event is also equivalent in the PPI and surgery both. So surgery is needed in the patient who don't want to take PPI for the long term, but we should counsel these patients on the relative merits of the long-term medical therapy versus surgery. Means anti-surgery have some perioperative complication and post-op complication, as we discussed by my friend. Sometimes patient need conversion from lapro to open surgery. Perforation is also known in case of surgery. Pneumothorax, wound infection, herniation at the site of lap port, and rarely death can occur in perioperative. Post-op dysphagia, clotting is almost 5 to 35% of the patient, and almost 6 to 60% patient need anti-secretory drugs after the surgery, and almost 10 to 15% need reoperation surgery. Indication for surgery is erosive esophagitis, which does not resolve with the drug therapy, volume regurgitation, patients who do not need long-term therapy for the reflux, but they are explained for the serious adverse event. Patient with esophageal regurgitation, most of the patient will not relieve on the PPI alone. These patients definitely need surgery. Patient with structural abnormality like reduced LES pressure, hiatus hernia, delayed gastric emptying needs surgery. Non-acid reflux definitely needs surgery. So in conclusion, is my take-home message is PPI remains the main cornerstone, main foundation of GERD therapy. As per the long-term RCT, various meta-analysis, Lotus, Sopran, various trials, they have equal efficacy as compared to surgery. PPI offer flexibility, more reversibility, and safety, which are unmatched by the surgical intervention. Anti-reflux surgery is not definitive, as suggested by my friend. Registry and cohort data shows almost 15 to 40% recurrence by 5 to 10 years. In first 5 years, surgery is little beneficial, like after 5 to 10 years, almost 1/3 of patients need again PPI therapy. Many surgical patients end up back on PPI and sometimes require reoperation. Surgery carries some irreversible mechanical complications like gas bloat and dysphagia. So as per evidence-based clinical practice, PPI are safer as a long-term. Guidelines are suggestive surgery only in carefully selected patients or more motivated patients. And for most of the patient, long-term PPI is more safe, more programmatic strategy. In summary, surgery cost is more. PPI is availability is not at all an issue. PPI can be prescribed by any physician, but surgery requires trained staff, anesthetist, and a specialized doctor. In PPI, patients usually respond well even in the long term. In surgery, significant proportion of patients require PPI therapy even after the surgery. PPI have limited side effects, but surgery have some dangerous complications. Thank you very much. And
Dr. Anand, you have got 2 minutes for rebuttal if you wish to add something to your argument after listening to Dr. Amit Agarwal.
Please, Anand, be on the podium, both of you.
actually just a friendly debate because most of the things are clear.
When I was preparing the data, initial my mindset was that obviously the GERD surgery is a better. But when I evolved through the data, the moment I realized no, the long-term data says both are clear. Then I said medical management is better, but not. As the experience of more and more RCTs, more and more studies I have seen, let me tell you practically, 5 to 10% of complication can happen, accident can happen. But would you deny 90% of the people for deserving a good candidate? A person who walks in your OPD and says that I've been taking this PPI since last 10 years, and the first time after surgery, I could sleep properly. Otherwise, I have to sleep with two pillows. So that's a quality of life. I agree. The standards and the RCT says that most of the patients after 5 years or 10 years, almost reusable of PPI rate is quite high, 30 to 40%. But who knows, this group of the patients can be a reflux sensitive. They may not be the genuine patients. As I said in the beginning, as our maturity of understanding has increased, we have a pH impedance, we have a manometry. Surgical techniques have evolved. The data which says that 10 years, 15 years, the complication rate has also gone down. So I do agree, not all the patients require the surgery, but every physician should counsel if there is a long-term solution is viable for.
So, Anand, my question is, a patient who is doing well on long-term PPI. So should we continue him on long-term PPI? Suppose a young patient is doing good on long-term PPI. What we should?
I always believe the patient should earn the surgery. If the patient is happy with the PPI, I will put the pros and cons of the surgery as well as the PPI. If patient says that no, with the PPI, because the one has to judge the quality of life. If patient feels and I feels that by adding the surgery, I can improve her quality of life, my literally guidance would be on the surgical aspect. If my patients that I'm happy with the PPI, not every patient require daily PPI, right? So I would say, okay, once you feel that you need these options, then you come for the surgery.
This is more depend on the patient also, how the patient is motivated, how is he comfortable with these medications. Because most of the patient of surgery, the patient who respond to PPI on most of the surgery results are good in only these patients. And this is clear-cut data. After 5 to 10 years, almost 1/3 patient need PPI.
Primary endpoint should be quality of life, not the PPI. Any patient who asks me in OPD, sir, these two medicine, will I be able to stop? They ask clearly. Then I dig down which are the other symptoms she or he has, and I highlight those symptoms. A volume regurgitation might stop, but you probably need a PPI even after surgery. I cannot say that.
May I add, Anand? May I add? Findings in the endoscopy. Hills 3, Hills 4 lesion, moderate size hiatus hernia, gastric mucosal prolapse. While you're doing the endoscopy, retching, gastric mucosal prolapse, you are doing the retroview, your findings, you cannot ask everything from the patient. At least you have to decide from your end as well whether this patient will be better with the endoscopic approach or the surgical approach for a long time, quality of control. I mean, like one more thing, GERD is the mechanical issue. It is not a short a chemical issue. It is a mechanical issue because there are ligaments has been considered. Right? Weakening of the ligament.
I will agree with him. The GERD is more a physiological problem, and every time fixing the anatomy, physiology does not get changed. And there are subset of the patients. Okay, we have seen now almost 9 to 10 years of practice. We have seen that there are atypical symptoms and better not to operate on them. So we have to filter it out the right candidate.
Reflux patient, long-term PPI good, but in volume regurgitation, non-acid reflux, if patients are billing, surgery can be offered.
My question to physician, Dr. Agrawal and Dr. Dhananjay. Is there an MTD, a GERD, without having hyperacidity? Because PPI reduces acid secretion and mechanical repair does not reduces acid secretion. So both the treatment, they do not have any intersection anywhere, what I believe.
If GERD and reflux is not coordinated, means this is reflux hypersensitivity. So these are not a GERD patient. So these neither improve with long-term PPI, neither with the surgery. The psychological evaluation is more important for this.
So one should understand that if there is a GERD, there is a hypersecretion of acid also.
If we will do that,
then you need to address it with PPI, even though you should do the surgery. Dr. Patel.
No, I'll tell
There
you
is a catch.
Yeah. See, how do you prove there is a hyperacidity? The first thing, by the test,
UPA,
okay.
yeah.
And I clearly said there are subgroup of patients who are reflux sensitive. And in our practice, it is clear cutly says that those patients who are PPI responder are the best candidate for the surgery. Those who are not PPI responder, just you do the pH impedance, manometry, you rule out everything, then only you offer them fundoplasty.
If the symptoms is not correlated with the 24-hour pH monitoring, these patients will not improve.
I think this is endless debate. Better we conclude it right now, okay? Because of the shortage of time.
Thank you. Thank you.
Thank you, Anand. Thank you, Amit.
Thank you, sir, for the interesting talk. Next, we would have a panel discussion on unrelenting reflux disease patient. I would like to invite our panelists, Dr. Sudhanshu Patwari from Patwari Clinic, Ahmedabad, Dr. Chintan Kansagra from Prime Hospital, Rajkot, Dr. Gaurav Chawla from KMC Hospital, Kanpur, Dr. Rasesh Solanki from GastroPlus Hospital, Ahmedabad, Dr. Jyoti Ranjan Mahapatra from Peerless Hospital, West Bengal, Kolkata, Dr. Ekant Gupta from Advanced Gastro Hospital, Palanpur. I would like to call our speaker, Dr. Govind Makharia.
So my name is Govind Makharia.
So next speaker is Unrelenting GRD by Professor Govind Makharia. I think he doesn't need any introduction. As you know, he is a professor in gastroenterology and senior professor in All India Institute of Medical Science, New Delhi. His interest is luminal gastroenterology and human nutrition. Without telling further, I would request Professor Makharia to go ahead with his presentation.
Thank you, Dr. Mahapatra. I think it's a wonderful panel of gastroenterologists here. And thank you, Yogesh, for a wonderful meeting talking about esophageal and pancreatic diseases. I think last 1 hour we have been discussing the GERD and more complexity in the GERD. So let's simplify that what GERD is and how do we approach a patient who comes with a GERD-like symptom in our OPD. And while we do that, we'll also involve our panelists as we go along the discussion. The first that as we discussed last time, the GERD is a very, very common problem all over the world. And in the world, almost 1 in 7 person have a GERD or GERD-like symptom. It's so common disease. And coming to our own country, even about 10 to 15% of people, so again, about every 8th person in our country have GERD. So every family will have people having GERD-like symptoms. And people believe that this disease is more common in urban area like big cities like Ahmedabad, but it's not true. It is there in every part of our country, even those small towns or villages. GERD is as common as that in Ahmedabad or rest of the metro cities of our country. So with that, the GERD is a common problem. And as a physician, we are going to see patients with GERD almost every day in our practice. So how do we treat these patients very, very appropriately? So again, at the same time, GERD, as we discussed, GERD is a lifelong disease. And the course will be either continuous for some, but for majority of people, it will be mostly relenting, like mostly kind of come and go. So again, your treatment will depend upon, do they have continuous symptom or do they have a recurrent symptom? And it does affect quality of life. So again, GERD means what? two important symptoms, heartburn and regurgitation. And it can, as we said, heartburn, all of us will have heartburn. You have a heavy meal, have a dinner, will have heartburn. But unless it's troublesome, unless it lasts more often, it's not good. Good, like one heartburn everyone will have in the world, everyone, after a long, big dinner or something. But if they become troublesome, if they are more frequent, then it's called a disease, and this will require treatment. So, as we say, heartburn, the fundamental question is heartburn is because of GERD, like reflux, or there are some other causes of heartburn. And this will decide do they give PPI or surgery or anything else. So the first thing that the most common cause of heartburn is reflux disease. There's no doubt about that. But also there could be heartburn because of many other disorders which are non-reflux disease. And that could be any drugs can lead to heartburn. More importantly, can lead to any viral esophagitis, can have a heartburn. Eosinophilic disorders of esophagus can have heartburn. Echinacea cardia, some patients with echinacea can also have heartburn. And two other disorders which are functional disorders called functional heartburn and reflux hypersensitivity. They will also be a heartburn. So as specifically the heartburn, we cannot be sure this is because of reflux disease, the first thing. And more important, they can also have reflux patient can also have other disorders, like they can have a extraesophageal, they can have a symptoms of pharynx, symptoms of larynx, symptoms in the lungs, they can have, but they are uncommon. They are not very common. So why does heartburn occur? We discuss, and this is important to understand why this is a heartburn occur, because heartburn will occur because of multiple factors, but more important factor is looking at the G junction. The G junction is here because this part which is this looking at G junction here, and if there is any kind of abnormality out here, they will is one important factor, and the other factors including acid pocket, and we'll come back as we go along. Also, if there's any dysmotility in the esophagus, as we discussed in the last session, they can also lead to heartburn and other disorder that sometimes patients perceive heartburn because there's something in the brain, and that's for the functional heartburn that will also lead to heartburn. So as one important factor we need to understand is called acid pocket. So after we have a meal, there's a food inside in the stomach, and above the food in the fundal region, because the food that we eat, they go along the curvature, and the upper part of the fundus remain empty. And there, if there are parietal cells there, they produce acid. And this acid is above the food. And this acid is the cause of postprandial heartburn. So we need to also understand that how do we take care of this acid pocket. So as we say, GERD is a heterogeneous disease. It's not one type, heterogeneous. And need to segregate what symptom or what disease person has that will help us prescribing our treatment. So there are three types. One is called erosive, the most classic one. Those patients with heartburn have ulcers in the esophagus. They're called erosive esophagitis. This is the most evident symptom or most evident finding which confirms presence of acid reflux. The second one, there are a lot of patients, almost 2/3 of patients with reflux disease, they don't have any ulcer. You do endoscopy in them, there's no ulcer. They're called non-erosive. And third one, at the first time you find some patients, small number has a Barrett's esophagus, right? So as I said, the heartburn can be related to GERD, right? And heartburn can also be related because of other causes. I need to segregate why this is so. So what is a different GERD? Different GERD, as Yogesh said in the last lecture, the different GERD, we have three evidence. Number one, there should be erosion, right? In the esophagus, that's first. There should be more acid exposure. And third one, if there is a Barrett's esophagus. If all three are there, you're sure this is a gastroesophageal reflux disease, right? But if they're not there, they still are reflux disease, but the evidence is not great. And also remember that of all symptoms, what we treat, be it a cardiac symptom, be it respiratory symptom, be it a GI symptom. Heartburn is one symptom. If somebody has heartburn, you are right if you say GERD by 70% times. The only symptom which tells you diagnosis. Somebody has cough, you can't say this is a cardiac cough or this is a lung cough. And lung also there are multiple diseases, right? Somebody had chest pain, could be multiple regions. But somebody has heartburn, you're sure this person has reflux disease. That's very important to understand. So if you have a patient with a heartburn, so 30%, I said, are erosive esophagitis, right? 70% are non-erosive, and a small number are esophagus. If you get a PPI, what will happen? If you get a PPI, those have erosive disease, 90% will respond, and 10 will not respond, right? Those who have a non-erosive, 50 will respond to PPI, and 50 will not, because non-erosive is a heterogeneous. Some are because of reflux, some are not because of reflux. Therefore, only half will respond to PPI, half will not respond to PPI. And therefore, overall, of all patients with heartburn, 70 will respond to PPI, 30 will not respond to PPI. And Dr. Anand said that in this group, those who are PPI responsive, you will not like to do surgery, right? Because they're not like to respond to surgery. And these 30% are different disorders. They may not be GERD. They may be something else. They may be eosinophilic esophagitis. They can be functional heartburn. I will come back to functional heartburn. Or they may be reflux hypersensitivity. And give a perspective, before we come to panel, give a perspective of our own country. Look at our country have 140 million people in our country, 1.4 billion people. If 10% have GERD, it means our country has 140 million people with GERD in our country, right? Over 150 million, about 90 million or 100 million will respond. But large number, almost 30 million people have a heartburn, but cause is not reflux disease, right? So somebody has reflux doesn't mean it's only GERD. So what do we do if patient have a simplified? If patient comes to our OPD with heartburn, what do we do, right? And should we do endoscopy examination in every patient? But first start with that question. This is a fundamental question. That if I get a patient in my OPD with heartburn, should I do endoscopy? And maybe ask Patwari what would suggest.
Sir, if patient do not.
No, but please carry on. Please carry on.
Yeah. Thank you, Noble, for giving all of us this opportunity to discuss. And Govind, very interesting is that we cannot do endoscopy of all the patients. I would add one thing, because when patient comes to us with heartburn, there are two types of patients. One patient is who is PPI exposed, because most of the patients who come to us in OPD, they come for the second opinion or the third opinion. So many of them already have the endoscopy, or they are PPI exposed. I think these are the patients we do endoscopy only if there is a suspicion of complication. Second group is they come primarily for your opinion without any exposure to PPI. And in these patients, I think I will go for detailed history. If there is a high risk patients, if there is a history of NSAIDs for a long time, if there is a cardiac history who is on ecoscreen or the clopidogrel for a longer time, who has a habit of smoking, tobacco, or alcohol, I think our patient is a dysphagia, weight loss, or the GI bleed. I think these are the patients, definitely you immediately go for upper GI endoscopy. Otherwise, if it is a simple heartburn, I think definitely I would like to treat with PPI and antacids and see the response to the therapy.
Oh, we actually said that at the first time somebody comes with a heartburn, they don't need to do endoscopy. Unless there are regions, unless somebody has exposed to PPI and not responded to PPI. So moving forward, we won't discuss about it. We don't need pH metry to start with in every patient. pH metry is done only for some patients who do not respond. I will come back there. So simple diagnosis of GERD, somebody's heartburn, this is GERD. You are right by 70% times, and patient will respond to PPI. The first line treatment would be always be in uncomplicated GERD in the first time coming to our OPD would be just giving PPI and no intervention required. No investigation, just writing PPI. Once you write PPI, what else you do? One important thing to understand is to advise lifestyle modification. And the lifestyle modification have two principles. The first principle that is something which relaxes LES, some food items, some smoking. So anything which have effect on the LES functioning, this should be avoided. For example, giving them large amount of meal. Large amount of meal will lead to what? Increased intergastric pressure and more reflux as they lie down. And also avoid chocolates, fatty food, and citrus food like things. At the same time, smoking, one very important thing, that smoking leads to relaxation of LES, and therefore symptom will be more. So all those smokers should stop smoking. I should counsel to do that. And those who are obese, I should request them lose weight. The symptom will get better. So these are the general lifestyle principles which must be advised to every patient, that don't lie down till 90 minutes after meals, avoid fatty food, avoid chocolates, avoid carbonated drinks, and also lose weight, stop smoking. This should be practiced all across the board in GERD management. Now coming to treatment, we all know once you have a patient with GERD, you give 4 to 6 weeks of PPI. I'm talking about primary care first. I'm not talking about secondary or tertiary care. Primary care, 4 to 6 weeks of PPI. Assess at 8 weeks. If patient responds, stop PPI. Stop PPI and give them on demand. If the symptoms recur, give them on demand. Many patients will come that I stop PPI, my symptom recur back. So these patients may require a low dose therapy for long term, but most patients we must stop at 4 to 8 weeks of PPI. Which PPI? There are so many PPIs, but all PPI are equal. You can choose whatever you like. There's no great advantage of choosing one over other. And other new class of drug which is now emerging is PCABs, was called potassium competitive acid blockers, and there are many are available. 3 of them, top 3 ones are available in our country, and they are probably better, stronger compared to PPIs. The new class of drug, and why they're stronger, because there are 2 types of cells here. One is the active parietal cells on top. These are top one, the active parietal cells, so they are passive cells. And where PPI blocks only the active cells, but PCABs blocks both active and passive cells, and therefore they are more stronger. The stronger state blockers. But the question is that, let me ask the panel, that would you use PCAB this point of time in patient with GERD? At this point of time?
I think I am more comfortable with PPIs, frankly, rather than PCABs. And in last suppose 6 months, we are using PCABs. Not that they are much more effective than PPIs. So the experience is equal. Only thing we want the immediate effect. It is fast acting. So first dose of PCABs, it will be effective. So it gives faster relief. Secondly, very important, it does not have drug-to-drug interaction. So especially in cardiac patients who are on long-term other medications, I think PCABs may be preferred. But otherwise, I think I would be very comfortable with PPIs.
Gaurav, you have any addition?
PCAP, I will prefer if we have a first will be PPI only, but if it is a grade C, grade D, and PPI is not responding, that subset will be the thing with PCAP.
I think we rightly said that PCABs are not that expensive, but at this point in time, there is no recommendation to use PCABs in GERD. You use PCABs only in those situations where they're not responsive to PPI. So it's not good to start PCABs so early. Only in some patients later, one can use PCABs. But one indication for sure, Helicobacter pylori eradication, always PCABs, always vonoprazan or fexoprazan, not any PPIs. So so this is a symbol management. Now we have a patient who has given PPI, he didn't respond to PPIs. What do we do? What's called unrelenting or refractory GERD. The 2 different terms. Unrelenting means persistent symptom, refractory means symptom persists. So what do we do? Give them double dose. for 8 weeks, morning, evening for 8 weeks, and look for response. Majority of patients will respond, but there are some patients who will not respond. Then what do we do in them? That's called refractory GERD. Do we get more time or we'll stop here? I have more to discuss, but we can stop here. Okay, Yogesh is here. Do we have more time or we stop here? So refractory GERD, that despite giving 2 doses of PPI, morning, evening for 8 to 12 weeks, if symptoms persist, is called refractory GERD, right? And so what do we do? Now, somebody has a heartburn, PPI, no response. Double dose PPI, no response. The two things will happen. One, that this reflux is because of two factors, GERD-related factor and non-GERD factors. GERD factor means your PPI is not working, one, or there is some amount of gastric dysmotility. Therefore, the gastric emptying is not proper, therefore there's more reflux, or there's a esophageal dysmotility. That reflux is coming, but normal esophageal clearance is not happening. As discussed, that somebody has a poor esophageal peristalsis. Reflux happens, but there's no clearing. So these patients will have which are acid related, and their treatment in them would be that those who have in lifestyle, stop weight weight reduction, smoking reduction would be one important thing to do. Change PPI. One doesn't work, then use other PPI or add PCAPs. This point of time, for acid pocket, we can give alginate, and those who have a nocturnal breakthrough, I'll come back in a minute time. So these are GERD-related things. But more important, those who use PPI, it may be not reflux, something else. And what could be something else? There are two terms called functional heartburn and reflux hypersensitivity, and other esophageal disorders like eosinophilic esophagitis and other disorders as written here. But I'd like to focus on these two terms, what is functional heartburn and reflux hypersensitivity. So these are, for that, skip this one. So what is reflux hypersensitivity? Reflux hypersensitivity is something that there is reflux, but there's not acid, right? And the patient has symptom. There's no acid, but there's a reflux. This is called reflux hypersensitivity. And this is detected by doing a manometry and pH metry, pH impedance, right? So simply to understand, reflux hypersensitivity, there is a reflux in the esophagus, but this is not acid. It's called reflux hypersensitivity. Something like a crystal hypersensitivity. What happens in IBS? Rectum is hypersensitive, right? Therefore, the more frequency. Similarly, esophagus here is a hypersensitive, and therefore, this is called reflux hypersensitivity. PPI will not work here. In this patient, PPI will not work. And second term is called functional heartburn. That this is typical functional disease. That there's no abnormality. There's no acid reflux. There's normal manometry. There's normal esophageal peristalsis. But patient perceive heartburn. This is a functional disorder. So functional disorder called functional heartburn and reflux hypersensitivity are the patient which we diagnose after doing pH metry and also esophageal manometry and endoscopy, all three together, which are they're not common disorder, but some patient will treat that they don't respond to PPI. So these are functional heartburn. And what do we do in them? We do, just skip this. We do in them, we have to give central neuromodulator. You have to give either fluoxetine or venlafaxine to these patients, and they do better. So those are functional heartburn, and those are hypersensitivity. They will require central neuromodulator. Maybe ask panel, how common do you see these terms, these disorders in your practice?
So, functional heartburn, mostly when patients are anxious, patients have that kind of, once they come in our chamber with few files, we come to know that they already have exposure to multiple consultants, and many of them would be on tricyclic or SSRIs. But yes, those subset of patients, we can offer the alternative therapies and lifestyle modifications. Apart from that, it's very difficult for them to treat.
So I hope we were clear on that functional heartburn and reflux hypersensitivity are different disorders, small subset of patient, and they will not respond to PPI. And these patients should be referred to gastroenterologists for these advanced testing. There's some patient where you give PPI, but they get them in the night and come back to you that, doc, I have if I sleep, I have reflux in the night. What do I do? And this is a common problem. This is called nocturnal breakthrough. And nocturnal breakthrough occurs because of there is a efficacy of PPI goes down and there's a reflux in the night. And in these patients who respond, you ask them that don't eat your meal early in the night. Give at least 2 hours of gap between your meal and your recommended position for lying down, and eat small amount your dinner. You have a pre-dinner at the early part of the evening and have a small dinner. And you can add one other drug that's called, you can add one drug, it's called ranitidine or H2RA in the evening. So PPI in the morning and H2RA in the evening will do all the tricks. Although all those patients who have a nocturnal reflux or who have to get up in the night because of reflux, then small meal at the dinner, don't lie down till 90 minutes after meals or 2 hours before meals. And third one is to add ranitidine to them. Skip this. Those patients, maybe we'll come back on this question to our panelists. I'll stop here itself. Yes. So those patients who have a lot of cough, like they have a lot of what called phlegm in the throat, that sakharati rehti hai, because of this, they have a cough, they have a laryngitis. What do you in them? What do you do in them in panel? And do you see these patients, those having nocturnal extra-respiratory reflux?
I think apart from esophagus, there could be laryngeal and pharyngeal symptoms. There could be problems with ear, dental caries. So many symptoms can, even respiratory symptoms like bronchial asthma, aspiration pneumonia can be there. So basically, we get a lot of referral from the ENTs because of LPRD, laryngopharyngeal reflux disease. And that is the case when we investigate for GARD in those patients. So typical as well as atypical symptoms could be there.
Absolutely. So there's some patient with a reflux disease can have a reflux coming up to the upper esophageal sphincter and then aspiration into the lungs or in the larynx or in the throat or pharynx, and that's due to multiple such symptoms. And this patient should be given longer term PPI for 3 months, right? But everybody don't respond. Only 30 to 40% respond. This will not respond. I think I'll stop here and take any comment from panelists.
A couple of queries are there. For functional heartburn, we have to rule out eosinophilic esophagitis. If endoscopy is normal, should we take esophageal biopsies, and how many and from where?
Absolutely. So as I said that any disease of esophagus, any inflammation will lead to heartburn, right? So esophageal esophagitis is not uncommon. I think there's a miscommunication. It's not uncommon. We don't look for it. But all those patients who are not responding to PPI, once you do endoscopy, you find some lesion or you don't find some lesion, do biopsy. Say 5 centimeter above LES, and at least we do 2. We do at 5 centimeter above LES and 1 at mid-esophagus, and do multiple biopsies. And also please ask pathologists to please write in the form that please look for eosinophilic. Otherwise, most pathologists not ever reported. This is simply say there's some inflammation.
It's a second very practical point that all evidence is showing that lifestyle has a weak, like not strong evidence, but still all guidelines recommend to follow lifestyle. Patient doesn't want lifestyle to be followed. If we can give only PPI without lifestyle, some trial can be designed like that or something. What's your take? Because evidence is very weak for lifestyle, which we all follow.
I think it's very difficult to design a study and ask them somebody to stop smoking and do studies. I think the evidence is weak because it's very difficult to do RCT, randomized controlled trial. That somebody comes up, for example, Gaurav, you raised a very important question. Somebody says smoker, right? So what I do, as a doctor, I have to say, stop smoking. But I can't randomize that you continue smoking and you stop smoking. You can't do that. It's no ethical purpose, right? So therefore, there's no data. And whatever data is, there's no evidence because they're all small term cohort studies, right? So doing RCT to ask somebody to continue smoking doesn't make sense, right? Therefore, but is essential that lifestyle are very, very important, very important. Weight reduction, stopping smoking, small and frequent meals are, I think every patient with GERD should be advised. Because it's a long-term disease. These are not 3 months, 6 month disease. They are lifelong disease. And therefore, lifestyle may play a little role. We must do that. And last point that if I can go for my last slide, without one message I want to just pass on as my duty as a physician and a gastroenterologist, that PPIs are misused. And if you look data from all over the world, that every second PPI use is a misuse. Every prescription we write, be it IBD, be it chronic liver disease, be it pregnancy, be it orthopedic problem, be it a psychological problem, every prescription has PPI. I think we shouldn't do that. PPI, over half of them are misuse. So use PPI more judiciously. With that, I leave it to panel for any questions.
There is anything.
So one more question. When the patient is having reflux heartburn and the reflux, functional reflux, so when patient comes to, they have so many files, so many GI consultations. So which immunomodulation do you prefer in which doses? Because some of the patients, they don't even respond to the initially modulations also, like PCA or SNRI, SSRI.
I think SSRI better. Fluoxetine is a drug. A couple of RCTs available, and this was just at I'd say fluoxetine start with a low dose and build up, because the dose of fluoxetine or central neuromodulator for depression is much higher, but as a central neuromodulator, the dose is much lower. So even 10 milligram at bedtime to start with and go to 20 will be a good start.
Thank you, Govind. I think we will conclude, and because of paucity of time, we will conclude. No questions from you.
Thank you so
very
much.
much, Govind, and thank you, my panel colleagues. Thank you.
Thank you, sir, for sharing your insights. We will move to our next topic on the management of achalasia cardia in 2025. I would like to request our chairperson, Dr. Vivek Tank, Dr. Kavesh Patel, Dr. Deval Shah, Dr. Darshak Prajapati, Dr. Manoj Agrawal, Dr. Sameer Dani. I would like to welcome our speaker, Dr. Naresh Bhar.
Good afternoon. We're running late, so I'll try and finish off a little fast. I'll be talking about management of achalasia cardia in 2025. We all know that achalasia cardia is basically a kind of autoimmune degeneration of the nerves of the esophagus, leading to an abnormal motility of the body, the esophagus, and also a non-relaxing lower esophageal sphincter. And it can go from many phases, from early achalasia, where it can be difficult to diagnose, can be confused with GRD, to end-stage achalasia, where you have a large dilated sigmoid esophagus. So the diagnosis of achalasia, of course, you suspect on history, you do an endoscopy, you find certain features suggestive like a dilated esophagus or spaces, or the LES does not relax very easily. You need to force your way in. But whenever you have a non-obstructive dysphagia, you must suspect achalasia. Of course, you exclude strictures, neoplasms, EOE, eosinophilic esophagitis. But really, the most important test is high-resolution manometry, and you can supplement it with a barium swallow at times. 30 years ago, we depended only on barium swallows and a history to make a diagnosis, but things have changed since then. You've seen some of these pictures today and yesterday as well. You see that the first phase is the normal one, that you see there's a good esophageal peristalsis. But in the next three, you find that the LES is not relaxing and you have some amount of abnormalities in the esophageal pressures, either absence of motility or some amount of pan-esophageal pressurization, or in the last one, you can see that there is a lot of black here. That means there's a very thick spastic segment. So these are classified as type 1, type 2, and type 3 achalazias. Why is this important? We'll see. But remember that one of the most important things when you do an HRM is to diagnose achalasia, but also to tell you what type of achalasia it is. We said that manometry is most useful, but is it always dependable? The simple answer is yes, but remember 10% or more times you can have problems because we decide that something is achalasia based on a metric called IRP, and we find that the IRP can vary between manometric systems. Some systems accept 15 as a cutoff. Some systems need a cutoff of 22. So it's not that IRP is a sacrosanct figure. And earlier we had a speaker tell us that sometimes you can have a low IRP of 10, which can also be seen in achalasia. IRP varies if the patient has a study done when it's supine or standing. So you need to have a clear sort of thought process. What would you do? You suspect achalasia, but the IRP is normal. Moreover, you may not be able to get your catheter down into the across the G junction. So you may not be able to measure the IRP as well. And the last thing is opiate use is increasing in our country, especially in some parts of North India, and that can mimic achalasia. So the options are you do other adjunctive tests on HRM like multiple water swallows or rapid drink challenge, or sometimes use a solid meal. You can do a time variant study or something called EndoFlip, which Zubin kind of introduced it to us earlier in the day. In EndoFlip, what you do, you put a catheter with a balloon across the G junction, and you keep increasing the pressures by 10 ml of saline each time. And it gives you this kind of a three-dimensional plot, which tells you what is happening. For example, here is the EG junction there in blue, which is a narrow part where this pressure is the highest. So it can tell us a lot of things. One of it can be on the left, you can see the peristalsis, that is the antegrade contractions, which is normal. It can show retrograde contractions here, which is abnormal. It can tell us this, the narrowing at the G junction, can tell you the size, as well as what is called a distensibility index. And based on this, you can have a flip planometry where you can classify these diseases. So EndoFlip becomes extremely useful when you have a doubt in your diagnosis and you want more clarity. When it comes to treatment, our entire treatment is addressed at the LES. In our unit, we use all these methods to treat our patients' achalasia. Some we do a Botox, some we do a pneumatic dilatation, some we refer to our surgeons, and some we do a bone procedure. But remember, all of them only target the LES while we have no solution to the poor motility of the esophagus. So just to put in a nutshell, it's a degenerative disease. So whatever we do is only palliation of dysphagia. Earlier, we used calcium antagonists as therapy. Now that is gone to the graveyard. We no longer use it. Botox is used in certain patients. If I have a very old person who's had maybe a recent MI or a pregnant lady, I may use Botox. but otherwise we generally avoid that because the response is short term. So the two players are really endotherapy and surgery. Pneumatic dilatation is being practiced for a long time. We've been doing it for over 50 years in our country. And it's a simple technique that you use one of these balloons, pass it across the GE junction, inflate it, and it is a kind of very dignified Lord's procedure of, when you stretch the anal sphincter. Uncontrolled, but you do it, it achieves the aim of disrupting the fibers at the MES. The simple procedure, but look at the importance of the types of achalasia. When you have type 2 achalasia, it's pretty good, 90% on par with everything, all other modalities. But when it comes to type 1 or type 3, not a great procedure. Pneumatic dilatation also doesn't do well when in younger patients, males, or if you have a very dilated esophagus, or as I said, a type 3 achalasia. So then what are the other options? The other two options are surgery, a lap Haller's myotomy, or an peroral endoscopic myotomy called a POEM procedure. So that in a POEM procedure, we go through the mucosa, enter the submucosa, make a tunnel, go down to the GE junction, and then cut the muscle on the gastric side and in the distal esophagus, and then close the tunnel so that you have achieved the whole thing. What a surgeon can do, we've achieved it from the inner side endoscopy. When POEM first came, gastroenterologists fought amongst themselves, saying, is pneumatic dilatation better or POEM better? Some data showing that yes, POEM was far superior, though the numbers are not that bad. Certainly, POEM is superior to pneumatic dilatation, no two things about it. Then gastroenterologists started competing with surgeons and said, no, POEM is better than surgery, and the surgeon claimed otherwise. But a good randomized trial showed that POEM was not inferior to a lap Heller with a fundoplication in symptom control. So they're equally good, except that patients with POEM procedure had more GERD. But in type 3 achalasia, what happens? We know that pneumatic dilatation doesn't do well, but you find that lap Heller's also is not as good. So when you compare POEM and lap Heller's, POEM had better results with the type 3 achalasia as well. So if you compare all the modalities, in type 2, all modalities are reasonably good. Overall efficacy, LHM and POEM do reasonably equal. More reflux with POEM, no doubt about it. Though lap Heller's also has significant amount of reflux seen. So the question then, the endoscopist says, okay, I think we can reduce the reflux by reducing the gastric myotomy, not cutting the sling fibers and so on. Then they got even more aggressive and said, can we do a fundoplication as well during the same procedure called the POEM-F, POEM with fundoplication? Or others said, okay, if a patient has reflux afterward, we'll do an arms procedure or use a Gerdeck device to give them relief. So this is the new anti-reflux procedure. It's not yet got popular. Very few people do it. Of course, some of the champions are there in our country who do POEM. Dr. Bape and his group at Pune are pioneers with the Japanese. So the next question is, should we throw away this pneumatic dilatation? Do we stop doing it altogether? We know that in type 1 and type 3, the response are not so good. So you prefer to use some other modality. But in type 2, if the patient is slightly older than 40, 45, it's a female, and there's no great esophageal dilatation, you could consider pneumatic dilatation because it is cheap and can be done. The risks are not so great. A small risk of perforation less than 1% when you use a 30 mm balloon. But the recurrence of symptoms is there at 50% after 5 years. So if you choose your patient well, you can offer them this less expensive procedure. So finally, if you have a patient with dysphagia, you do an HRM. If he's got an abnormal IRP, you assess peristalsis, no peristalsis, one of these types of achalasia, offer them appropriate therapy. So that's the kind of algorithm. So surgical myotomy and fundoplication, still the gold standard. Pneumatic dilatation, fading, but can be used in type 2. POEM is a fast rising star and potential to be the one-stop shop for all spastic disorders. So ultimately, in your practice, you have to choose based on the type of HRM, patient profile, and likes, local expertise, and cost. So that is achalasia in 2020.
Thank you very much, sir, for wonderful lecture. We will proceed for the next lecture. Any questions from the crowd? So if there are no questions, we'll move on to next talk. Thank you, Chairperson. Sir,
Thank
please-
you, sir, for sharing your
Naresh, sir.
expertise.
Naresh, sir. Please, sir.
Now for our next session on the Chronic Pancreatitis Symposium, I would like to invite our chairperson, Dr. Harshal Patel, Dr. Varun Shukla, Dr. Deval Parikh, Dr. Sajjan Limbachia. I would like to call our first speaker, Dr. Daksh Khurana. He will speak on the role of fecal elastase in pancreatitis.
At the outset, I'd like to thank Noble Institute of Gastroenterology, Dr. Yogesh and his team for making me a part of this wonderful meet. The topic that has been allotted to me today is to talk on diagnosis of pancreatic exocrine insufficiency, a screening tool that is the fecal elastase 1. The objectives of this talk that I'll try to cover is defining what is exocrine pancreatic insufficiency, discuss the various tests of pancreatic functioning, and review the screening tool to aid in the identification of the pancreatic exocrine insufficiency. So patients with pancreatic exocrine insufficiency are often misdiagnosed, left untreated because of lot of overlapping of symptoms that I'll just come to in further slides of mine. A little introduction is abdominal pain. They just present you with loss of appetite and weight loss, which is unexplained, and nausea, bloating sensation, abdominal cramping. So these symptoms are quite overlapped with the other GI diseases. So this pancreatic exocrine insufficiency is quite misdiagnosed or overlooked at quite a lot of times. It can be attributed to the other GI diseases that I've just spoken about. There's a lot of misconception that it is just the fat maldigestion or fat malabsorption that is usually determining the presence of pancreatic exocrine insufficiency. So what exactly is exocrine pancreatic insufficiency? So there's a difference in the terminology, exocrine pancreatic insufficiency or pancreatic exocrine insufficiency, whatever you label it as. So it is a condition where there is an inadequate delivery, production, or activity of the pancreatic enzymes needed for normal digestion. So it is either of the three. And the pancreatic enzymes are the lipase, amylase, and the protease, although there are multiple others. It is just not the lipase that is the misconception here, and which is important for digestion of all the fat, carbohydrate, as well as the proteins, that is all the three macronutrients. So diagnosing EPI can be difficult. What is the problem here? As I said, signs and symptoms quite overlap with the other GI conditions, and then we tend to overlook this, underdiagnose it, and under-recognize it. It is seen in various disease states and conditions, and over the top, the diagnostic testing is also limited. So that is why diagnosing this condition tends to become a little more difficult. So what exactly pancreatic exocrine insufficiency is? The acinar cells and the ductal cells contribute to the 98%, 90% of the pancreatic tissue. And once damage occurs to these acinar cells, then there tends to be exocrine insufficiency. And there are multiple causes leading to pancreatic exocrine insufficiency. The front two runners in this list are the chronic pancreatitis, where there's a complete architectural distortion of the pancreas, and pancreatic cancer, which is mainly involving the head of the pancreas. And on the right-hand side, we have the other list of causes, that is cystic fibrosis, severe acute pancreatitis leading to loss of the pancreatic tissue, gastric resection or bypass, where multiple surgeries, complex GI surgeries are being done. That also tends to contribute to exocrine pancreatic insufficiency. Type 1 diabetes, where there's a lot of asynchrony in the literature here as well. So that also tends to cause exocrine pancreatic insufficiency, and then Crohn's and celiac disease also. So this is what I was talking about. A lot of patients tend to come to your OPD with excessive gas, bloating, flatulence, and abdominal discomfort. So we tend to overlook this condition by labeling these patients as functional dyspepsia or functional constipation, abdominal pain, which is predominantly postprandial, cramping, lower abdominal pain, early satiety, hyperactive bowel sounds, weight loss, which is despite adequate intake, changes in your bowel movements. What exactly are the changes that you look for? There's increased frequency, there's loose or unformed stool, large volume diarrhea, floating stools, increased urgency, presence of oil in the toilet bowel after bowel movement. It's just not steatorrhea. Steatorrhea occurs only when there's more than 90% of the loss of pancreatic tissue. So there's a whole gamut of symptoms that you should be looking at and diagnosing this condition early, when rather than just concentrating on in the fat in the stools. So coming to the background now, how do you diagnose this condition? What are the various pancreatic function tests? Now, there are a lot of direct tests and indirect tests here. The direct tests are more in the research purpose. They are cerulean-based and secretin-based tests, which are cumbersome, costly. So I will not be talking about them, and are limited to only various centers in the country. The indirect tests are the 72-hour fecal fat, the fecal elastase, and the breath test. Now, let me take a quick question here. 72-hour fecal, who would like to actually take a specific 100 gram of fat every day, which is difficult, and then store your 72-hour stool in your fridge, and then send it for a sampling? Is quite cumbersome, although the gold standard. So fecal elastase 1, and then the breath test, which I'll be concentrating upon. The various tests that have been, although a busy slide, but then concentrating on fecal elastase 1, it is highly sensitive for moderate to severe pancreatic dysfunction, correlates with the other tests of pancreatic function, and it is not affected by the enzyme replacement therapy. So allows to screen of many patients, widely available and easy to use test. But the disadvantages are it has a limited sensitivity in a mild disease, and it should, as the name suggests, it's an elastase concentration that you're measuring. You should not do it in a liquid stool sample. You should always perform it in a well-formed stool sample. So again, just telling you the same thing, the direct tests, they are invasive, time-consuming, costly, and limited availability. 72-hour fecal fat is cumbersome, requires diet control, specific 100 grams of fat for 3 days, and then collection of stool sample. It is unpleasant. Breath tests are again time consuming and affected by small bowel diseases. And chymotrypsin can also be measured, but has low sensitivity and is affected by the enzyme therapy. So based on this, what we are left with as a screening tool is the pancreatic elastase 1. It is a specific human protease synthesized by the acinar cells. It is immunoreactive elastase 1 that can not be detected by the other porcine or the bovine pancreatic enzyme preparations. In contrast to the fecal chymotrypsin, elastase is unaffected by the exogenous pancreatic enzyme replacement, and measurement of fecal elastase 1 in stool by means of ELISA is the best method for screening of pancreatic exocrine insufficiency. So what are the causes for low elastase 1 in your stool sampling? It is the reduced parenchymal cell mass. The most common diseases affecting that, causing that is chronic pancreatitis, cystic fibrosis, and pancreatic post-surgical resection of the head of pancreas. Reduced signaling in maybe in type 1 diabetes and celiac disease, ductal obstruction in chronic pancreatitis, and as I said, dilution, watery stool sample, fecal elastase 1 should not be measured because it will give you a false positive result. Luminal inactivation by small intestinal bacterial growth or Zollinger-Ellison, where there's hypersecretory state, that can also lead to low elastase 1. So this is a newer indication that is post-Sybil asynchrony, where there's type 1 diabetes or an upper GI foregut surgeries can lead to maldigestion and low fecal elastase 1. So as I said, you're measuring the concentration of elastase. So less than 50 is a severe pancreatic exocrine insufficiency, less than 100 is moderate, and 100 to more than 200 is normal fecal elastase. So overall diagnostic performance, it is a screening tool for pancreatic exocrine insufficiency for moderate to severe disease, and it determines the exocrine status in disorders not commonly tested by pancreatic exocrine for pancreatic, but which have a known association with this complication. So coming to an algorithmic screening performer, where there's approach to exocrine insufficiency, where you're screening, where there's a measurement of fecal elastase, you have a value of less than 100, 100 to 200, and more than 200, which is normal. 100 to 200 can be mild. And if we concentrate on the less than 100, if your imaging is also suggestive that the pancreas is diseased, and you have you have an asymptomatic patient with the normal micronutrients like vitamin A and E levels, you have to go ahead and confirm your diagnosis with fecal fat measurement. And if more than 15, it confirms pancreatic exocrine insufficiency, and then you can start pancreatic enzyme replacement therapy. But if it is your pancreas is normal on imaging and the patient is asymptomatic, then there's no role of enzyme replacement therapy. And if you have classical symptoms and low vitamin A or vitamin E levels, then it is moderate pancreatic exocrine insufficiency. And then you can give a trial of pancreatic enzyme replacement therapy in these patients. So in view of lack of time, I think I'll summarize here. It is a simple performance test that is non-invasive, and the diagnostic efficiency of the fecal immunoreactive elastase 1 assay makes it a satisfactory pancreatic function test for screening of patients with pancreatic insufficiency. Test appears to be useful not only in adults but also in children. And elastase 1 cannot be the gold standard. I'm not saying that, but it cannot replace the 72-hour fecal fat. But yes, it is a very simple tool that you can do it on your daily basis, which is unaffected by your enzyme replacement therapy, to screen for patients with early, moderate to severe pancreatic exocrine insufficiency. Thank you so much.
Thank you. Thank you, Daksh. Thank you. Please have your seat. We'll take questions in the end.
Any question from the audience?
No, we'll take it in the end after the completion of this
Let's move
entire
forward
session.
to our second speaker, Dr. Deepak Johnson from Panchkula. The topic of presentation is management of pain in acute and chronic pancreatitis. Over to you, sir.
So Deepak Johnson is from Kerala. He's a senior gastroenterologist there.
So very good afternoon. At the outset, I'd like to thank Yogesh and Team NIG for the opportunity for this talk. I'll be speaking mostly on how to manage pain in chronic pancreatitis. Well, chronic pancreatitis, as we know, is characterized by progressive, permanent, and irreversible damage to the gland. And at a microscopic level, there is chronic inflammation, fibrosis, destruction of the acini, the islets, and the ductal cells. This is a condition not so easy to diagnose in the early stage because getting a pancreatic biopsy is not an easy task in routine clinical practice. By the time the imaging shows all the telltale findings, the disease is in a far advanced stage. CP is considered as a suffering disorder because pain is the cardinal symptom and complication of chronic pancreatitis. It is described as a deep boring, a dull aching, or a sharp type of pain, upper abdomen, radiation to back, often worsened by meals. So the repeated episodes of pain impairs the quality of life, makes patients depressed, makes them eat less, leading to malnutrition, and some of them get hooked to opioid medications. Again, patients can have steatoria, diabetes, pancreatic cancer, and a host of complications, as we can see here. The two varieties of pain in chronic pancreatitis have been depicted by Aman et al. In their seminal study at least 25 years back. So type A, they have discrete episodes of pain which last less than 10 days, and they have long asymptomatic period of months or years in between. These patients generally do well. Type B, it's a chronic, unremitting pain, long-lasting with acute painful exacerbations in between. So these are the patients who often require surgical interventions. Pain in CP is multifactorial. 75% of patients present with pain as the very first symptom. 85 to 98% of patients will have pain at some point of time. The pain is more if the presentation is at a younger age and if alcohol is the etiology of pain. And since the pain is multifactorial, no single treatment is effective. And again, there are different schools of thought. Like one says that there is a burnout hypothesis that over a period of time, these patients develop a pain remission. But this does not happen in all patients. The natural history of pain in one particular patient, you cannot predict. Well, disease related, mostly related to inflammation, the enlargement of the pancreas, the fluid collections around the fat stranding, raised amylase lipase, all these are pointers towards inflammation as the cause. Ductal and parenchymal hypertension leads to tissue ischemia and drop in pH, and that definitely causes pain. So these are the patients with large duct pancreatitis, dilated duct stones strictures, where a drainage procedure will be very beneficial. Oxidative stress leads to inflammation. The neuroplasticity means the nerves around the pancreas undergo some changes, lowering the pain threshold. And long-standing pain leads to a sensitization at a spinal and peripheral level and a CNS level. Acute complications like inflammatory mass, cancer, duodenal obstruction, biliary obstruction, pseudosis can also be causes of pain, and some of this can be managed eminently by endoscopy. As we can see here, this patient has a benign biliary structure being treated by insertion of a fully covered SEMS. So any patient with CP who has elevated bilirubin and 3 times elevation of alpos lasting more than 4 weeks should be given the option of endotherapy. You can go for a multiple plastic stenting or a fully covered SEMS. The results are more or less same, but the number of interventions is less in the fully covered SEMS group, which is kept for up to 1 year and usually removed, expecting stricter resolution. This next patient has chronic pancreatitis, type B pain in between. Imaging shows a large fluid collection in relation to the posterior wall of the stomach. This is the pancreatic pseudocyst. So these fluid collections in chronic pancreatitis seldom have any necrosis because it happens due to the ductal leaks and disruptions. Again, these kind of complications can be very well treated by endoscopy. The cystogastrostomy procedure where you puncture the pseudocyst, pass multiple guide wire, dilate the tract, and multiple plastic stents, which are kept for up to 6 weeks. And these patients again get long-lasting pain relief. Again, unrelated causes like gallstones, peptic ulcer, mesenteric ischemia, small bowel strictures can also be cause of pain. Now, coming to pharmacotherapy, mostly we follow the WHO pain. Let us start with simple analgesics, of which paracetamol is the preferred drug. You can go up to 4 grams per day. Very safe, not much of side effects. NSAIDs in general not preferred because of the GI and renal toxicity. Now, if you want to step up, go for mild opioid analgesic like tramadol. It's a mild opioid agonist with some effect on the serotonin and noradrenaline uptake. You can go up to 400 milligrams per day, not much of GI side effects. Still want to go higher, you can go for morphine or levorphanol, but morphine patients may develop opioid dependence, constipation, and a lot of side effects. And this very old paper, which compared tramadol and morphine and found that for the same amount of analgesia, the GI side effects are much less with tramadol. So most of us use tramadol or any of these newer types for the management of chronic pancreatitis pain. Again, there are a lot of adjuvant drugs, tricyclic antidepressants like amitriptyline, SSRIs like fluoxetine, SNRIs like duloxetine, and gabapentinoids like Prega and gabapentin. Now, out of all these drugs, each different practitioners have their own choice of medications, but pregabalin is the only one that has been proven by an RCT to have benefit over placebo for managing chronic pancreatitis pain. Well, how does antioxidants help? Oxidative stress leads to inflammation and pain. In this good paper published by the Ames group in 2009, they gave a proprietary antioxidant cocktail for 6 months and found that there was very good pain relief. But a 2012 paper from the European group did not replicate this results. This may be explained by the difference in the patient characteristics. The Ames group had younger patients, more of idiopathic chronic pancreatitis, whereas the European patients had more of older patients, alcoholic pancreatitis, and a higher proportion of smokers. Again, the Ames subgroup analysis found that alcoholic chronic pancreatitis, the benefit of this antioxidant therapy was not that much. So what do the guidelines say? ACG says you can give antioxidant therapy with expecting a modest benefit, but the European guidelines do not recommend it. So if at all we are giving antioxidants, don't give a single antioxidant like vitamin E or methionine alone. Give an antioxidant cocktail which can be given up to 6 months. Well, any benefit with enzyme replacement? We know that patients who have exocrine insufficiency, there's a definite role for PRT, but does it help in pain management? This is less clear. So the theory is that when we eat food, the nutrients in our intestine release CCK releasing peptide, which triggers release of CCK. CCK stimulates the pancreas to secrete, and the pancreatic juice and the proteases come into the lumen and denature the CCK releasing peptide. This leads to a hyperstimulation in chronic pancreatitis because not much of pancreatic juice is coming to the lumen. So when we give pancreatic enzymes, they directly denature the CCK releasing peptide and thereby prevent hyperstimulation of the obstructed chronic pancreatitis patient. Again, this has been studied in multiple trials, and the meta-analysis found that 2 out of 6 trials showed benefit with PRT, and all the trials which showed benefit used uncoated preparations. The reason may be when you give acid-coated pancreatic enzymes, they are released more in the distal duodenum or jejunum, and thereby they may not have the effect on the CCK releasing peptide. So if you're give uncoated preparation with a high protease content, and 4 to 8 tablets 4 times a day. Again, people are going to extreme measures like doing jejunal feeds with a PEG-J or a direct percutaneous jejunostomy and found that pain relief is good, but these are not practical in our day-to-day work. Now, who should be considered for endoscopic intervention? If medical management fails, you can consider endoscopy Again, remember that a dilated duct with stricture or stones, but patient does not have pain, there is no role for endoscopic management. So you can do a plumbing work or a wiring work. So in plumbing, you can relieve strictures, take out stones, drain pseudocysts, stent duct leaks and dissections, stent biliary stenosis, and take care of duodenal stenosis. Wiring means most of the celiac plexus interventions come under the wiring group. So the essential treatment includes pancreatic sphincterotomy, dilatation of strictures, ESWL for stone fragmentation, balloon sweeping for stone clearance, and stenting. But you need to carefully select your patients. So those with larger chronic pancreatitis, single predominant stone in head or body are ideal, but extensive strictures, extensive calculi, presence of an inflammatory mass, these patients may not do well. Now, how do you do when there is a single dominant stricture? Single dominant stricture means there is a stricture with MPD dilatation 6 mm or above. Keeping a pancreatic stent for up to 1 year is the standard endoscopic treatment. So the ASG says you keep only one stent, which is the largest possible stent, preferably a 10 French stent. But you should not try a very forceful manipulation to put a 10 French stent. If a 10 French is not going, put a smaller one gradually upsize. And they do not recommend using fully covered SEMS because of delayed adverse events like de novo strictures, which has been seen in the fully covered SEMS group. So what can we do about stones? Small stones less than a 5 mm radiolucent might come up with a normal ERCP. but the success of a normal ERCP is less than 15% overall in CP. Larger stones you need to fragment. You can, with the ESWL, add ERCP for relieving the stones. If you're very daring, you can try mechanical lithotripsy. And if you have access to a cholangioscope, you can do a pancreatoscopy and a lithotripsy. So this is a patient with a dilated duct, radiolucent stone, a normal ERCP, sphincterotomy, balloon sweeping, stone clearance, and stenting. She had pain relief for at least 2 years. How effective is ESWL? One of the largest data is from AIG with more than 5,000 patients. They found that complete ductal clearance, meaning more than 90% clearance, they could get in 72.9%, and more than 80% had pain relief. So there are certain exclusions for ESWL, which we have already seen. Let's look at the success of endotherapy. Short-term pain relief, you can expect 80%. 60% may get 5-year pain relief. Multiple RCTs have compared surgery and endotherapy and concluded clearly that surgery is superior to endotherapy.
Please
You can
conclude,
use
sir.
endotherapy
Please
as the
conclude.
you can mind it. Last slide. To conclude, pain is part of chronic pancreatitis, multifactorial, so no single therapy is effective. You can try medical management, enforce strict abstinence from smoking and alcohol, selected patients endotherapy, surgery is better, but look for complications. Thank you.
Very
Thank
nice
you,
and
Deepak.
informative lecture.
Please have your seat on stage.
Because of less of time, we are taking a lecture at the end of third topic of presentation. To move forward to our third speaker, Dr. Praveer Rai from Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow. And the topic is medical management of chronic pancreatitis, pancreatic enzyme replacement therapy, antioxidant, neuromodulation, or all. Over to you, sir.
Very good afternoon. I'd like to thank Yogesh for this opportunity. So I think many of my slides have been covered with the previous speakers. So I think it's good. You should be able to revise those things and then memorize it better. So I will be talking about medical management of chronic pancreatitis, pancreatic enzyme replacement therapy, antioxidants, and neuromodulators. So chronic pancreatitis definition again is very, very important, and everyone needs to be aware of this definition. Fibroinflammatory syndrome of the pancreas in individuals with genetic, environmental, or other risk factors who develop persistent pathological response to parenchymal injury or stress. That's what chronic pancreatitis is. Medical management, very, very important, which everyone of us should reinforce to the patient, is stopping alcohol and smoking. Because if you give other drugs, give endotherapy, but patient doesn't follow this, they will not have relief. Vitamin D and calcium supplementation almost will be required in majority of the patients. Then we will touching upon pain management and exocrine insufficiency. So there is a recent guidelines by European Society for Clinical Nutrition and Metabolism in 2025. And what it tells you is that fat-soluble and water-soluble vitamins and minerals should be administered if deficiency is detected, one, or in case of clinical signs of deficiency. If you have definite signs, then you can choose to supplement this. And the primary clinical manifestation, as everyone is aware of, vitamin A, patient may complain of decreased vision, patient may complain of muscle weakness, fatigue, and vitamin D needs to be supplemented in these cases. Peripheral neuropathy, which many of these patients do complain, vitamin E needs to be introduced. Increased bleeding tendency, again, deficiency of vitamin K. So pain, as has been touched upon, is multifactorial, and that is the reason why a single modality does not work in majority. And you have to provide a blend of options. So active inflammation, altered nociception, which can be visceral, central, psychological, intraductal hypertension, tissue ischemia, and again, the complication, as Dr. Deepak has already shown you. So as I mentioned, stopping alcohol and smoking is very, very important. And then you have the role of analgesics, antioxidants, and adjunctive agents, predominantly pregabalin, which I will touch upon. So this is a WHO step ladder pattern, which again tells you that you are choosing drugs which have got lesser effect, lesser complications first, and then switching over to the the opioid, mild opioids, and then the strong opioid ones. So this WHO step ladder pattern is again very, very important. So antioxidants, how do they work? So if you see there is an oxidative stress in these patients, which is an important pathophysiological mechanism, there is free radical blocks exocytosis and SNS cells, which leads to increased autophagy, diverts of pancreatic enzymes into the interstitium, which leads to degranulation of mast cells, and inflammation is mediated by chemotaxis and pain. And what ultimately your antioxidant does, it reduces ongoing inflammation, SNS cell injury, and the resulting pain. And that's the reason why antioxidants are important. The composition of the antioxidants, if you see, you will have various combination of alpha tocopherol, vitamin C, beta carotene, theanine, and methionine. Mind you, the drugs that are available may have different composition. So this is again a busy slide. What is important here is this is a systematic review and meta-analysis published in 2015 of all the important studies published here. And if you see this study again has been shown earlier from AIMS, this showed that there was a response with antioxidants in the patients. And here the other study again from India, which showed that the response is not that great. So if you see this systematic review and meta-analysis, overall, there is a significant reduction in pain in antioxidant compared to placebo. So this meta-analysis tells you that overall antioxidants have got a role to play. The caveat here is if you see the alcoholics, this is subgroup analysis based upon the etiology. So alcoholics, if you see, the response was in favor. If you see the non-alcoholics, there was no significant response of antioxidants. Moreover, based on age, if the age is less than 42, the patients obviously didn't had good response. However, when the age was more than 42, the patients had good response. So age and etiology, that is alcoholic or non-alcoholic, will have a role to play whether the patient is going to benefit or not. So this again is important. 2009 study from India, 2012, 2009 idiopathic cases were 2/3. 2012, again, mostly alcoholic patients. In Bhardwaj et al., it was young, 30 years of age, effectiveness in reduction of pain. And in C, when you have an alcoholic patient's age more than 50, no effective reduction in pain with antioxidants. So the conclusion of this meta-analysis is 27% reduction in pain in patients with CP who had antioxidant compared to those who received placebo. Antioxidants effective for pain reduction in patients with alcohol etiology, but not in non-alcohol etiology. Patients more than 42 years show significant reduction in pain, but not those with a younger age. AGA guidelines again, ACG guidelines tells you that antioxidants may be given, though the benefit is limited. What about pregabalin? So pregabalin is a derivative of GABA. It inhibits the neurotransmission through the nerves. Mechanism of action is primarily the inhibition of calcium flow through the high voltage gated calcium channels. Dose, again, no one uses more than 300 milligram. However, this tells you that up to 600 milligram it can be used. This is a single, there's a Cochrane review available of the single RCT that was done, 64 patients. And they have 34 in one arm, placebo 30. Duration of therapy, mind you, is just 3 weeks. So for a disease which persists for many years, this study talks about pain relief only for a period of up to 3 weeks. And so that's the problem here. So this Cochrane review basically tells you that the pain relief was significant in those patients who had pregabalin compared to placebo. However, this was associated with side effects as well. So the conclusion was the short-term use of pregabalin decreased short-term pain scores, increases the adverse events compared to placebo, and decreased short-term opioid use. So mind you, this is again just 3 weeks. The clinical implication of the decrease in short-term opioid use and short-term pain score is again unclear. What about the combination of antioxidants and pregabalin? Again, study done from India. So if you see this from AIG, this is 2016 randomized controlled trial. It's in patients 42 in the treatment arm and 45 in the placebo arm. And again, they observed this for a period of 2 months. Following this, they also gave antioxidants in the placebo group as well for a period of 4 months. There was a reduction in visual analog scale, reduction in ISBK pain score, which is again used in research to determine the pain. Complete pain resolution, number of painful days was less. So antioxidant GABA, pregabalin combination. So this is a cocktail regime results in a significant relief in pain recurrence. So this is what the study tells you. Another study again from India. This study also tells you that if you give a combination of antioxidants along with pregabalin, there is a mean change in the visual and long scale and Isbicki's pain score, and change in the quality of life was not significant in this particular study. So combination of pregabalin and antioxidant significantly reduces pain requirement of non-opioid analgesics and the number of hospital admission in patients with chronic pancreatitis. It also significantly improves the overall patient satisfaction. What about pancreatic enzymes? Much has been talked of. So I'll just tell you how this works. If you have lower pancreatic enzymes, the release of GI hormones, stimulation of the pancreas, increased pancreatic ductal and tissue pressure, which leads to pain. And if you have restoration of increase in intraduodenal protease, this leads to a reduction in pain episodes. So there's a Cochrane review of enzymes for chronic pancreatitis, and this included 10 randomized trials, including 360 patients. And this study concluded that the pancreatic enzymes don't have a significant relief in pain. Pancreatic enzymes of pain, weight loss, steroid analgesic use, and quality of life remains equivocal, and the strong need of sufficiently powered randomized controlled trials comparing pancreatic enzymes plays for. Guidelines, what do they tell you? The ACG guidelines, we do not suggest the use of pancreatic enzymes to improve pain in chronic pancreatitis. Again, conditional recommendation, low quality of evidence. So we still need more evidence in this. So what is the expert recommendations? Again, smaller diseases may be preferred. 6-week trial, non-entry coated preparations. Doses again, 40 to 50,000. Mind you, this dose is again very, very important for each meal and half with snacks. Acid suppression may be required in majority of the patients. Again, the problem is as soon as you stop these, the patient again has recurrence. So that is the problem. So I'll not touch upon this. Pancreatic enzyme exocrine insufficiency has already been talked of. And so to summarize, antioxidants for pain and chronic pancreatitis is effective, but benefit is limited. Pancreatic enzymes not recommended for pain and chronic pancreatitis. Pregabalin in combination with the antioxidants may be beneficial. Fecal pancreatic elastase is the first-line test for pancreatic exocrine insufficiency, and PERT in adequate doses is needed to achieve the benefit of enzyme deficiency. Again, I have not touched upon diabetes, but please remember that diabetes in patients with chronic pancreatitis, you should be giving metformin to all these patients, and insulin is needed if hypoglycemia is at risk. Thank you.
Thank you, sir. It's a very enlightening session. In view of constraint of time, we would like to take 1 to 2 questions.
The plastic stents provide more resolution of pancreatic stricture, the duct stricture resolution. This is what my knowledge is. Thank you.
So I think for PD strictures, single dominant stricture, there are 2 options as you mentioned. You can choose either to place multiple plastic stents, vis-a-vis metal stents. Again, the data still is not very clear, because the problems with the metal stent are, one is it has to be a fully covered stent. There is no doubt about it. You have to use a fully covered stent. And these fully covered stent are typically available by the name of bumpy stent in the form that the compression of the side branches is prevented. They should keep on draining. So that's what you need to use. The problem with these stents is there is a high incidence of formation of a de novo stricture. That is the problem. So you may have a stricture, resolution of structure on after you pull out the stent, but you may have a new occurrence of a stricture in the pancreatic duct. So we have published a small 11-patient study, again, Indian Journal of Gastroenterology. And the other problem is the migration. So these are the 2 main issues of using a metal stent in patients with chronic pancreatitis.
Beautiful. Thank you so much.
So before we, can we conclude this session with the chat? So before we move to next session, there is a small announcement that after this we'll be having lunch Now I completely understand Sunday noon is very dear to everyone, especially after lunch. But today, for the sake of academics, please be here with us, motivate us. They are going to be very informative sessions, post lunch also. And don't forget to take your book on hospital management, which is being given by the organizing committee. Thank you.
Thank you, sir, for the excellent session. Now we will have a debate on chronic pancreatitis. I would like to invite our subject experts, Dr. Sandeep Laktakia, sir, from AIG Hyderabad, Dr. Vaibhav Sutaria, sir, from Professor and HOD IKDRC Ahmedabad. I would like to invite our speaker, Dr. T.S. Chandrasekhar.
Let me invite Dr. T.S. Chandrasekhar, our senior colleague and a good friend from Med India Hospital, Chennai. He is the director, owner, everything of that hospital. Just short of taking over Tamil Nadu. He is speaking on chronic pancreatitis endoscopy side, endoscopic management.
I initially thought Yogesh is a good friend of mine till he gave me the debate that chronic pancreatitis. He was insisting on that. I know it is a very weak case to fight. But when you have a very senior surgeon, very sincere, dedicated Sanjeev Haribhakti is going to talk. And most of the data is available. Surgery is better than endoscopy. If you are really pressed for lunch, we can close it also. Anyhow, having given the job, I should talk about what is it. So endoscopy versus surgery. My previous speakers also know. Sometimes when you are going a weak case, the lawyer also wins over. Let's see how much I am going to perform here. 30 to 60% of the patients have uncontrolled pain with the medical treatment, whatever Pravir Roy or other people discuss, deeper discuss. That means there is a case for intervention. There are only two players. One is surgery, and years later only the endotherapy care. That itself shows that we are fighting with a giant who has got established practice for surgery. Now there's a famous landmark article, all of you see that 2007 came in NEJM, clearly indicate that's from Amsterdam group, and with the Kees Hubrecht being the endoscopist under whom I got trained in the very early 90s before the study. And it clearly indicates that came in NEJM. It's not moving now. Right. So the results are say surgical drainage is most effective. But go into the detail of the study, it is a very small sample. I think you should all agree with me that. And the stent with no side hole. The Amsterdam type of stent is the one without side hole. That was discovered by Kees Hubrecht. It's called Amsterdam type of stent. So no side holes. And not only surgeon did the drainage, they opened the capsule also. That means it becomes a non-comparative study. If you go really detail into that, and they themselves were clear, so non-comparative. So they themselves suggested that I have some hope here now. Sanjay must be very happy that I am coming to the debate. Less expensive disease, endoscopy treatment may still be available. This is 2007. And after that, there is a randomized trial called ESCAPE trial, came in JAMA. Again, it clearly indicates that the early surgery, the pain relief is better, the size of the number of patients relieved also better with that ESCAPE trial. And the third one was the very important one, is another randomized trial. Again, you see that only 22 patients were there. And that's also in favor of surgical management, but they recommended multidisciplinary decision and individualized for each patient. So I have some scope for debate here. It is not the only surgery, even though it's a gold standard. And another study I want to quote here is, so far I was dealing about the randomized RCT only. Now systematic review with the meta-analysis there. 3 were randomized meta. Very difficult to do the randomized control trial. The surgery versus endotherapy. And 22% of the patients for endoscopy moved to surgery. Again, it's a big blow for me to go for the debate here. I was searching for another randomized systematic review with the meta-analysis. They also clearly said it's a very busy slide. You don't go through that, but only clear message is surgery is better than endotherapy. But if you look at the number of cases, everything less than 50, 20, 30, and nothing more than 100. So there can be a sample bias and bigger selection bias. Now this slide will clearly tell you that my opponent will be very happy because it clearly tells the surgery is time tested, longer follow-up, universally available, one-time solution, cost effective. An Indian scenario treats associated malignancy too, and evidence is more supportive, and he's an established player now. My side is very weak, that's why I was angry with Yogesh. Had he given me GI bleed, I would have thought of endotherapy is better than. But here, recent entry compared to surgery, short follow-up, less widely available, multiple intervention needed. That's why our surgeon always will mock at us, oh, we have to do 3 times, 4 times, what is this? I do one surgery and cost depends on the institute. Malignancy, you can do only palliative and evidence is evolving only. How can you fight with that? So I was just reading a newspaper. Came to my mind. The established player like surgery, like Sanjeev, winning the national award is not the news. But the most important is the evolving endoscopy, the Vikrant as he is winning along with the the senior surgeon is a news. So I may place myself here. So how I am going to argue, let's see. The outside will look like surgery can be undertaken in all cases. My colleague says, Sanjeev, no need for endotherapy. I surrender that. Debate is not needed, but it's not the case now. Which is better, endotherapy versus surgery? It's not the question now. Which is the best for this patient? That is the debate. Then I have some scope to discuss. Let's see. The fact that so many surgeries are been discovered, found out, practice means there's no one-time solution here because pain is, as already Pravir and Deepak said, multifactorial. It is not difficult to confine with one surgery. They also struggle a lot. It's not an easy surgery. In fact, yesterday, my surgical colleague was doing phrase procedure, started with, it took almost 3 hours also, sometimes it takes, because he had an associated portal hypertension. And endoscopy also not that simple because you see the spectrum. But most of the studies didn't have the advanced endotherapy like spyglass, cholangioscopy, peroral, and the laser lithotripsy. So we cannot compare the latest advanced endotherapy versus this unless we do RCT right now, 2025, we have to do that. So I have a point here to tell you that. So CP means chronic pancreatitis heterogeneous disease, different approaches and personalized algorithm is needed. If my colleague agrees with me, then I have a point to discuss because appropriate control arms. Now we have the advancement has happened so much in endotherapy. Not surgery is not as advanced, maybe already established, so there is no need for that. The rationale for this positive high quality RCT is still lacking and the guidelines are inconsistent. The German group says surgery is the gold standard, but European society says step-up approach. I am going to use the word here, step-up approach. That is my very important keyword. I'm glad that none of the previous speakers used the word step-up approach. This is what needed for chronic pancreatitis. My argument is. My surgical colleague is going to tell me surgery is better because superior long-term outcome. Better for painful obstructive lesion. Effective for severe, serious, and advanced cases. Where are you now? My argument will be, it is less invasive, it is cost effective. For a specific patient, endotherapy does wonder and is suitable for small and radiolucent stones. So why to have AK-47 to kill a small ant? You reserve your armamentarium for a very serious, complex disease. So I do have a role. I was searching for the literature thoroughly. For the preparing debate, that takes a lot of time, almost a week. So this study, I recommend strongly all of you to go through this paper. Controversies on the endoscopic and surgical management of pain in patients with chronic pancreatitis, pros and cons. That became very handy for me to discuss here. It says very clearly, somebody already pointed out plumbing theory and wiring theory. So just because you drain it is not going to, pain is not going to subside. Even the surgical group, 80%, beyond that, after 5 years, 10 years, the pain returns also because of the various other mechanism, and wiring theory is because of the lot of neural plexus and altered threshold also there. It's a beautiful diagram. You must take a photograph how the drainage procedure helps to relieve the pain. At the same time, a wiring theory also, the art, even without any painful stimuli, patient can get pain because of the altered threshold and altered nociceptive sensation. That is a very important factor. I want to draw your attention. All pain cannot be cured either the surgery alone or the endoscopy. There is a different mechanism also operating. So it is going to be a different way. There are patients who will be unfit for surgery. I think my colleague will also agree with. So we have an alternative also. And sometimes the surgery is very good, but too much for a too little problem. Suppose I have got a clear-cut pseudosis. Why do you need a surgery? I can reserve the surgery at a later date. And surgery sometimes too early. I've seen a patient, young patient, got operated. The disease was evolving. And after 2-3 years later, again started having pain because of different mechanisms. So I always wait for the step-up approach when particularly the evolving. The argument also there, young patient early surgery is better because they don't become addiction also. I think you have to balance it, and particularly young female before marriage, I also reserve endotherapy. I will reserve the surgery. I will go for endotherapy to buy time. That is also very important. And once the disease is evolved, and then the surgery would be. Endotherapy sometimes as a guiding pre-test to assess surgical success. I place a stent, the patient get relief. Then I also know that the patient at a later date, he may be benefited or he may be benefited by surgery. Recently, I had a patient, ductal dilatation, and we did the stenting, my colleague, and the patient did not become all right. I was wondering what is the reason. The tail portion, we carefully looked at the different imaging, advanced imaging, we found it, tail had a very inflammatory mass was there. So then we had to remove the stent, we went for the surgery, and that's how you can see the assessment, endoscopy to tide over crisis and select a choice of endoscopy. I just want to let all the patients should undergo side wing endoscopy before either surgery or endotherapy, because sometimes stone may be in the ampulla of the papilla, and you relieve it, the patient becomes all right. And during follow-up, he did not require surgery. This ERCP will clearly tell you that the stones were smaller, 5 millimeter, less than 5 number, confined to the head of the pancreas. Then we relieved it with the stone removal. And this is another case where pancreas ascites. If you ask me, if one case I would not like to refer to surgeon is a pancreas ascites. Surgery will be difficult, and you see the leak has been identified, the stone has been removed, and the patient did very well. I'll take one more minute. And the pseudosis, if it is non-complex, I would rather prefer it to drain it with the endotherapy. So this is again a very important thing. So when do I refer to surgery? My question is, I have to answer this complex disease, suspected malignant mass, chronic refractory biliary stricture, inflammatory mass not resolving, duodenal obstruction, associated segmental portal obstruction, you want to do surgery for that, refractory or unsuitable for endotherapy. when do I prefer to do endotherapy is pancreatic ascites, single dominant stricture, impacted PD stone within the papilla, multiple small size stone confined to the head of the pancreas, simple pseudosis accessible through transpapillary or transmural route. That is where I now I would like to know from my learned colleague, Dr. Sanjeev Haribhakti, when does he refer to endoscopy at all? If so, if he says even one indication, I wonder, I am the winner here. So with this, I am a very happy thing. Who is the winner? Patient should be the winner. I always take combined rounds and discussion before any procedure. And we are comparing apple versus orange. Both are good in their own right, and both are needed at one time or other. That is what is needed. And my preference for trials is I choose straight away for endotherapy certain cases, straight away for surgery, and step up approach when I am not able to decide. Surgeon also said, why don't you try endoscopy? So you must have 3 arms for the trial. If anybody want to do the multiple clinical trials, they are welcome. We have started this recently, early biliary stricture, evolving disease in adolescents, small duct stage. Again, small duct is very important. And conclusion, the choice of treatment should be individualized based on the patient's specific condition preference, and there should be ongoing research. We are one of the large number of cases we have in India. The small centers also do volume little bit, but we can't, all of us can combine and multiple. We have started a group called the Pages, Pan India Gastroenterology Research Study Group, with the permission of the organization chairman, I'm telling those who want to join also. Now, I'm a very happy endoscopist. You know why? I have a senior surgeon like Sanjeeva along with me traveling all the time. I always discuss with him. Whenever we have a complication, we both of us discuss, you know what happened, you just video will show you and you will enjoy it. And sometimes whether to do endotherapy or surgery, conservatively it also gets become all right. So the step-up approach, so I'm happily traveling along with my surgeon. I don't overburden him. I don't overburden him because he's a very learned surgeon. And they meet a complication now. The complication they are seeing now, both of them are discussing. The panel discussion going on. Endotherapy or surgery to be done. And sometimes they're not able to decide further. While they are waiting for that, the complication disappears. So sometimes conservative management also useful. So ladies and gentlemen, very important is the patient is the winner. And thank you very much for this. Let us listen.
I'd like to invite Sanjeev Haribhakti, who is director at Asian Hospital, clinician, great teacher, and I think he does not need any introduction.
Thank you. So, good afternoon, and at the outset, with due respect to my senior colleague, friend, dear respected friend, I was just looking at the program, whether I have been given the surgical topic or Dr. Chandrasekhar has been given to favor surgery, because he's almost covered so many things and has almost conceded this debate. So let's just give a perspective, to introduce. We know that it's a very diverse condition, chronic pancreatitis, with varied etiology, varied pathomorphology. But what I would like you to bring to the notice is that the pancreatic stones are very different from the CBD stones. They're hard, they're spiculated, they're impacted, and often, most of the time, they are associated with stricture, sometimes inaccessible, because they are, as an endoscopy, you will see they are distal to the stricture, but in the pancreatic duct perspective, they are proximal to the stricture. the necrosis, fibrosis pattern, the strictures are so dominant, so hard sometimes, and most of the times there are multiple strictures, not just one stricture. Almost 80 to 90% of patients will have stones along with strictures. So it's not just the stone disease we're tackling stones and strictures. And the indications is very clearly brought out already, that pain relief, which is multifactorial. And here we are talking about dilated duct disease. We're not talking about the small duct disease, because in that small duct disease, neither the endotherapy nor the surgical therapy works well. So we are discussing dilated ducts, pain, and discussing endoscopy versus the surgery. So any debate, we should first look at the evidence, and especially RCTs, level 1 evidence, meta-analysis, reviews. Safety is the second important part, cost effectiveness and applicability in our own area, India. How much is the applicability? So let us start with the evidence. The first evidence paper was published in 2003, endoscopy versus surgery in chronic pancreatitis, a 5-year follow-up, complete absence of pain, surgery 37% versus 14% endotherapy. And they suggested endotherapy superior, but in both the arms, the results were not that good. Of course, this was a, we're not going to discuss the merits or demerits of each paper, but just we'll go through the evidence in the literature. So 2007, Dr. Chandrasekhar talked about this paper where they already used ESWL along with ERCP, not just the endotherapy. And there were, small number of patients in each group, but it was a comparative study. Also showed that surgery was superior to endotherapy in terms of pain relief. You see 75% versus 32%, which was statistically significant. Number of procedures much higher was required in endotherapy. Technical successes were higher, and complication rates were also higher with endotherapy. So there are some problems with ESWL, that the fragmentation rate is about 60%, especially when it is associated with strictures. And for stone sizes more than 10 millimeters, it is difficult to clear them with ESWL sometimes. Stone recurrence rates on a longer term follow-up are quite high, and adverse effects, pancreatitis, is also significant. And pancreatic ESWL machines, how many of them are available in our country? That is a question that we need to ask. And the renal lithotripsy are not that effective in the pancreatic lithotripsy. A surgical drainage was by far more effective. The early results showed with patients with chronic pancreatitis with obstruction. So this is the Cochrane review. The Cochrane review also showed that not just the pain relief was superior, but even the morbidity and mortality, when they were compared between the two groups, they were similar between the two groups. This was the ESCAPE trial that Dr. T.S. already alluded to, which compared, it was a randomized trial from the Netherlands, the Dutch pancreatic study group, which compared the endoscopy and the surgery and showed that surgery was definitely a better and median number of interventions were less. This was a study with a long-term outcome, 79 months follow-up, so more than 6 years follow-up, and they showed that almost 47% of the patients in the endoscopy group eventually underwent surgery. So on a longer-term follow-up, a procedure which has less than a 50% success rate in a benign disease, we have to question the real need of that procedure for all the patients. Repetitive endoscopic interventions also associated with less favorable outcomes when surgery is eventually performed. But I want you to focus on this study and several other studies of similar nature that have been published in the last 10 years. And they show that early surgery is better than delaying surgery in chronic pancreatitis. There is a disease progression that happens, and when you operate early in the course of the disease, you get much better results. And this would put in the theory of step-up approach into question. So I'll come to that aspect also. But early surgery, the pain relief is much better, and exocrine function probably is preserved better with early surgery rather than delaying surgery. And this is not just one study, there are several such studies, and this has also come into the guidelines, which suggest that early surgery is more effective than delaying surgery. When we talk about safety, there is often a feeling amongst all of us that endotherapy is definitely less invasive, it is safer, morbidity is less, mortality is less, but that's not the truth. If you look at the evidence, endotherapy requires multiple sessions. And if you combine the morbidity or mortality of all these sessions and compare it with surgery, the morbidity of endotherapy and mortality of endotherapy is not lower than surgery. And many of the studies have already shown that there can be significant mortality with surgery as well as endotherapy in several studies. So talking about the efficacy, people may say that, with pancreascopy and cholangioscopy, with putting in stents, we can achieve a better success rate. But you can say that, yes, as you go from ERCP alone to SWL to pancreascopy, the stone clearance rate does improve, but the pancreatitis rates also go up. And this is another big problem. So this is data from high volume centers, and endotherapy also is not standardized how to do the endotherapy. Coming to cost effectiveness, surgery is a one-time procedure. Endotherapy is a multiple sessions, ESWL, ERCP, pancreaticoscopy, and lithotripsy. Obviously, it's all going to add on to the cost. And finally, the applicability. Surgery is applicable in wide variety of situations. There are many, many surgeons who can do surgery for chronic pancreatitis, higher technical success rate, better quality of life, and you can avoid long-term failures. Whereas applicability of endotherapy in chronic pancreatitis, Dr. Chandrasekhar asked when I would refer a patient for endotherapy, probably a patient who has a small, early disease in the duct, in the head, with a dominant stricture in the head, with a low volume of stones in the head, either 5-10 millimeters up to that. And if you have a good endotherapist with lithotripsy facility, with an absence of an inflammatory mass, probably this is the patient that I would send to an endotherapist. But this kind of patients probably maybe 10 to 20% in our practice, only 1 or 2 out of 10 patients. Most of the patients have multiple strictures, multiple stones in the entire pancreatic duct, and are most suitable for a one-time early surgery. So this dichotomy or paradox, that why, in spite of all the literature suggesting surgery is better than endotherapy, why does guidelines do not reflect this? And this is an editorial by Dr. Nageshwar Reddy. He says, despite the evidence of superiority of surgery over endotherapy, current guidelines don't make recommendations properly. The German S3 guidelines does suggest surgery as a front line, but the ESG guidelines still suggest endotherapy first and then a step-up approach. But for a step-up approach, it is my earnest request that if somebody is going in for a step-up approach, do not wait too long. If the patient does not benefit from 1, 2, or at the most 3 sessions of endotherapy, possibly the patient should be referred for surgery. So to summarize, surgery is definitely the gold standard today, the first-line treatment based on current evidence with patients who have recurrent pain and a dilated duct. Endotherapy can be done in selective cases who have a small volume disease in the head. And if pain persists after endotherapy, then one should definitely resort to an early surgery based on the current evidence. Thank you very much.
Thank you, Dr. Sanjeev Haribhakti. And Dr. TSC, would you like to have a rebuttal before we take up any other?
No,
questions
the
from the audience?
rebuttal is the one thing I contradict in the morbidity and mortality endotherapy. I think most of the selection bias is whether what kind of endotherapy technique they were using and how proficient in endotherapy. Otherwise, in a center like where endotherapy is so popularly done with the major efficacy, we don't see this kind of morbidity and mortality. Number one. Number two, I'm glad that you are telling that you will refer some cases for endotherapy too. I think I thought the audience will give a clap to that. The reason is he has agreed that means I am the winner now this time. The third one is he says the endotherapy suitable cases only 10 to 20% only. Again, there is a referral bias is there. In my center, we get lot of patients of small pseudosis requiring simple pseudosis, and the stones confined to the head of the pancreas. Probably repeated CMEs like that, they have realized that what I am worth of it, so they start referring cases and single strictures. And the step-up approach would be ideal. I agree with you that you should not refer it very late. But another controversial point is doing surgery or endotherapy, endocrine function improved is again so far not been documented very clearly. So that point I cannot take it as an advantage for you. I mean surgical. But I do agree that early surgery referral should be there. In my opinion, straight A for endoscopy, straight A for surgery, and step-up approach when there is a confusion there, or when there is surgery not possible.
So talking about morbidity, mortality of endotherapy, similarly, the morbidity, mortality of surgery for chronic pancreatitis is very low actually. If you compare, this is a patient who has a burnt out disease. So in comparison to Whipple, the risk of pancreatic leaks are very low, almost negligible when we do a phrase or or a push dose operation. So this kind of, and nowadays we are doing it minimally invasive with laparoscopy and robotics. So the risks of pancreatic surgeries, which were once considered very high, they are not high, especially for chronic pancreatitis. In Whipple's, yes, in pancreatic cancers, still the morbidity is high, mortality is significant, but in push dose or in phrase operation, we don't have a high morbidity or mortality.
So one point that I think excellent debate actually. Surgery probably overscores, but I think as sir has pointed out, one small subset of patients like those who have a splenic vein thrombosis, collaterals around the pancreas, portal hypertension, probably another comorbidity, probably maybe we should consider endoscopic therapy.
That we have already told, no, those surgery unfit for surgery, and they will gladly refer the case. But again, how much work you will be able to do in that case? Suppose simple stone confined to that, okay. So surgery should be reserved for a complex. That is my opinion. So in a individual algorithm, individualized algorithm should be there, and then they would be better for the patient also. Even though everything I agree that surgery, as far as chronic pancreatitis is concerned, surgery is the gold standard. There is no doubt. Like a GI bleed, most of us we manage endoscopically. Hardly we refer to surgeon because they also agree. Either this is what, but we have now progressed very well with the advent of. Only thing you have to be over enthusiastically doing endotherapy, referring the case for surgery later date is not advisable.
We need experts and experts on both the sides. A surgeon doing a good anastomosis and endoscope is aggressive enough to clean the complete duct. You have a question?
Yeah,
Yes.
good afternoon, sir. So I think what we are discussing from the clinical point of view, our endotherapy and surgical options are there. But we have to, very important, it's where we have to keep the patient and patient's relative also into the clinical decision making, because many a times as a surgeon, I'm a gastrosurgeon, hepatobiliary surgeon, so I operate lots of phrase procedure. So what we see is patients coming after 3 or 4 or 5 times endotherapy, and he has been never given a beforehand option of a surgical treatment also. So I think it is before starting any kind of a treatment, even a step-up approach, you have to discuss all these things, parameters with the patients, and then we have to take them in confidence. So when it comes to the surgical part, they don't have any different opinion for the endotherapy people. That's
That
what
is
I
totally agreeable. Same thing you should also do.
Yeah.
There's a simple case, endotherapy also may be useful also.
So
that's why one of the slide I showed combined round and includes the surgeon endoscopy. Then you tell the pros and cons to the patient more. Nowadays patients are also very smart. They put it into the endo. In fact, I did not use Chat GPT or Meta in this my preparation. So I asked my colleague who is a non-medical. So just you find out, I want to give a debate for endotherapy on this one. Almost most of the points, if not they came in the thing. So every patient is going to read it like that now. So we have to be much more smarter than the patient. And because in 1 minute, you will get every detail about it. So I think your point is well taken. We need to have a discussion. So our unit, we have a combined rounds every day, medical surgical cases. Our surgeons accompany, we also accompany. So we select the patient appropriately.
Thank you, sir.
I would say about 20-25% of patients on a long-term follow-up do come back with recurrent pain. And this is well documented in the literature. The success rate of surgery for pain relief at the most 80-85%. And that too in selected good patients who have dilated ducts. We have now started doing surgery even for patients who have borderline dilated duct. like, the definition of a dilated duct used to be 7 mm. Now in guidelines, it has come down to 5 mm. So there is a, up to from 3 to 7, this duct is a duct where, it's not clear whether to operate or not to operate. Dilated ducts, they give good results. We have a predictable result. But the borderline duct, but there are specific procedures for borderline duct, like there is a Hamburg procedure, Isbecki procedure, which can be used for borderline duct disease also. So we can actually drain the entire duct. But the success rates are lower. Success rates for borderline ducts will be 60 to 65%. For small duct, normal duct, we never operate. We never operate in small duct. So for recurrences, we'll evaluate. Most of the time, it would be an inadequate drainage. So we will see MRCP or ERCP and we'll see for the drainage whether there is any part, because, a surgeon, unless he has done from the head to the tail, complete, drainage of the duct is not achieved, then there is a high risk of recurrence. So we'll first look at that. Some patients who have even done a redo LPGA and they have improved, the pain has gone away. So that is also possible. Thank you.
Very valid. I tell you that we had a patient, he had undergone modified pustules. And actually then he came back promptly a year later with the pain. We found in the MRCP, the side branches were also died. So trace should have been done. He did not do that. So everyone is not as efficient or technically expert like Dr. Sanjeev. I think we have to train our the next one is also so much like you. Number one. Number two, other reason for the recurrence of pain is evolving disease. We forget to understand chronic pancreatitis is a progressive disease. Despite the surgeon doing at one point of time best surgery, they come with it. Then we have to reevaluate it's a where other causes for the pain. That is maybe a pseudosis appearing or malignancy or neural inflammation. That is the one main thing. So some of the cases we have to do the to tide over the crisis. We have done the US guided the neural block also, and 6 months they were all right. Then after that, the medical treatment we have to manage it because surgeon said there is no scope for surgery. Those are the cases most difficult to do this. So inadequate surgery. Next is the evolving disease, the reason for the recurrence of pain despite the surgery.
Audio. Thank you.
Actually, the chronic pancreatitis, the risk of pancreatitis is much less when compared. Suppose you ask me, I'm doing a biliary therapy and the pancreas is very fertile and very active. And those are the cases I'm very, very careful about pancreatitis, particularly young women. But in a chronic pancreatitis, the chance, yes.
Worried. You are not worried about ERCP.
I'm worried about pancreatitis, but it doesn't happen that frequently like what you do for biliary. Any pancreatitis, I'm worried, but usually does not happen.
The risk of pancreatitis after ERCP in a chronic pancreatitis setting is very, very less.
Very, very low. So you can, in fact, I used to tell them.
As per literature, it is 4.7%.
And that's the reason why the selection bias also there. See, but Sanjeev is reporting a trial. If you have equally competent endoscopies, means the trial is very valid. I am reporting a trial where I have a competent surgeon means okay, but then there will be problem.
I think with that we'll finish up this debate. Thank you very much for the active participation and
Thank you, sir.
action. Thank you.
We will meet after lunch at 2 o'clock. Faculty lunch will be on the ground floor restaurant. Good afternoon, everyone. Now, for the next session, I would like to invite our chairperson, Dr. Sailesh Patel, Dr. Gaurang Modi, Dr. Jayesh Pavra, Dr. Latif Bhagwan, Dr. Harsh Shah, Dr. Bhavesh Bhoot. I would like to call our speaker, Dr. Ruben Thomas. He will cover the topic on the vascular complications of pancreatitis.
At the onset, I'd like to thank the organizers, Yogesh and his team, for the opportunity, and the chairpersons as well.
Hello. Should I introduce you? Yes. Well-known speaker, Ruben Thomas. Valor. Vascular complication in pancreatitis. After the lunch, it is difficult, but he is a well-known speaker from the Valor. Shall we give the permission? Yes, okay.
I think I jumped the gun. Thank you, sir, for that introduction. Yeah, so I'd like to thank the organizers, Yogesh and his team, for this opportunity and really the wonderful hospitality. We've just dealt with the vascular complications, possibly of a lunch. Now we'll deal with pancreatitis. It's pretty similar, I suppose. So just to say, basically, overall, these are what I'll be kind of trying to cover. Vascular complications range from being fairly uncommon to being present in about quarter of the cases, not that they really need intervention all the time. Venous complications are far more common than arterial. Arterial complications, as you can see, are maybe 1/4 or less. The really thrombosis of the portal and splenic vein are really the most common problems. And portal vein thrombosis, the risks go up as there are local complications. I'll come to each of these. This says chronic pancreatitis, but it's just a visual representation of the same things, basically trying to tell you that the splenic vein, the portal vein, and pseudo aneurysms of the arteries really are what we're kind of going to be talking about. So we must always go back to history. And so what the patient will really present with is a possibly GI bleed or abdominal pain. And really the GI bleed, if it occurs, is a serious complication because it's vast majority of the time an arterial complication, and up to two-thirds of the cases is because of pseudoaneurysms. So really needs intervention quite urgently. Abdominal pain, the fact is you must be aware already that it's a vascular pain. So the symptom far outweighs the physical finding. And so be conscious of that fact when somebody says pain in this situation. So physiologically, it's a very basic slide, but just saying the inflammatory cascade is probably a major player. I'll try to kind of elaborate on that aspect. And as you are all aware, obviously, the pancreas produces digestive enzymes. So the enzymes itself could be a factor that plays a role. And of course, compression from the local complication. So I will focus on the inflammatory cascade because this is something that we have an interest in at the law. So as you're aware, obviously, when there is an injury to the vascular system, the coagulative cascade is put into play, and this will form a clot. The clot may form homeostasis and then stop at that, but sometimes there can be extension and in some effect propagate inflammation. I'll try to show that. So I'm sure all of you are already aware. This was an old triad where we know that endothelial injury, stasis, and hypercoagulability are the critical limbs that could really put the cause the thrombosis in the vessels to kind of happen. So if there's endothelial injury, if there's something that has more endothelial injury, thrombosis is possible. Stasis, obviously, if there's blood doesn't flow, thrombosis is possible. And similarly, anything that propagates hypercoagulability, as you are already aware, like a factor C protein C, protein S deficiency, that itself could play a role. So it's an interplay. It's not a straight up shooting match. So this slide is just, I may say something controversial. You can forgive me. You can argue with me. But so this is a horseshoe crab. So evolutionarily, the horseshoe crab doesn't have innate immunity per se, but it uses clotting to kind of capture any invader, pathogen. And so similarly, since we're all evolutionary beings, it is possible that our clotting system also plays a role. Now, it is to be seen whether definitely all clots are not bad, but obviously when things go out of hand, clots can cause problems. So just to say that this is where we come from. And this slide is, I'm just trying to kind of propagate here that it's a give and take. It's a bidirectional flow. Obviously, there are inflammatory cytokines and inflammatory pathways. When they overact, they lead to thrombosis. And similarly, the other way, when there is thrombosis happening, platelet activation happening, that in itself can propagate inflammation. So just to be aware that this is a cycle that can happen, and sometimes things go out of control. So this is an interesting study. It's a meta-analysis that kind of put together, because splanchnic venous thrombosis in acute pancreatitis and even in chronic pancreatitis, splanchnic vessels are probably the most commonly affected. So this is the timing, not really so important, but just to say that obviously the thrombosis is longer. Early stages, not so much, but it's still seen in the early phases. There are MRI studies that show that there are some phlebitis happening in the splanchnic venous system, even within the first 24 to 48 hours. Does it have a clinical significance? I don't know. Probably not. But as severity increases, the risk of thrombosis goes up. So you're more likely to get vascular complications in a severe case as opposed to a mild. So keep your eyes open from that aspect. And as necrosis goes up, similarly, possibly because of the release of the digestive enzyme, that or the inflammation, its degree of inflammation is higher, which is what I'm propagating, is that maybe that's why you have more vascular complications. So this is, I mean, it's a busy slide. This is some work that we've done in Vellore, where we've kind of shown that the interaction between the von Willebrand factor and ADAMTS13. So von Willebrand factor is produced by the endothelial cells, and it forms a mesh to which the platelets can adhere and form clots, while the ADAMTS13 is a protein that's produced in the liver, and it's basically used to cut this mesh up. So it's a balance. And here we've shown that when this balance is more in favor of the von Willebrand factor and lower ADAMTS13, we could say why, I can't say why as of now, but when there's an imbalance, possibly endothelial dysfunction, is when you have more severe, it kind of has its role and it's able to predict more severe organ failure and pancreatic necrosis. And possibly this may be the role where you will see more vascular complications, but we haven't shown that at all. This is just severe. So this is another study of ours where long-term outcomes of splanchnic venous thrombosis in acute pancreatitis. So by and large, I just brought this up to say, this slide is just to say it's predominantly a localized problem because only about 4% of them had concurrent DVT. So it's not that there is a predisposing condition. And by and large, the most common that we see is retropancreatic splanchnic vein, which I'm sure all of you are seeing in your practices as well, as this is why, or most often why this happens. So if I try to tell you, we screened a lot of patients, our numbers are low, and you'll see globally in the data that the numbers are low. Overall, it's only about 70 patients, and we had complete recanalization in 54%. Only about 20% of these people received therapeutic anticoagulation. And it appears that the anticoagulation per se didn't really influence. There was nothing that influenced the factor. But we did find that the BISAP score said that the more severe the disease, recanalization is less likely to occur. So this is our information. Oh, okay, I'll have to rush through. Fine, no problem. So if we look at the data from the rest of the world, it appears that anticoagulation may increase the risk of bleeding, and it doesn't change mortality. Similar information from another more recent trial that said that anticoagulation doesn't make a difference in about 80 patients, but it predisposes you, if anticoagulation doesn't occur, it predisposes you for varices. So these are long-term consequences that we need to be aware of, that you can get varices, portal biliopathy, and ectopic varices. Pseudoaneurysm, I'll just quickly go through. Pseudoaneurysms, there's a classification. You just want to know whether it's from a minor artery, whether it's from a major artery that can be sacrificed, or it's from an artery that cannot be sacrificed. And really, this is a fantastic review from AIMS that it's a busy slide. So it just tells you that the incidence of the arterial pseudoaneurysms vary from 4 to 12%. And the splenic artery is most commonly involved. Pain and bleed is the most common. CT angiogram used for assessment. So this is what we do for treatment. Predominantly, if endovascular approach is possible, you need to approach it endovascularly. The interventional radiologist here should be your best friend. If not, then of course, you can ask your surgical colleagues or you can try to do it on EUS. But preferentially, these are various methods. It's a slide here. We can discuss this later. So I'll just summarize. So it just kind of, in summary, vascular complications, pain and bleed, venous complications more common than arterial. Anticoagulation in venous combination doesn't appear to be beneficial as of today. Pseudoaneurysms, if found and bleeding, need treatment, splenic artery most commonly, and an endovascular approach is preferable. Thank you from Vellore. Any questions? Happy to take them.
So actually we have questions at the end, but Rubin has a flight. So if there are any questions, you can please ask. Rubin, any suggestion? Now we are doing such pseudoaneurysm therapy with EUS. So any suggestion which pseudoaneurysm you will ask your IR to do it, in which you will do it yourself?
So I think it depends on if you have access to a good IR team, really. So if you, my concern with pseudoaneurysm treatment and endoscopic treatment is the wall is not real. The wall is incomplete. And if we're too aggressive on treating that, rupture is a risk. So bypassing that wall with the help of your interventional radiologist, possibly a safer option. But if your choices are, I don't have a radiologist that can handle it, then using your EUS, you need to use the yin-yang sign to know whether that is the area where you need to access. Then injecting is an option. I know Gaurav has done several, he likes talking about it, so Gaurav can answer more of those questions.
No, I think, Ruben, we can do it safely. Neck of the aneurysm is the one which we should do. Neck is not wide, we are safe enough to go and converse. And we can see real time what's happening.
The neck rule appears, if we are going to treat inside the aneurysm, the neck rule appears regardless of who's doing it, whether it's the radiologist or us. If the neck is wide, then obviously injecting into the aneurysm, we have to bypass, we'll put a stent.
Okay. Thank you.
Thank you for
We'll invite
accommodating me.
Next speaker. Dr. Manoj Sahu. Surendra. Oh, sorry. Dr. Surendra Rana from the Chandigarh PGI will have a approach to a patient with pancreatic head mass. As a surgical oncologist, I am very much interested the physician how they treat the pancreatic head mass. Sir, will allow.
Thank you, chairpersons. Good afternoon, everyone. At the outset, I would like to thank Yogesh team NIG for this opportunity. And I've been asked to speak on a diagnostic approach to a patient with a head mass. Can I have the slides, please?
Hello.
Slides, please. Yeah, sure. So pancreatic mass diagnosis and clinical workup is a diagnostic challenge. In this aspects, patient's clinical history, lab parameters, CT findings, and EUS are cornerstone in diagnosis. And we need to have an appropriate diagnostic strategy so that we should not be doing over or under diagnosis. So when we look at diagnosis, we have to find out whether the lesion is benign or malignant or potentially malignant. And then stage it if it's a malignant, whether it's resectable or unresectable. And then following that, we have to decide on the treatment strategy, which can be upfront surgery or chemo, radiation, or a neoadjuvant. So let's start with first diagnosis. The first step is to find out whether the lesion is solid or mixed solid cystic, or it's a cystic space occupying lesion. CT can more or less tell you, but sometimes there can be surprises, as in this case on a CT, it looks like a cystic lesion, but when you do a EUS, it looks like a solid mass. But by and large, CT will help you in differentiating between cystic and a solid as well. And if it's cystic, Manoj is going to talk about it next talk. So I'm going to talk about solid and a mixed solid cystic lesion. And in this case, pancreatic adenocarcinoma is the most common and the first diagnosis. And then there is wide list of rare diseases which can mimic adenocarcinoma, which can be both benign and malignant. And the benign lesions include SPEN and pancreatic tuberculosis. So how do we approach these patients? Most of the times, patients, when they come to you, they will come with a cross-sectional imaging. So the questions which you need to ask to yourself is, are any blood investigations required? Will that help in diagnosis? Has the imaging been done properly? Do you want to repeat the imaging, or any other imaging is necessary? And then, is tissue diagnosis required? If yes, then which route? The possibilities here are adenocarcinoma versus inflammatory, adenocarcinoma versus autoimmune pancreatitis, and adenocarcinoma versus other malignant as well. So these are the three differentials which you need to consider when you see a patient with a mass lesion. Now coming to blood investigations, CA99 is quite commonly misused, although it has got a sensitivity of 80% and specificity of 90%. But then the limitations are it can be falsely negative, especially in small tumors. It is elevated in benign conditions like autoimmune pancreatitis as well as inflammatory mass. It's even elevated in patients with benign lesions with obstructive jaundice, and therefore it has got a very poor discriminating value between benign and malignant lesions. Again, we quite commonly do IgG4 in patients with pancreatic mass. Again, it is elevated in even in pancreatic cancer. About 20% of patients with pancreatic cancer can have an elevated IgG4, and looking at autoimmune pancreatitis, type 2 AIP have normal IgG4 value. So therefore, again, it has got a very poor discriminating value and should not be done for establishing a diagnosis. And same is the case with chromogranin A and neuron-specific enolase, which is quite commonly misused for diagnosis of neuroendocrine tumors. So contrast-enhanced CT abdomen plays a key role in evaluation of pancreatic solid space of benign lesion. So we have to see the mass, whether it is clearly visible or there are indirect signs like dilated duct. And then we need to carefully look at the enhancement pattern to have a differential diagnosis. So once we look at a CT scan, we have to see whether a proper CT with a proper pancreas protocol has been done or not. What is a pancreas protocol? MDCT, which is a multi-detector CT with 3D reconstruction. The slice thickness should be less than 5 millimeter. It should have 4 phases: unenhanced, early arterial, late arterial, and a portal venous phase. The administration of negative contrast like water is necessary because it produces less artifacts for a 3-dimensional post-processing, which is quite important for local staging. And then whether a chest imaging has been done or not, because almost 5 to 10% of pancreatic adenocarcinomas can have metastasis in lung or mediastinum. So the phases are non-contrast, which is a baseline for looking at enhancement and also detect calcification and stones. Then early arterial is for looking at arterial involvement by the mass. Late arterial is for detection of cancer, which are hypovascular, in contrast to hypervascular tumors, which are neuroendocrine. And finally, the portal venous phase is to pick up the liver metastasis. So all these 4 phases are necessary for evaluation of pancreatic mass. Adenocarcinoma is classically hypovascular, poorly enhancing, but autoimmune pancreatitis, inflammatory mass, and tuberculosis have similar appearances. A neuroendocrine tumor is hypervascular. So if you have a hypervascular tumor, it is either a neuroendocrine tumor or rarely a metastasis from renal cell carcinoma, or a melanoma can also be hypervascular. So a properly done MDCT will localize the mass, differentiate neuroendocrine tumor versus rest, as well as detect metastasis and vascular invasion. Is there any role of MR? MR is useful for detecting small tumors. It can also detect the primary tumors, but that is not an advantage over CT. So the studies have shown that once a CT has shown you a mass, there is no added advantage of doing an MRI in these patients. However, if there is no mass, only indirect signs like dilated duct, then you can do MR because it will help you in detecting small lesions. And then many times patient comes to you with a CT having an enlarged pancreatic head. In those situations, MR can help you in finding out small tumors. What about PET CT? Again, quite misused investigation. It has got a lower spatial resolution, so it has got a poor sensitivity than MDCT for detecting and staging, local staging of the pancreatic tumors. And false positive can happen in a lot of inflammatory diseases, so I'm not going to enumerate that. And false negatives can also occur in necrotic, mucinous, or small tumors, which are less than 1 centimeter in size. So routine use over MDCT is not recommended for PET scan in these patients. So after we have done a proper CT, what next? If a metastasis is obvious, like a metastasis in liver or lung, then one should do an image-guided tissue confirmation followed by chemotherapy. If there is no metastasis, then the choices in front of you are doing an endoscopic ultrasound and tissue diagnosis or upfront surgery. But why EUS? EUS is the most sensitive modality for detection of pancreatic mass. Small mass, which are less than 1 centimeter, can also be picked up on endoscopic ultrasound. And the diagnostic accuracy increases by doing a tissue diagnosis using a fine needle biopsy. There is no risk of needle seedling as the tract is going to be removed while doing Whipples. And it gives you a complement staging information, especially for T and N staging. And EUS and ERCP can be done in the same sitting. And if you find it to be unresectable, a celiac plexus block can also be done in the same setting. So it turns out to be a one-stop shop for diagnosis and management of these patients. But then tissue diagnosis is a debatable topic. The proponents would say that it is necessary because small percentage of patients, especially in country like us, where tuberculosis is a problem, can have a benign diseases. So doing a Whipples in them would be disastrous. It can detect malignant lesions like lymphoma, which do not need surgery but chemotherapy. Biopsy is safe and effective. It improves staging. And then most importantly, it gives a psychological and a tactical benefit to both patient and surgeon if malignancy is confirmed preoperatively. But on the other side, the opponents talk about small but real risk of biopsy-related complications like pancreatitis and bleeding, which could delay treatment. What about negative predictive value? The negative predictive value is about 55%, and many times it does not change the treatment. So if the FNA is negative, then you still will go ahead with surgery. And surgeons believe that doing a diagnostic laparoscopy followed by resection does a better staging than doing an EUS. But our institution, the policy is to do an EUS FNB. If the first time diagnosis is negative, we do a core biopsy or surgery after discussing with patient. So then coming back to this list, so once we have done a proper evaluation, we are usually left with these three differentials if your tissue diagnosis is negative. So in these situations, complementary imaging like elastography and contrast enhanced endoscopic ultrasound can help you differentiating between these three problems. And then what about doing an FNB versus FNBA? FNB has shown to improve the diagnostic accuracy for pancreatic cancer. And now the sensitivity of FNB needles, the newer ones, is more than 90%. So only in 10% in first pass, you don't get a diagnosis. The other differential is autoimmune pancreatitis. So autoimmune pancreatitis, only presence of plasma cell is not sufficient. You have to look for 3 of these 4 findings. And of these 3, only 1 can be assessed on FNA. So therefore, FNB should be done in these patients whenever autoimmune pancreatitis is the differential. So coming to the learning points, CT with the pancreas protocol and EUS, FNA and FNB will helpful in establishing the diagnosis in majority of patients with pancreatic mass. If patient is a good surgical candidate and clinical presentation and imaging are typical for a resectable cancer, you may proceed directly with Whipples without a tissue diagnosis. But biopsy is indicated if there is an unclear diagnosis on imaging, or you need to give a new adjuvant before doing surgery, then you should have a tissue diagnosis. A negative biopsy in a patient who is strongly suspected to have a pancreatic malignancy, one should go ahead with surgical exploration rather than doing repeated FNAs. Thank you so much for your patience.
Yes, very good presentation. If any question, okay, we'll take it. Hello, next speaker I will invite Dr. Manoj Sahu, Senior Consultant Gastroenterologist from Odisha. He will deliver the lecture on pancreatic cystic neoplasm and NET, neuroendocrine tumors. This is very difficult to manage when we have a report of this tumor.
Thank you, respected chairperson, seniors and friends. I'm extremely grateful to Dr. Jagesh for this opportunity. We'll be speaking very briefly on pancreatic cystic neoplasm and neuroendocrine tumor. Now the question is, do all need attention? Pancreatic cystic neoplasms are increasingly identified because of widespread use of different imagings. Certain pancreatic cysts, they represent pre-malignant lesion because they may transform into malignancy. The overall risk of malignancy is not very high, but resection of these lesions before progression to invasive cancer is important because this is a crucial opportunity to reduce the burden of pancreatic cancer. However, the benefit of early resection must be weighed against the risk of overtreatment. If you see the recent data, if we apply different guidelines, the current guidelines also, nearly half of the patients who undergo resection for IPMN might not have required surgery, while malignancy is detected in only 16% of resected mucin cystic neoplasms. So the emerging evidence suggests surveillance strategy might be playing an important role, reducing unnecessary surgery. Now the question is, do all need attention? Yes, all need attention, but all do not need intervention. As you know, pancreatic cystic neoplasms, the common are IPMN, serous mucinocystic neoplasm, and uncommon are the SPEN, as discussed by Sir, and the cystic degeneration of neuroendocrine tumor, etc. Most common is IPMN. IPMN and mucinous cystic neoplasm are two important entities are concerning because due to their potential for malignant transformation. This is a very crowded slide. This is mucinous and non-mucinous cystic lesion. There be different features. This is the representation of serous cystic neoplasm, mucinous and IPMN. If you see the US picture, the left side is the main duct IPMN, then right side is the branch duct IPMN with communication to MPD, and the fish eye sign very pathognomonic of main duct IPMN when you are doing a side viewing endoscopy. Endoscopic ultrasonography is a beautiful modality when you are dealing a case of pancreatic cystic neoplasm because the evaluation has expanded beyond morphological assessment, as discussed by Sir, like contrast enhanced US, elastography, needle-based confocal laser endomicroscopy, and through the needle we can do biopsy of the thickened cyst wall. Cyst fluid biomarkers analysis can be done. Why I'm putting this glucose analysis? Because this can be done at the beds during the procedure. Glucose less than 50 consider a reliable indicator for mucinous cyst. So this can be done, and a few recent studies they found this is a better indicator, better biomarker than CEA. So this is again just aspirating fluid by USFNA. Right side is the contrast enhancement, and there is another picture of taking biopsy from the thickened cyst wall. Advanced diagnostic techniques. We need to integrate molecular diagnostic because of significant enhancement in pancreatic cystic evaluation, KRAS, GRAS, mutation, advanced neoplasia markers, and genomic classification. Why I am showing this slide? Because in near future, this will be integrated in the guideline for evaluation and management of different pancreatic cystic neoplasm. Here, different pancreatic cystic neoplasm and different molecular biomarkers, their specificity, sensitivity, and the data shows that this need to be integrated in the evaluation management of cystic neoplasms. What is the recent management guideline? Serous cystic neoplasm generally benign. They do not have great malignant potential. Conservative management is advised unless symptomatic or causing complications. Surgery reserved for symptomatic cases or when malignancy cannot be ruled out. Mucinous cystic neoplasm is the size-based management criteria as advised by the recent guideline, and cyst size should be 4 centimeter and more. And the complete surgical resection is the standard approach. If you have high-risk features, mural nodule or enhancing wall, cyst size is 4 centimeter and more, symptomatic, need to consider surgery. Otherwise, if the cyst is low risk, before telling low risk, you may consider doing a US to exclude high risk features. And this patient put on surveillance, and there is a recommendation for surveillance. This is a very recent paper what I found. The mucinous cystic neoplasm and simple mucinous cyst. What is simple mucinous cyst? What they describe? A similar cystic lesion, but lacking the ovarian type subepithelial stroma. The ovarian type stroma is very classical of mucinous cystic neoplasm. But these lesions, this cystic lesion, they do not have ovarian type subepithelial stroma. So they are not mucinous cystic neoplasm as per definition. But what they found, the carcinoma arising from these simple mucinous cysts appear to be more aggressive than compared to arising from classical mucinous cystic neoplasm. So this is a new term. We need to see more data. Then come to IPMN. IPMN, what the recent guideline tells us, we need to see high-risk stigmata for IPMN. For primary high-risk stigmata, obstructive jaundice in patients with cystic lesions of the pancreatic head, enhancing mural nodule, 5 millimeter and more, main pancreatic duct dilatation 10 millimeter and more, and suspicious or positive cytology result. If any one of these is there, need to consider surgery. Then second is origin features like new onset or acute exacerbations of diabetes mellitus within 1 year. And cystic growth 2.5 millimeter and more every year. And there are various other origin features. If these are there, we may consider surgery. Surgical intervention, if there's the recent guideline, any high-risk stigmata, if it is there, surgery, multiple origin features in appropriate surgical candidates, single origin features in young fit patient may consider surgery. If there is repeated acute pancreatitis episode, also need to consider surgery. And if it is brand duct IPMN, which do not have great malignant potential, if there is no origin or any high-risk features, and this is the size, and you need to consider surveillance based of size. And there is your recommendation of surveillance discontinuation. When we can discontinue surveillance, if there is a small stable cyst, after 5 years of surveillance, may stop surveillance. So this is again the similar thing. If you are having high risk feature, need to consider surgery. And with origin features, if it is there, may consider surgery, but this area is not very clear, little gray area. If there is a low risk lesion, may continue surveillance. And the surveillance should be dynamic surveillance. And this is the surveillance recommendation at the right side. Solid pseudopapillary neoplasm, surgical resection is recommended regardless of tumor size. And this has a low grade malignant potential. And this is the different comparison of different guidelines, but the recent guidelines what I described now. Endoscopic management also can be considered. We do various US guided ablation technique like ethanol, paclitaxel, combination of both, radiofrequency ablation, etc. When to consider symptomatic benign PCN, malignant PCN surgically ineligible or not willing for surgery, confirmed mucinous type cyst without high risk feature. May consider this thing. We have good data also of response. Future direction depends. We need to incorporate molecular diagnostic now, molecular integration, personalized surveillance. So this second part is pancreatic neuroendocrine tumor. The classification, if you see the WHO classification of well differentiated and poorly differentiated. Well differentiated G1, 2, 3 depends on mitotic rate and Ki-67 index. And we have other classification, functioning, non-functioning. These lesions can present sporadically. These lesions can be associated with various hereditary syndrome, most commonly MEN1 and 10%. And these classifications are important because it determines prognosis and treatment plan. Surgical indications of non-functioning neuroendocrine tumor. Active surveillance is acceptable if it is asymptomatic and the size is 2 centimeter and less and G1, G2 lesion. Surgery recommended tumor size more than 2 centimeter, any G2 lesion and the growth is 0.05 and more. Functioning tumors need to be, surgery need to be considered. Genetic syndrome, we have different result, different protocol for different genetic syndrome, but we need to consider this is a multifocal disease before considering surgery. Functioning net, again, resection is indicated due to hormone-mediated morbidity, follow-up based on imaging and biochemistry. US guided radiofrequency ablation also considered in the option is a small localized insulinoma, especially patients considered unfit for surgery. And we have good evidence also. This is the representation. And we have medical multimodal therapy in advanced disease. This is a very beautiful case. And the very recent publication, the patient presented with non-functional malignant pancreatic neuroendocrine tumor managed with octreotide and everolimus, stable disease for 40 months, subsequently turned out to be a functional insulinoma. So what is required now? Required is very dynamic surveillance. Artificial intelligence is everywhere. We have great data now. It need to be incorporated now. This is the future direction, immunotherapy, combination, biomarker, etc. Every pancreatic cystic lesion and neuroendocrine tumor deserves careful attention at diagnosis. We need to stratify the risk and determine the best management approach. It should be an individualized approach. Not all require intervention, but all require attention. But periodic surveillance is crucial for those with low risk features. Identifying high risk lesions early and referring for specialized management is important. Balancing potential benefits of intervention with patient comorbidity and quality of life is essential, highlighting the importance of multidisciplinary evaluation. The paradigm has shifted from universal intervention to personalized risk stratified management. Thank you.
Thank you. If any question from the audience? Yes.
We heard about the elastography. Can someone throw some light on shear elastography and strain elastography in detecting these lesions, and how much sensitivity they increase, and how they differ in summarize, like shear and strain elastography, please? Thank you so much. I'm Prashant Verma.
Yeah, Dr. Prashant, interesting and a good question. First is difference between strain and shear. So strain elastography has been put into small transducers much long back. So whatever literature or data we have is with strain elastography. Shear has just come on to EUS because it was a challenge to have a shear elastography on a small transducers. The basic idea is using elastography to differentiate between benign and malignant is to look at the hardness. The malignant tumors or the adenocarcinomas are believed to be hard. So they will have higher stiffness, and we look at stiffness by looking at strain ratios and shear as shear values. So if we look at strain, the studies which have looked between benign and malignant, it has been shown that if your strain ratio is more than 10, it usually suggests a malignant lesion. But again, there is a caveat that patients, that's a comparison between pancreatic adenocarcinomas vis-a-vis other tumors. But if you look at pancreatic adenocarcinomas versus inflammatory mass, then the values overlap. So it is not going to, clearly differentiate between the two. But if you add on to contrast, so if you have three things, the grayscale, the elastography, and contrast, on a contrast, the heart lesion, which is hypovascular, no vascularity, is 95 to 100% adenocarcinomas. In contrast, a hard lesion, but with varied vascularity, some of the lesions will take up some contrast, is inflammatory. And then finally, you can have a targeted FNA using these findings. So very hard lesion, which is hypovascular, should be targeted to look for tumor cells. And in case you are looking at inflammatory mass, you target the lesions which are showing increased vascularity, you will get those inflammatory cells. But many times it's very, very difficult and you don't want to miss malignancy. So in these patients, ultimately, the management approach depends upon symptoms. If it is refractory pain, these patients should undergo Whipples because that's the only way you can differentiate 100% whether it's a benign or malignant.
Yeah. Dr. Anand, this is Dr. Kaushal Anand from Ahmedabad. So what you say is when there is a, after FNAB, it's autoimmune versus adenocarcinomas, not conclusive. So you go for the first steroid approach, or you how you proceed for that?
That's again a very important and important question because what's happening is autoimmune pancreatitis is quite overdiagnosed, and many of times we have seen patients being given steroids, and then 4 to 6 weeks the tumor from resectable becomes locally advanced or borderline resectable. So it's a dilemma. You should always be erring on the side of adenocarcinoma rather than diagnose autoimmune pancreatitis because adenocarcinoma is much more common than autoimmune pancreatitis. So especially if you have done a good FNAC or an FNB, then most of the time adenocarcinoma diagnosis would be made. But then again, you have to look at the individual patient. If it's a painless jaundice and your biopsy is negative for malignancy or IgG4 is elevated, because I have another talk on autoimmune pancreatitis where I'm going to discuss about differentiating between the two. But if your patient is having pain with a mass, then it's more or less adenocarcinoma. Autoimmune would be less likely.
Thank you.
Okay. So, sir, I wanted to ask, in the setting of chronic pancreatitis, you have a suspicious mass with obstructive symptoms. Biopsy shows chronic fibrosis with inflammation. Will you do an endotherapy? Will you follow up? Will you send to surgery or will you repeat a biopsy? Distal biliary obstruction, head mass with chronic pancreatitis.
If you have a definite mass with a chronic pancreatitis, then I think this patient probably is having a malignancy or a doubt of malignancy is there. If patient is a good candidate, surgery should be offered upfront. Endotherapy is only for those lesions where there is a ductal stricture or a calculi which can be removed. For a mass, surgery is upfront. If it is unresectable, then you need to have a proper tissue diagnosis before subjecting to chemotherapy.
Hello. We conclude the session. Thank you to all the speakers.
Thank you, sir, for the interesting talk. Now we will move to our next session on the complications symposium. I would like to invite our chairperson, Dr. Varun Bajaj, Dr. Nisar Patel, Dr. Krunal Patel, Dr. Kaushik Shah, and Dr. Mukesh Patel. I would like to call our speaker, Dr. Nikhil Sontalia. He will cover the topic on the management of pancreatic fistula and disconnected pancreatic duct.
So the next session topic is management of pancreatic fistula and disconnected pancreatic duct. The speaker is Dr. Nikhil Santalia, which is a consultant gastroenterologist at Apollo Hospitals, Kolkata.
Thank you, chairpersons. Thank you, Dr. Yogesh and team Noble Hospitals for this opportunity. So I'll try to simplify this complex situation, BPD, yes, and pancreatic fistula. So what is disconnected pancreatic duct syndrome? It's a condition where symptoms arise and complications arise due to complete discontinuity of the main pancreatic duct between segments of viable secreting pancreatic tissue and duodenum, usually seen in a setting of severe acute necrotizing pancreatitis with incidence of ranging between 16 to 50%. So the important thing is you need to have two conditions to develop DPDS. Firstly, necrosis of pancreatic duct, and secondly, preserved and functional pancreatic parenchyma upstream to the necrosed duct. If you get a severe necrotic pancreatitis with necrosis of the duct and necrosis of the upstream pancreas, then that pancreas become atrophies and this patient does not secrete pancreatic juice, hence does not develop DPDS. So for DPDS, disconnection with viability of the upstream pancreas is important because the pancreatic juice that is secreted by viable pancreas results in complications which are pancreatic fistulae, recurrent pancreatic fluid collection. And by definition, pancreatic fistula is a condition where there is abnormal connection between the pancreas and the surrounding structures or the external surface resulting from condition causing disruption of pancreatic duct like surgery, trauma, or pancreatitis. So when the communication is internal, it can like pleural cavity or peritoneum, it causes internal fistula with pancreatic ascites and pleural effusion. When it is external, it causes external pancreatic fistula. So any condition causing leakage of pancreatic fluid due to ductal injury, which has high amylase content, can either form a contained collection called pseudocyst or one, or it can communicate with other organs to create a fistula. So what are the consequences of duct disruption? It can lead to pseudocyst. It can communicate with peritoneal cavity leading to ascites. It can communicate with pleural cavity leading to pleural effusion. It can communicate with the external skin leading to external fistula, or it can communicate with other luminal organs like pancreatoenteric or pancreatocolonic fistula. Why it is important? Ultimately, if fistula occurs and it's a high output fistula, it will lead to sepsis, bleeding, malnourishment, diarrhea, skin excoriations, and it can have a good amount of mortality of around 25 to 28%. So when do you suspect DPDS in a setting of acute necrotizing pancreatitis? When you have a patient with acute necrotizing pancreatitis presented to you with pancreatic fluid collection, you have treated that, but the fluid collection is persistent. Even after treatment, after resolution, once you remove the drains, it is coming back. If you have an external pancreatic fistula, which is continuously giving output more than 3 months, if you develop ascites or effusion after an attack of acute pancreatitis, which is non-resolving, these are the situations when you suspect DPDS. Common etiology is again acute necrotizing pancreatitis, followed by trauma, chronic pancreatitis, post-surgical, pancreatic neoplasm, sometimes when they become necrosed, and sometimes when you drain pseudocyst percutaneously, it can lead to external pancreatic fistula. Surgical causes that causes pancreatic fistula most commonly are distal pancreatectomy followed by Whipple's. Central pancreatectomy, enucleation or partial resection generally does not cause fistula. So diagnostic criteria, clinical suspicion followed by evidence of necrosis of at least 2 centimeter of pancreas. Because if you have less than 2 centimeter of necrosis, it results in stricture rather than complete disruption. Second criteria is presence of viable distal pancreatic tissue upstream from the site of necrosis. And third is documentation of extravasation of contrast from the blowout of the disruption. or total cutoff with non-filling of the viable segment. So all the three criteria needs to be met to diagnose DPDS. And for pancreatic fistula, post-acute necrotizing pancreatitis, if you get a persistent collection, either from external fistula or internal pancreatic pseudocyst or one or ascites or effusion, and that fluid shows very high amylase content in thousands with and contrast study showing pancreatic ductal communication, then you can 100% confirm diagnosis of pancreatic fistula. What are the modalities of confirming the diagnosis? CT scan, MRI, ERCP, EUS. So CT is good only to detect site and number of collection and extra pancreatic complications, but MRI with MRCP is a cornerstone for diagnosing this because it can identify the content of the collection. It can give you an accurate anatomy of the pancreatic duct. Abrupt discontinuation of PD on MRCP at the level of collection with entry of the collection at 90 degrees, highly suggestive of DPDS. Secretin enhanced MRCP has some advantage, but which may not be done routinely because of cost. So once you have an MRCP with MRI, you want to know the site of leakage, you want to know presence of stricture, and you want to know whether it's a partial disruption or complete disruption, or their duct is continuous with only leakage. So what is the role of EUS? So EUS can be done in a setting of pancreatic fluid collection before when we embark on drainage. So when we evaluate a pancreatic fluid collection for drainage, we always try to find out predictors of DPDS. What are those? Presence of well-defined fluid collection in continuity of the main pancreatic duct with presence of viable upstream pancreas. And if you find a feature of PD terminating into the fluid, combination of all these three as 100% correlation with DPDS confirmed on ERCP. However, these are highly specific features, but may not be seen in all cases. And ERCP remains gold standard. In early stages of DPDS, you will find a complete blowout with extravasation of contrast without filling of the upstream pancreas. In delayed stages, you will see total cutoff of the PD, however, without filling of the upstream pancreas and no extravasation. The commonest site is neck of the pancreas, followed by distal body and tail. So if we combine everything, combination of EUS and ERCP is 100% sensitive. MRI with MRCP is 90 to 95% sensitive. Fluid amylase alone has a low specificity. So once you have a clinical condition and you have diagnosed DPDS, how do you manage them? So conservative treatment is not often useful or in symptomatic DPDS. Antibiotics, nutritional therapy, enteral nutrition can be given as a supportive treatment, but alone this does not work. Even somatostatin analog has shown to reduce your fistula output amount, but doesn't lead to healing itself. Percutaneous drainage in a setting of DPDS can be dangerous and it can lead to a persistent external pancreatic fistula. It should be done only in cases as a rescue therapy when patient is too sick for any endotherapy or surgery, or there is no ideal collection that can be drained internally. So endoscopic management, there can be combination of various approaches. So one is EUS guided transmural drainage of the fluid, ERCP guided bridging of the disrupted duct, EUS guided drainage of the disconnected pancreatic duct, EUS guided internalization of the fistula tract, or combination of these three. So technical expertise in all this procedure is needed to manage this situation. Transmural drainage by lamps is a standard approach for well-defined pancreatic fluid collection. However, once you remove lamps in DPDS, chances of recurrence is high. So a practice of indwelling plastic stent after removal of lamps after 4 weeks of resolution is standardly practiced, which leads to almost no recurrence. What about transpapillary drainage? This study shows transpapillary drainage alone works only in cases of partially disrupted duct and when you can bridge a stent across the disruption. Otherwise, transpapillary drainage alone will not work. So what to choose? First step should be transmural drainage of the fluid. If you document DPDS on ERCP, then you consider transpapillary drainage. If it fails, then you have to embark on complex endoscopic intervention or surgery. A hybrid approach initially where you have a high suspicion of DPDS is combination of transmural endoscopic ultrasound guided drainage of one together with percutaneous drainage, which works synergistically by causing internal drainage and using irrigation by percutaneous route as well. So what is our protocol at our center? Acute necrotizing pancreatitis, 4 to 6 weeks. We get a symptomatic one. We do a CT scan and EUS evaluation, try to look for upstream pancreatic parenchyma and the duct features suggestive of DPDS, embark on EUS guided drainage plus minus percutaneous drainage. After 4 to 6 weeks of resolution, MRI with MRCP followed by ERCP. Documented DPDS, remove lamps, attempt at bridging on ERCP. If it fails, replace lamp with plastic indwelling stent. No DPDS, direct removal of lamps. In very special cases, EUS guided pancreatogram is obtained. This is one of our cases. Patient had sepsis with multi-organ failure. Percutaneous drainage was done as a rescue procedure on 4th week. After stabilization was taken up for EUS. We use this percutaneous drain to instill large amount of fluid in the cavity to create a space to drain it because it was predominantly necrotic organized collection. Once we were able to place the lamps after using the percutaneous drain to increase the fluid content, we drained large amount of pus and patient required serial necrosectomy over a period of 7 to 8 days. And at the end of 7 to 8 days with 3 sessions of necrosectomy, we could achieve a healthy granulation tissue at the base and we could then remove the percutaneous drain. This is the healthy granulation tissue and this is the percutaneous drain that you can see at the base of the collection. After 4 weeks, we did an MRI with MRCP which showed very small residual collection with features suggestive of DPDS. So we went in with ERCP. Contrast shows leakage of contrast from the site of disruption through the lamps into the stomach, confirming DPDS. However, we were fortunate enough to bridge this and pass the wire into the tail, and we could put a stent right across the disruption into the tail and remove these lamps. And patient is asymptomatic and doing fine. So this is an example of hybrid approach where both EUS, ERCP, and percutaneous had played some role at some point of time. Another rare scenario is where you're not able to do bridging and you want to internalize, you can use EUS guided drainage of the residual pancreas. So you access the pancreas. So this is an example where ERCP is showing complete obstruction in the neck with extravasation of contrast. There was an EUS guided access of the distal duct was done and EUS guided pancreaticogastrostomy in the residual viable pancreas was done to internalize this. The last slide on pancreatic fistula. So if you get a patient with more than 3 months of fistula output of more than 200 ml with malnourishment, pain, sepsis, you should consider endotherapy. However, you should give adequate time for closure as 70 to 80% close without intervention. EUS guided tracheogastrostomy is a innovative concept where you access the percutaneous drain by puncturing the needle into this under EUS guidance. And then you pass your guide wire and do the fistula tract dilatation using balloon and cystotome. And then you place the plastic stent in the tract itself. So you create a communication between the fistula tract and the stomach. And then after a point of time, you can remove the external drain. So basically internalization of the external pancreatic fistulae can be done EUS guided. The last slide on surgery. So surgery remains cornerstone if you are having a patient not responding to conservative and endoscopic management. Surgical options are internal drainage, where the collections are drained into the lumen, which preserves your pancreas but needs higher repeated reintervention, or resection, where you remove the viable pancreas, which carries more morbidities. So endotherapy versus surgery. Endotherapy has low morbidity, shorter hospital stay, low risk of pancreatic insufficiency. Surgery has high success rate. However, it has its own morbidity and mortality. Do all DPDS need treatment? This important study from AIG showed though 75% incidence of DPDS in acute severe necrotizing pancreatitis, only 13% developed recurrent pancreatic fluid collection, out of which only 6% required reintervention. So a concept of indwelling plastic stent in all versus personalized approach is a food for thought. So take home message, early recognition is important. Not all cases needs intervention. Endoscopic treatment works in symptomatic cases. A team with expertise in EUS, ERCP should handle these cases, and backup of IR and surgery is a must. Thank you.
Thank you. Thank you, Nikhil. Please have your seat. We'll take questions. We'll answer.
Hello. Now our next talk is biliary stricture in chronic pancreatitis. How do I manage? From Dr. Rajesh Puri.
So, Dr. Pawan Rawal, the introduction is there itself.
Sorry?
Dr. Pawan Rawal, he is from Medanta. Introduction of the.
Thank you.
Thank you,
Pawan.
Pawan. Thank you.
Yeah, thank you, Dr. Yogesh, for having me here. Dr. Rajesh couldn't make it because of some medical reasons. So I'll go ahead with the topic of biliary strictures in chronic pancreatitis. So we know there are various causes of biliary strictures, and they can be benign and malignant, but the focus would be, of course, chronic pancreatitis, because that one is assigned to us. The incidence is quite varied. The development of strictures in chronic pancreatitis may vary from 3 to 46% of the cases. This variation is because of the anatomy, which actually says that when CBD comes into the duodenum, it is variably encased by the pancreas, and the intrapancreatic portion also varies from 1.5 to 6%. So that much of difference occurs because of that. Why do they develop? We know because of the recurrent episode of pancreatitis, recurrent inflammation will lead to fibrosis and will lead to development of the lower end of CBD stricture because of the encasement of the fibrosis. So that's the main cause. And if you go by the etiology, the alcohol pancreatitis is dominant worldwide. Otherwise, the idiopathic and tropical also play significant contribution. Pathogenesis, I already discussed the cytokine effect, recurrent episode of pancreatitis, scarring, fibrosis, and encasement of CBD that probably contributes to the strictures. But yes, other than chronic pancreatitis, if there is acute exacerbation, then the edema of the acute pancreatitis may also lead to stricturing. Then the development of complications like the cirrhosis, the walled-up necrosis, and all those things also press the lower end of CBD, leading to the strictures. But we have to be careful that these strictures usually resolve with the time or intervention where we drain the pseudocyst or walled-up necrosis. Presentation can be nothing. I mean, person may be asymptomatic with just a rise in GGT or alkaline phosphatase. But if the stricture progresses, patient will be present with right upper quadrant pain as expected, followed by jaundice, and sometimes the obstruction may lead to the fever because of the cholangitis. So if you just leave this obstruction there and then, it may lead to the development of secondary biliary cirrhosis, and ultimately there can be the symptoms of prolonged cholestasis in the form of pruritus, steatorrhea, and cirrhosis as well. How do we diagnose? We should have a very, very high index of suspicion in all the chronic pancreatitis patients. When they come in follow-up, the liver function test, they should be checked. The rise in GGT or maybe the alkaline phosphatase 2 times the upper limit normal should actually tell us that probably patient may harbor underlying biliary stricture. Imaging usually is the ultrasound. We have to do the ultrasound to see the dilatation of the common bile duct or intrahepatic biliary radicals. Or if you CT is done, same also can be confirmed. CT again helps in detection of the mass also, either in the CBD or in the pancreatic head. MRI and MRCP, they give quite detailed evaluation. You can see MRCP can tell us so many things. It can tell us the length of the stricture. I think it's not length of the stricture. It can tell about the health of the pancreatic duct and many other things which ultrasound will not be able to tell. This is very important to differentiate benign from malignant biliary strictures because chronic pancreatitis may also lead to malignancy. So one should have an index of suspicion for checking for the malignancy. On imaging, if the stricture is longer, it is asymmetrical, eccentric irregularity, and there is an enhancement on the arterial phase, or there is some invasion to the surrounding structure and also lymph nodes. They should raise to the suspicion of malignancy because the management will change in that case. So one should be looking for it. Tumor markers, though, have limited role. As the previous speakers have talked, the low CA99 up to 300 doesn't carry much value, but if it is more than 1000, it strongly suggests malignancy. But the patient should not have cholangitis at that point of time. Tissue sampling is useful. They can be done by either ERCP. ERCP, you can go ahead with the ERCP and breast cytology and intraductal biopsy. Ultrasound, the endoscopic ultrasound can supplement in that. ERCP helps in brushing, though the sensitivity is not very high. The studies have shown that sensitivity of breast cytology with ERCP is around 40%, and the negative predictive value is 58%. So it is not diagnostic for the malignancy. There have been various means where they have tried to improve the sensitivity of breast cytology. We may not go in detail. This makes at least the sensitivity to around 75 to 80%. One may go ahead with the cholangioscopy if needed. Herein, we actually pass a small scope. It's called the single operator cholangioscope. You take through the endoscope, and this scope goes into the common bile duct where you can visualize the various strictures. There are certain parameters which may tell us about malignancy, like a lot of irregular vessels, the irregularity of strictures. They may raise suspicion of the malignancy in the underlying stricture, and the bite or the biopsy also can be taken from here to confirm the diagnosis. Now, whom to drain? That's important. We may not drain all the strictures, but then if there is cholangitis, that's absolute indication of urgent drainage. If there is a persistent biochemical finding in the form of raised GGT and alkyl phosphatase, especially confirmed after 4 to 6 weeks as well, that probably becomes the indication again in the presence of dilated common bile duct or common intrahepatic biliary radicals. We cannot leave these kind of obstruction for long because this may lead to the development of secondary biliary cirrhosis. So they become the indication. And then there can be special situations where there's a progressive rise in the diameter of the stricture. One has to be cautious while draining because if there is acute edema present there, that may lead to a transient narrowing in the common bile duct. So waiting for at least 4 to 6 weeks is a good criteria so that we know that the stricture is fibrotic rather than inflammatory and edematous. Premature drainage should be avoided because the complication rates are high. Unnecessary intervention will lead to unnecessary exposure of the common bile duct, and it may itself lead to cholangitis and other complications. There are ways to drain. It could be endoscopic and surgical. Endoscopic means have been through the plastic stents and now through the self-expanding metal stents, the fully covered ones. The surgical means have been hepatico-enterostomies and the choledocho-enterostomies. Now, when they compare the technical success, endoscopic methods were quite technically good. Initially, they could decrease the bilirubin and GGT in around 90-95% of the cases. Short-term outcomes were better. When they compared with the surgery, the long-term outcomes were not better. Surgery could stand the test of time for longer period, but then of course there was an associated morbidity and mortality with the surgery. So in any case, the first modality of the choice of drainage has been the endoscopic methods. It started with the single plastic stent. Initially, they used to put single plastic stent. Then it went through multiple plastic stents where they insert up to 2 to 4 plastic stents to dilate this. First, they dilate the stricture and they put 2 to 4 plastic stents for remodeling. And then it went through a fully covered metal stent. Historically, when they used single plastic stent, the long-term data was not good. The efficacy on long-term was even less than 30% in some cases. So they resumed to the multiple plastic stents. Multiple plastic stents, they could have a very good long-term resolution rate up to 80 to 90%. And the same was confirmed with the randomized trials as well. Later on, the fully covered SEMS, that's the fully covered self-expanding metal stents were used. They also were showing good efficacy data in randomized trial on long term, around 85 to 95% resolution. And the comparable data, when they saw the comparison between the different modalities, as we discussed, once you compare endoscopic versus surgery, surgery on long term is better as compared to the endoscopy, but there is a definite risk of morbidity. So in the absence of a pancreatic head mass, usually endoscopic methods are preferred. Out of the endoscopic method, the single plastic stent, they couldn't stand the test of time, so they have been almost obviated. Then the multiple plastic stents, once they were compared with the fully covered metal stent, they were having almost comparable efficacy. And in other meta-analysis, the FCMS, that the covered metal stents were non-inferior to the multiple plastic stents. Thereby, we have to choose between either a fully covered metal stent or multiple plastic stent for good efficacy. And the same was actually shown by the Mohan's the article in 2021. If you're not able to drain by endoscopic means, or you're not able to access the papilla because of various reasons, EUS can salvage this. The EUS guided hepatico-gastrostomy and enterostomies can be tried when you need to puncture directly from stomach to the left lobe ducts, and you achieve the drainage. There are various other kind of innovative stents and technology are on the way. Maybe we have a good future in next 4 or 5 years. Smart stents and the drug-eluting stents and the AI-guided imaging, they are under the way. Maybe, the drainage will become much better in next few years. So just to conclude, We have to have a very high index of suspicion where we should doubt about benign biliary strictures or in that malignant if there is a rise in GGT and alkaline phosphatase on follow-up of patient of chronic pancreatitis. The indication should be optimized. Indication of drainage should be optimized. It shouldn't be too early so that you don't drain the edematous part, but then you don't leave it for long so that you don't let to development of secondary biliary cirrhosis. Single plastic stents are almost out of endoscopic treatment. The multiple plastic stents and the fully covered metal stents are the choice. Surgery is usually reserved, especially in cases of pancreatic head mass, which is doubtful. Thank you.
Thank you, Paul. We'll take one or two questions. So, Pawan, in chronic pancreatitis biliary stricture, first time you are diagnosing, do you do an EUS to rule out malignancy? Any mass?
Suppose you have done ultrasound and MRCP and we showed the criteria. You have any doubt of the stricture being malignant, then of course you go ahead with the sampling in any which way. The lower end strictures, the sensitivity of EUS is quite good, so you can go ahead with that.
Do you have any data which suggests like how many times the patient needs multiple stenting, and do you also feel that it delays the ultimate surgery in whether it be an acute pancreatitis and MPD stenting or biliary stenting in case of biliary stricture?
Can you repeat the question?
Yeah.
So if I put it other way around, so suppose you are taking a patient for endotherapy and you are replacing stents every 3 months. Usually the life is 3 to 4 months. It is said that you wait for 3 to 4 times, and after 1 year or maybe 3 or 4 attempts of the endoscopic treatment, definitely go with another method of treatment. You should consider them refractory.
So do you have any data which shows the average number of stents which have been placed before proceeding for surgery by different gastroenterologists?
Number or attempt?
Attempts as well as number.
Yeah, usually 3 to 5 attempts and 2 to 4 number of stents at one time.
So, Nikhil, a question to you. Once you do percutaneous drainage in pancreatic necrosis, you remove necrosum through the percutaneous route. So, you do tracheostomy in all patients or wait for the percutaneous tract to heal on it?
So 3 months standard wait
3
you
months.
have to do, otherwise that will 70% resolution happen. Healing was eternally.
Okay.
3 months.
And so, Dr. Nikhil, sir, I would like to ask you, like, what are your criteria for deciding whether to go for, like, is it only the time or is it like you have some criteria before going for LAMS or a percutaneous therapy or a collection?
So percutaneous therapy you want to do in patients who are terribly sick, not possible for endotherapy, early course of illness where wall is not well formed, where you are not sure about complications that you may land up with US, or collection is away from the lesser sac and it's not amenable for US. So these 3-4 conditions you go for percutaneous.
And if the percutaneous therapy has already been done, the patient is having an external fistula, then do we have any role like blocking the percutaneous drainage, let the pseudocyst form, and then going for LAMS? Or
So in that case, we wait for the collections to resolve and patient is asymptomatic. We go for ERC, MRI, MRCP followed by an ERCP. And if we find a disrupted duct, we try to bridge it. If we fail and the output is persisting, we try to internalize. So internalization is either you drain the cyst or you do tracheogastrostomies. If all those fail, then last option becomes surgery.
And like suppose what we usually encounter is a post-operative pancreatic fistula after a distal pancreatectomy. So is there any role of an ERCP in such cases? Like if you have developed a pancreatic fistula post pancreatectomy, this distal or central pancreatectomy, and the patient has been done a percutaneous drain or maybe the drain has been post-surgical drain is leaking pancreatic fluid.
So you have to internalize the tract. So doing an ERCP may not help because the distal segment is not in continuation with your fistulous tract. So doing internalization of the tract by endotherapy can be attempted. If that fails, then you have to
Only
do
sphincterotomy and will not help.
I told transpapillary drainage does not work if you have a complete disruption and you're not able to bridge the disruption. Just sphincterotomy in this case.
Thank you.
So we conclude the session.
Thank you, sir, for the interesting talk. Now we will cover miscellaneous topics. I would like to request our chairperson, Dr. Anand Patel, Dr. Varun Shukla, Dr. M.M. Ludwani, Dr. Deepti Bai Dave to join the stage. I would like to invite our speaker, Dr. Surinder Rana. He will speak on autoimmune pancreatitis.
So we have a Dr. Surendra Rana. He will speak on the autoimmune pancreatitis. So the stage is.
Thank you. I'm going to briefly talk about diagnosis and management of autoimmune pancreatitis. It's a unique steroid responsive form of chronic pancreatitis. So unlike other chronic pancreatitis, which don't have a definitive management, here they are quite responsive to steroids. They have characteristic histopathology and imaging, but that helps in diagnosis. It is very rarely encountered, closely mimics pancreatic cancer. So 9 out of 10 times or maybe more, it will be pancreatic cancer. It may involve the pancreas diffusely, which we call as a diffuse form of autoimmune pancreatitis, or focally, like a mass, which is called as a focal form of autoimmune pancreatitis. And in the current era where the serum IgG4 is so widely available, we have a problem of incorrect overdiagnosis. So we need to accurately and correctly diagnose autoimmune pancreatitis. Before I go on to the diagnosis, we need to know what are the various types of autoimmune pancreatitis. Before I talk, it's important to remember that to accurately distinguish between the 3 types or 2 types, you need a tissue core. So based on clinical and imaging, you can only suspect. Diagnosis is based on tissue core. Type 1 AIP, also known as lymphoplasmacytic sclerosing pancreatitis, is a part of a group of diseases which we call as an IgG4 related diseases, where pancreas is also involved. And the pancreatic involvement is known as IgG4 related pancreatitis. These patients usually have elevated levels of IgG4, more than 140 milligram per deciliter. And these patients do respond very well to steroids, but have almost 30 to 50% risk of recurrence after steroid therapy. On the other hand, we have type 2 AIP, which is not associated with IgG4 related disease. It's an isolated disease of pancreas. It is also known as idiopathic duct-centric pancreatitis. Here, presentation like an acute pancreatitis is more common. So whenever you have acute pancreatitis and you suspect autoimmune, it is type 2 AIP. And it is commonly associated with IBD, and ulcerative colitis is almost 100% association among the IBD with type 2 AIP. In these patients, IgG4 is usually normal, and they respond very well to steroids with recurrence almost negligible. Then we have a new term which is known as AIP not otherwise specified. So these are suspected patients of AIP which don't meet criteria of either type 1 or type 2. And they do not have markedly elevated IgG4, other organ involvement, or IBDs. That's why we are not able to characterize them. And over a period of time, they will evolve into either type 1 or type 2. Type 3 is mostly asymptomatic or very rarely symptoms like dyspepsia or occasional pain. It is exclusively seen in patients with advanced malignancies. It is iatrogenic, caused by immune checkpoint inhibitors. Typically occurs 4 to 6 months of starting these therapies. And these are not characterized by pathognomical histopathological lesions seen in other autoimmune pancreatitis. And these are seronegative, means they don't have IgG4 elevation. So I'm not going to talk about type 3. We'll talk mostly about type 1 and type 2. Let's go to clinical manifestations. These are commonly seen in elderly males, but now are also seen in females as well as children. Varied clinical presentation, but it usually presents subacutely. An acute presentation is almost unheard of. They are also seen incidentally through radiological findings or unexpectedly in dissected specimens. Most patients with type 1 AIP will present with obstructive jaundice and a mass that mimics pancreatic adenocarcinoma. Less often, patients present with acute pancreatitis, that is seen in type 2. They usually will have interstitial pancreatitis. Necrotizing pancreatitis is not seen, They may have an associated obstructive jaundice or elevated alkaline phosphatase with no stones, and these patients usually have mild pain. Presence of severe narcotic requiring or a chronic pain is not seen in AIP, and presence of anorexia and significant weight loss, again, AIP is very, very unlikely. Then there is a wide gamut of extra pancreatic manifestations which can be seen in type 1 AIP, so I'm not going to go through them, but most commonly it is IBD, which is ulcerative colitis in type 2, and biliary strictures or thyroid disease in type 1 AIP. Coming to lab features, IgG4 is commonly done. It is usually seen as 5 to 6% of total serum IgG in healthy subjects and is usually less than 140. More than or equal to 2 times the upper limit is highly suggestive of AIP. Type 1 has elevated IgG4. Type 2 has normal IgG4. Less than 2 times elevation is also seen in pancreatic cancer, atopic dermatitis, bronchial asthma, parasitic diseases, pemphigus vulgaris, and polio. So these are the other conditions where IgG4 can be elevated. Imaging on a CT scan, a diffuse parenchymal enlargement is characteristic radiological features of AIP, which is usually accompanied by effacement of the lobular contour of pancreas, which gives it a featureless or a sausage-shaped appearance. And almost 1/3 of these patients will have a low attenuating capsule-like rim surrounding the enlarged pancreas. So once you see this, this is almost pathognomic of autoimmune pancreatitis. Other less common features can be a mass-like presentation and a diffuse pancreatic atrophy. And importantly to remember, a normal appearing pancreas on an imaging does not mean that patient cannot have an AIP. So even patients with AIP can have a normal appearing pancreas on CT. Now, what about mass forming? This is the one which is commonly has to be differentiated from pancreatic cancer. The features will help in differentiating between the two is that one, there will be lack of downstream parenchymal atrophy. In contrast, in malignancy, there is a mass. The pancreas upstream is atrophied, whereas in AIP, it will not get atrophied. The duct will not get dilated because it's a diffuse duct-centric disease. The duct will be stenosed in contrast to malignancy, where it will be dilated, and the involved areas will demonstrate decreased enhancement in pancreatic phase with a gradually increased enhancement in delayed phase, whereas in malignancy, it will be hypo-enhancing throughout these phases. And then you carefully look at biliary changes, renal changes, salivary gland involvement, and retroperitoneal fibrosis, which can help in differentiating between the two. This is how on ultrasound it will look like. A sausage-shaped pancreas on a CT. Again, you see there is a rim around the pancreas, hypodense, and then the pancreas is diffusely enlarged. And then EUS has these characteristic features. The bile duct and cystic duct will show these thickenings. So whenever you see these thickenings in these patients with pancreatitis, autoimmune pancreatitis should be your differential. And on a contrast enhanced EUS, there will be this patchy enhancement, unlike a malignancy where there is no enhancement. And then you can also have these extra pancreatic involvement like these renal hypodense lesions, which suggest a possibility of autoimmune pancreatitis. And when you do a PET scan, there will be diffuse uptake in pancreas, suggesting a diffuse inflammatory involvement. Type 2 AIP, again, you can have a focal mass, but the next most common is diffuse pancreatic enlargement like this. The pancreas will be enlarged. The common differentials are diffuse pancreatic lymphoma and acute interstitial pancreatitis. In pancreatitis, you will have peripancreatic inflammation, which will not be there in type 2 AIP. And most of these patients will have associated ulcerative colitis, which can help in differential diagnosis. Now, coming to diagnosis, how to diagnose? Is biopsy mandatory? So what you have to closely look at the imaging. If you have IgG4 elevation and the pancreatic imaging shows a diffuse disease, as I have described, then the biopsy is not needed. But if the evidence is not strong, then you have to do a biopsy. So this will be if you have a typical imaging, then any non-ductal imaging collateral evidence like IgG4 elevation or presence of other organ involvement is sufficient to diagnose type 1 AIP. The differential diagnosis, as I've talked about, is interstitial pancreatitis and lymphoma. And if these are strongly suspected, FDG PET may help in identifying other organ involvement. On the other hand, if you have a mass, then you need two evidences. That means there should be a duct stricture without dilatation. IgG4 should be elevated. And here you need a histological demonstration of other organ involvement. Or if you are looking at radiology, then there should be a proximal biliary disease or retroperitoneal fibrosis. And then if these features are not at all present, there is only a mass, then you need a biopsy to confirm a diagnosis of autoimmune pancreatitis. Type 2 biopsy is mandatory, but then many of these patients have associated IBD. They respond very well to steroids. So you can have a presumptive diagnosis of type 2 AIP in these patients. What about ampullary biopsy? There was one paper to suggest ampullary biopsy, but then it has not shown to be quite effective. So it currently has no role in diagnosis of autoimmune pancreatitis. What about steroid trial? In diffuse form, this can be appropriate, but one should be very, very careful if you are using a steroid trial in a patient with focal lesion. Risk to treat cancer with steroid is very high, and 90% of these patients will actually have a pancreatic malignancy. Now, finally, coming to management, the questions which we need to answer is who should be treated in patients with obstructive jaundice? Do we need a biliary stenting? What is the best induction regime? When to taper? How to taper? Which patients need maintenance treatment? And how to treat relapsing patients? In next 3 to 4 slides, I just briefly run through them. There are no randomized studies. There are various treatment regimes. Symptomatic patients definitely need treatment. Asymptomatic patients will need treatment if there is a persistent pancreatic mass on imaging, or if there is LFT abnormalities, if there is a lacrimal gland involvement, or if there is retroperitoneal fibrosis. So these are the indications for treatment in AIP. Steroids are first line. Weight-based or a fixed high dose, both can be used. Give high dose for 2 to 4 weeks, and then you start tapering gradually over 3 months, and then you have to come to reach to about 2.5 milligram per day over 3 months, and this may be continued for another 2 to 3 months and then stop. Alternatives are azathioprine, which is not indicated in acute phase because it reaches therapeutic efficacy in 2 to 3 months. Rituximab is a good option, and it is preferred over steroids in patients who have a proximal biliary involvement, who are younger age and high alkaline phosphatase. The dose is 1000 milligram on day 1 and 15 or 375 milligram per meter square, which comes to 500 milligram once weekly for 4 doses. Another new drug is inabilizumab, which is again given for 2 doses. There are again a lot of newer regimes which are being evaluated. Combination therapy has shown to decrease the rate of relapse, but again, studies are limited. Finally, a word about maintenance. Type 1 AIP with low disease activity means low IgG4, no other organ involvement. And type 2 AIP, you don't need maintenance. However, maintenance is needed in patients who have very high IgG4, persistent high IgG4 after steroid treatment, diffuse enlargement of pancreas, biliary type involvement, and extensive, that means more than or equal to 2 other organ involvement. In these patients, maintenance therapy should be given. So to sum up, you look at how do you evaluate if there are clinical symptoms and there is other organ involvement, that means salivary gland or retroperitoneal fibrosis. If these are not there, then observation. If these are present, then one should look at control of blood sugars and biliary drainage if the jaundice is high. Then if there is high risk of steroid intolerance or adverse effects, then use rituximab. If no, then steroids are given. Once patient goes into remission, you look whether the radiological response happened in 4 weeks or it took longer time. Normalize IgG4 after treatment, and there was no other organ involvement before treatment. There is no role for maintenance. However, if the pancreas was diffusely enlarged, there was a delayed radiological remission, high IgG4 even after treatment, and 2 or more other organ involvement before treatment, these patients need maintenance. Thank you so much for this.
Any question from Flo?
I think we'll have a question after Surbhi's talk. So please have a seat. Please have a seat.
We'll now invite our next speaker, Dr. Surbhi. She would speak on the pancreatitis in a pediatric group.
So Dr. Surbhi Dogra Jani is a postgraduate from PGI Chandigarh, and she is pediatric gastroenterologist with 3 to 5 years of experience, and she is working with us at Noble Gastro.
Good afternoon, everyone. So topic is pancreatitis in pediatric age group. So quickly running through it. So incidence of acute pancreatitis is increasing. It is around 1 per 10,000 children, and it is gradually approaching that of adults. So increased reference and increased diagnosis could be one of those reasons. So we have our INSPIRE criteria, that is International Study Group of Pancreatitis in Search of Cure in Pediatrics. So which requires 2 of the following criteria, like abdominal pain compatible with acute pancreatitis, sputum amylase or lipase more than 3 times of the upper limit of normal, and imaging findings consistent with acute pancreatitis. For acute recurrent pancreatitis, we need at least 2 discrete episodes of acute pancreatitis as per the INSPIRE criteria in the absence of evidence of irreversible structural changes in the pancreas. And chronic pancreatitis, we require only one criteria, that is irreversible structural changes in the pancreas, such as diffuse or focal destruction, sclerosis, pancreatic duct anomalies and obstruction, with some periods of consistent abdominal pain or lipase or amylase more than 3 times of upper limit of normal, with exocrine pancreatic insufficiency or with endocrine pancreatic insufficiency. So what are the differences which we see in the pediatric and adult pancreatitis? So abdominal pain or irritability are the most common features of acute pancreatitis in children, which is followed by epigastric tenderness, nausea, and vomiting. However, if the child is an infant or the toddler, the clear-cut symptoms are never present. So they may be very subtle, and we need a high degree of suspicion for the diagnosis. Percentage who develop severe pancreatitis is various in different published series, but children usually have been recorded to have a milder course as compared to adults. However, with a severe course in pediatrics, we do not have an established score to predict the outcome. So there is a varying extent of abdominal pain and vomiting. Severity, luckily, it's lower than the adults. So even after first episode of acute pancreatitis, we need not have a second episode in the same child. So there is a great possibility that the child may never have pancreatitis again after the first episode. Like in adults, Apache, BISAP score, those scores does not apply to pediatric patients. We do not have any defined types like interstitial pancreatitis, necrotizing pancreatitis, and the phases like mild, moderate, severe are not clearly seen in pediatric patients. So fluid management also differs. So basically, we first judge the child clinically. If required, then we begin with a bolus of 10 to 12 ml per kg. No, bolus is always given with normal saline. However, maintenance fluid is given 1.5 to 2 times of the normal maintenance. And we prefer dextrose normal saline, and ringer lactate is given as per case-to-case basis. Pain, usually kids don't respond to NSAIDs, and we need to give opioids, and 94% of the children do respond to opioids. Prophylactic antibiotic is not given. However, if there is a clinical deterioration documented, we do start antibiotics. So in the first episode, our first line of investigations are always along with CBC, amylase, lipase, lipid profile, and calcium. Most of the times we get normal triglyceride levels, normal calcium levels as compared to adults. So CT grading Balthazar score is not actually followed in pediatric patients as compared to adults. And we have a lesser incidence of complications and systemic illnesses like ascites, pseudocysts, systemic immune response are very less. Even if ascites is forming, it gradually dissolves by itself. And few pseudocysts require active intervention. Our primary radiological investigation is the USG. CT is only done in cases of clinical deterioration. MRCP is done in cases of recurrent pancreatitis or chronic pancreatitis is suspected, but never as a first-line investigation. EUS is not a primary modality for us for knowing the cause, and ERCP is done only in cases of biliary or pancreatic stones. So we have a short hospital stay of around 4 to 7 days, and cases of incidence of recurrent acute pancreatitis has increased from 15 to 36%. So going on to common causes in children, idiopathic and genetic still rule, it is around 24%, followed by trauma 17%, structural 15%, drugs 10%, infections only 8%, and autoimmune pancreatitis is very rare in us. So less than 5 years, causes mostly are idiopathic, structural, biliary or gallstones, and genetic. And few cases we get less than 5 years. Most of the cases we get in our above 5 years include trauma, structural, genetic, idiopathic, secondary to illness such as HUS, medications, and post-ERCP pancreatitis. So quickly going to the cases, we had a 1-year-old male child with abdominal pain since 3 days, loss of appetite, vomiting, and no weight gain. So what we see in pediatrics especially is the weight and height of the child. That is very important, which is not usually seen in the adult population. So for us, child not gaining weight and height is a big red flag. So this child has not been gaining weight, and past history had 2 similar history of pain over the past 3 months. Symptomatic relief on medication, and USG abdomen showed bulky pancreas and rest of the scan was normal. So outside done, in which we had a stone in the CBD measuring 8 mm and one in the CHD causing upstream bilobar IHDRD. CBD dimension was very big, 6.7 mm. So we admitted, and in view of persistent pain, child was stabilized. These are the investigations of the child. We always did a workup for stone, which is required. The workup was negative, hemolytic workup was negative, lipid profile was normal. So we did an ERCP and stenting. Stone was found. The stone was blackish in color. It was a pigmented stone. However, the hemolytic workup was negative. We plan to send a genetic workup. Sometimes on evaluation, hemolytic workup is negative, but genetic workup does give us a cause. And then the child was kept for 3 months, and we repeated an MRCP for 3 months, in which there was dilatation of the extrahepatic biliary system, possibility of the polydocal cyst, multiple non-restrictive calculi in CBD. Then we went ahead with the HJ, hepatogegenostomy with cholecystectomy, and the child is currently doing fine. Quickly, the second case, 3.5-year-old came with abdominal pain since a week, abdominal distension and fever since 3 days, appetite loss. Vitally stable, he did not have any edema, but abdominal distension, slit umbilicus, and fluid was present. So USG showed a cystic collection from the body ahead, not tail was not visualized. Second cyst was seen in the left pararenal space, gross ascites. He had a history of trauma around 2 months back. So trauma history is sometimes clearly not revealed in children. So this is most commonly known and most commonly missed because they never tell you the clear history. So these are the investigations. We did an MRCP and you can see the 2 cysts which are present. 2 large pseudocysts which are present. So EUS guided drainage was done. Stent was removed after 3 months, and there was a complete resolution of the pseudocyst. So these are just 2 cases, but yeah, as per the age, these cases are very rare. A trauma in a 3.5-year-old and a CBD stone causing chronic acute pancreatitis in a 1 year. Thank you.
Sir, how frequent in your institute is autoimmune pancreatitis? Because in private, it is very rare, but in your institute, sir, with so much case volume, how frequently do you see?
We would see about a case in 2 months, 1 case in 2 months. We recently published a series of about 30 cases, and after that, we have another 10 to 12 cases. So it is still pretty rare. It's not very common.
Type 1 is more common.
Yeah, type 1 is more common. Type 2, it is very difficult to diagnose because you need to do a biopsy. So any patient who has got an IBD, the other differential is gallstone-related pancreatitis. If there is no gallstones, he gives steroid for IBD. This disease also goes into remission. The only clue is elevated alkaline phosphatase and mild thickening of bile duct with no stones. We label it as presumed type 2A.
Sir, on this point, I had a patient of ulcerative colitis on azathioprine, mesacol, developed mild pain, CT scan showing mild interstitial pancreatitis. We withdrew azathioprine, mesacol, he improved, he had a layer of UC, so we started steroid. Now I'm not able to introduce azathioprine whether it's in type 2 AIP or it was azathioprine-induced pancreatitis. We don't know. So what's the risk of pancreatitis in doing diagnostic biopsy in this? Is there any risk of inducing pancreatitis by
First,
needle?
to diagnose type 2 AIP on FNB, the evidence is very sketchy. And it's a duct-centric disease. So even if you get a good sample, you will not get a histological diagnosis. So for histological diagnosis, you have to have a surgical biopsy. Now, IBD, the problem is it can be stone-associated, it can be drug-induced, and very rarely type 2. So first 2 are much more commoner than these. So if you have like elevated alkaline phosphatase, no stones, no vitamin D deficiency, we always do an EUS. On EUS, if you see mild thickening of the biliary system, which is throughout, you will see these mild thickening, which I showed you in images. That would suggest an AIP. So the 2 cases which we have diagnosed so far have these features. But then we didn't have a biopsy. So we all believe that it is presumed. But in your case, I think it will be drug induced. It's much more commoner than AIP.
And the other question, I had a case last month, old age, painless jaundice. We diagnosed as AIP based on biopsy with IgG4 staining positive, with IgG4 levels high, started on steroid, jaundice improved. We put a stent, of course, and 2 months later, it developed blood septicemia.
Stopped steroids, his success has improved. Now, should I reintroduce? Should I consider azathioprine? Should I consider rituximab? What should I?
Usually patients of autoimmune pancreatitis, they respond so well to steroids, the malignancy melts or the lesion melts. So if you have done a follow-up imaging and the mass is gone after 4 weeks, then it is AIP. If the mass is still there, then you have to think for something else.
Even if the IgG4 IHC is positive,
No,
PET, CT, everything is
I
still
deliberately didn't spend time on histological diagnosis because IgG4 staining is one component of the 4 criteria. So you need to have 3 criteria on histology to tell that it's autoimmune pancreatitis. Presence of only IgG4 cells on IHC is not sufficient to diagnose AIP. So I think you will have to look at a composite picture, and most of the times if patient has not responded to steroids, then it is something else.
Whether autoimmune pancreatitis is associated with ANA positivity, anti-nuclear antibody.
No. ANA positivity is not seen in AIP. AIP is actually, we don't know what's the pathophysiology. It is unlike other autoimmune diseases. Autoimmune diseases are more common in females. Pain is a common manifestation. So for peculiar reasons, these two things are not seen in AIP. So these are unlike other autoimmune diseases. So don't go with an impression that autoimmune pancreatitis is just like any other autoimmune disease. So ANA positivity is not usually seen. So ANA will not help. Sometimes autoimmune pancreatitis can be seen with like SLE or other diseases where ANA positivity may be there, but ANA positivity is not a hallmark of AIP.
And for you, pancreas division, is it just a coincidental finding in pediatric cancer, or you actually label them as pancreas division?
So that depends, sir. Mostly, if they develop symptoms, then yes. Otherwise, if it is an accidental finding, we do nothing.
Yeah, so a patient with pancreatitis with a division on imaging.
Yes.
No other etiology found.
Then we take it as a first.
You dictate it as
We
first,
take it
then you actually do endotherapy on follow-up once the edema resolves.
We do.
You do put in a stent to remind that.
Good talk, no? How commonly we see mumps in this pancreatitis in children?
The incidence of mumps itself has reduced, sir, over the years. So mumps-induced pancreatitis is very rare.
Excellent presentation, Dr. Sukhdev. And kindly remain seated.
So thank you, everyone. With this last session, I extend my wholehearted thanks to all delegates and faculty who stayed with us for last 2 days, and all of my staff, Payal, Nihali, Himali, Sharon, the host, Dimple, and especially my marketing people, they worked extensively hard, Deepak Bhai, Jagat, Sagar, Rivam, everyone, and to the pharma industry who supported us. Thank you so much. So before we end our session, we have a prize for those who have attended the highest art. So the first prize goes to Dr. D.P. Khatri. So this is a small token of appreciation. So please come on stage. And I would request Professor Dr. Surinder Rana from PGI to hand over a check. Should I tell how much amount? A check of 10,000 rupees. The second prize goes to Dr. Mohit Khanchandani. So Mohit, I thought you will get first prize, but second हो गया तुम्हारा. आ जाओ. The third prize goes to Dr. Roopchand Ramani. Roopchand, please. With this, I thank once again, and we promise from entire Noble Gastro team that every year will contribute in teaching and more academics to our doctor colleagues. Thank you. Thank you so much.
No, Arif. So GERD is a very severe disease that we should all do. Yeah. ಅಲ್ಲ ಆ ಚೂಡ ಅಪಾಯ ತಮಿಳು ಚೇನ ಅಪ್ಪು ಅವೇ ನವಿರಿತ ಅಪ್ಪು including stage.
Hal. Hal.